All right. Good afternoon, ladies and gentlemen. I welcome all of you. This is the Hall 2. Welcome all of you to the International Summit on Women's Health and Rights. Those who have logged in Hall 2, welcome. And in next 30 seconds, we'll be able to start with our first presentation being given by Dr. Rajendra Sangpal, as he is already here with us online. So, ladies and gentlemen, just stay with us for 30 more seconds and we'll be ready to go with our first presentation. Thank you.
Tech team, I think we're waiting for Nandita also to join in. Hello. Sure. Yeah, tech team, I think we're waiting for Dr. Nandita to join in as well.
Yes, so ladies and gentlemen, we have Dr. Nandita Palshetkar. She's going to chair the session, and we also have Dr. Hema Diwakar. And we have Dr. Suvarna Khadilkar also. Ma'am, please join us on the dais. All right, so our dignitaries, our chairpersons, may I request you to please invite the first speaker for the talk. Thank you.
Hi, good afternoon. Hema, would you like to do the honors? Yeah, since you're there online. Can you just...
I'll introduce the last speaker.
Okay, all right. So I'd like to introduce Dr. Rajendra Sangpal. He is our president of the Mumbai OB-GYN Society. And I think as he was introduced as the human scalpel, a lot of work in gynec endoscopy, and has worked very hard. And today he will be talking in the first lecture. Dr. Sangpal, over to you.
Thank you. Is my screen visible? And am I audible?
Rajendra?
Yeah.
Yes, Rajendra. But only thing is this has to go on full screen, Rajendra.
Yeah, Hema, I cannot read from so far.
Yeah.
Now my screen is...
Yes, yes, perfect. Yeah.
Thank you. So, as I said, he's also been the president of the IAGE in 2015 to 2017 and an honorary member of the European Society of Gynecological Endoscopy, ISGE. And of course, he is very, very popular in India. And over to you, Rajendra. You can share your talk on laparoscopic myomectomy.
Thank you so much. Is my screen visible?
You're audible and the slides can be seen.
Okay, thank you. Thank you once again. You know, fibroids, they affect the fertility status of a woman. They contribute immensely to the problem of infertility, and most of the fibroids are seen commonly in reproductive age group, and that's the fertility age group of the patient. Fibroids do affect the pregnancy rates in ART, especially those which are intramural and submucous fibroids. Submucous fibroids and intramural fibroids of a size more than 3 centimeters, which impact the implantation, affect the pregnancy rates in ART, as well as they increase the rate of miscarriages in those patients. They also affect the implantation rates. If you see here, the intramural fibroids and submucous fibroids are notorious for this, but the subserosal and other fibroids usually do not affect the pregnancy unless they are very, very larger fibroids. why do myomectomy we should do in the fertile patients? And that everybody knows that fibroids are the reversible cause of infertility, and the removal of the fibroids cause implantation rates to improve. They reduce the miscarriage rates almost from 60% to 24% and improves the live pregnancy rates almost up to the range of 60%. So myomectomy is one of the commonest surgery that we do for all those patients who are infertile, and having ruled out the other causes of infertility and presence of submucous fibroid or intramural fibroids of more than 3 centimeters. 2 centimeter fibroids, unless they impinge into the cavity of the uterus, they usually do not affect the implantation or they do not cause miscarriage. Laparoscopic myomectomy is one operation in gynecology which has got 3 different steps. And one is enucleation of fibroid, the suturing of the defect, and the retrieval of the fibroid by morcellation. Now, all these 3 steps they are going to take their own time, operative time, irrespective of the surgeon's skills. Like depending upon the number of fibroids, the size of the fibroid, the location and depth of the fibroid. Important thing is to assess the patient correctly so that the reward of the surgery depends upon the selection of the patient. If the selection of patient for laparoscopic myomectomy is not good, then probably the outcome will not be good as far as the laparoscopic myomectomy is concerned. There is a new entity which we call AMH in after the fibroid surgery. There is enormous literature which is there which says that AMH levels reduce maybe temporarily after removal of the fibroids or after myomectomy, whether it is laparoscopic or laparotomy. So one needs to focus on AMH levels when you are asking the patient to undergo laparoscopic myomectomy or open myomectomy. How big is too big? There is no consensus for that, but 2023 American College of Obstetrics and Gynecology, they have given some classification called fibroids which are less than 5 centimeter are called smaller fibroids. Fibroids between 5 and 10 centimeter are larger fibroids, and fibroids which are more than 10 centimeter are called giant fibroids. This is for our practical purpose. If the number of fibroids are bit less than 3, it is called straightforward laparoscopic myomectomy. Between 3 and 5, you require really a judgment and your skills. But more than 10 fibroids will be crucial. It increases the operative time and complications of the laparoscopic surgery, such as hypothermia, pulmonary embolism, so on and so forth. Those are the complications. So you need to be very specific when you do a laparoscopic myomectomy. Select the patient for laparoscopic myomectomy. Now, these are all important factors which tell you that whether you should choose the patient for laparoscopic myomectomy, whether your patient is going to get benefit by laparoscopic myomectomy. Ultimately, what you think technically feasible may not be correct ethically. Sometimes you may choose a patient which is a larger fibroid beyond your capacity. You may spend hours on this patient, and post-operatively patient may not have a correct benefits of laparoscopic myomectomy. Why do we do laparoscopic myomectomy? To get shorter hospital stay, less bleeding, less pain, and smaller incisions on the abdomen or keyhole incisions, and early return to their work. That's what the laparoscopic myomectomy would give. But if you choose a wrong, the patient which is having a larger fibroid or multiple surgeries before, these benefits may not be available for that particular patient who has undergone laparoscopic myomectomy. So initial assessment includes the past surgical history, the height of uterus and morphology. All that is important for this patient, and the morphology of the patient. If the patient is very short, probably the space which has been there, which you get to operate, will be small, and if the fibroid is larger, you will have technical difficulty and you will spend a lot of time operating these patients. Consultation and counseling is important. Surgery and facility consideration, that means the system where you are operating. It is not only you as a primary operating surgeon, it is your assistant, the operation theater equipment, the operation theater layout, and anesthesiologist. All those are important, and subordinate staff, such as who are going to take care post-operatively, they form the ecosystem of laparoscopic surgery. The system has to be geared to take care of the bigger surgeries or advanced surgeries. Final decision depends upon if you feel in your hands if the laparoscopic myomectomy is going to benefit the laparotomy, then you must go ahead the laparoscopic surgery for fibroids. So what is technically possible may not always be ethically appropriate. So sometimes sonography can be elusive. When you have, as I said, number of fibroids more than 10, you have to be cautious. Now these patients are supposed to be for laparotomy. Now we use three incisions on the abdomen, 3 ports, 10 millimeters supraumbilical and 2 right lateral ports. These are our common ports. Right side port entry gives an exact picture as that of the laparotomy, and it's more surgeon friendly practice, and I do practice putting ports from the right side of the abdomen. Now we are being blessed to have vasopressin, and vasopressin is available as vasopin or vasopressin or pitressin. 1:200 ml dilution. We do inject into the subserosal aspect of the fibroid or into the capsule, pseudo capsule of the fibroid. Now, injection vasopressin really gives a temporary hemostasis to these patients, and which lasts for almost half an hour to 40 minutes. And that's the enough time to enucleate moderate sized fibroids or a larger fibroid and do laparoscopic suturing. So we are in India, we have opportunity to use vasopressin, but while injecting vasopressin, you need to aspirate and alert the anesthesiologist that you are injecting vasopressin. Sometimes inadvertent injection into a vessel can lead to sudden vasoconstriction, followed by increase in blood pressure, followed by tachycardia, then bradycardia, and reduction in preload, and patient can have heart failure. So these are rare incidences but can occur in these patients. So it is important that you use pitressin with caution and always alert the anesthesiologist. How do we take incisions? There has been much talked about incision. What we realized and learned during our residency program is single incision and vertical incision. Remove all fibroids from one incision, but that is not true in laparoscopic myomectomy. If you see the uterine architecture or the blood supply to the uterus, uterine artery ascends vertically up from the isthmic region, and it goes up and sends peripheral branches which are called arcuate arteries, and these arcuate arteries at each level will send centripetally the spiral arterioles. If you take vertical incision, the blood loss will be more. If you take a transverse incision, blood loss will be minimized. And this was well published in AAGL journal in 2000, I think. And that the transverse incision or elliptical transverse incision will reduce or minimize the blood loss at the time of myomectomy. So this was a patient where, laparoscopic myomectomy, our incision is usually elliptical. We modified into a circular incision. And this is the serosa or the myometrium over the fibroid is usually actually is a hypertrophied myometrium with hyperplasia. Even if you take a circular incision, this is a stretched myometrium. You do not lose on the actual myometrial strength after the myomectomy. But once you take a circular incision with the scissors and avoid as far as the electrosurgery in these patients, once you take a circular incision, your fibroid is almost 60% out. You have to need to give a traction with the myoma screw and a counter traction on the cervix with an valsalum, and just keep giving an onion skin incisions on the fibroid capsule. The fibroid comes out very easily without endangering the uterine cavity. Most of the time, with this technique, you can save the uterine cavity or opening the endometrial cavity. Now, how do you suture? Now, suturing, as I said, it requires a lot. Many times I emphasize it's not that difficult, but suturing is one of the most crucial part of laparoscopic myomectomy, and it requires dedication and practice, and it's not that difficult. We do use polyglactin material and continuous or interrupted sutures. Now, it is not important how many layers you have taken into the myometrium, but it is important how have you co-opted both the edges without having sinus formation. There should not be any sinus formation in between this at the scar area or in the myometrial layers. That's important. So whether you do single layer or whether you multiple layer, doesn't matter. Multiple layer does not mean that your suturing is perfect or the scar would be good. It is important to avoid the sinus formation and having clots within or a blood collection within the area of the sutured area is important to, which will give you a good scar if there are no intrauterine or intramyometrial blood collection. So avoid electrocoagulation. Various papers have been published that electrosurgery was used to remove the myoma and obtain hemostasis in most of the cases where there were uterine ruptures. So avoid electrocoagulation. It may induce necrosis of the myometrium, result in poor vascularization. So that's very important. And so laparoscopic suturing, whether it is done in, it has got many concerns, whether it is single layer or multiple layer, whether strength of the scar during the labor process or rupture of the uterus in pregnancy and labor, and all those things are associated, and there are many concerns with laparoscopic suturing. We do use, as I said, polyglactin suturing, suture material such as Vicryl, Centicryl or Safil, whatever you name it, but it's polyglactin delayed absorbable sutures which stays on the uterus for almost 6 to 8 weeks. So the single layer or multiple layer suturing depends upon the size of the fibroid, the location of the fibroid, and the technique of the dissection, the depth of this uterine defect, and integrity of the myometrium as such. So this was a large fibroid with adenomyotic changes. What we do is we take a midline or in the center a figure of 8 stitch, which brings both the edges very close to each other, and subsequently we introduce or put stitches on the either side of the midline, and that's the complete suturing without having sinus formation. Idea is not to have sinuses within the myometrium, and that will help in maintaining the integrity of the scar post-operatively. Multi-layer suturing, I do use multi-layer suturing, especially when the myometrial debate having a lot of redundant portion of the myometrium, and the myometrial defect is very deep with a lot of redundant portion. And if the endometrial cavity is open, then we use multiple layer suturing. So larger defects, yes.
Just if you can hear us, sir, we are not able to see your presentation.
Oh, you are not able to see?
Yeah, we just lost your presentation. If you could reshare it. Also, just a gentle reminder, 3 minutes, sir. And you're looking very wonderful, like your tie too. Yes, now we can see it, sir. If you could just put it in the presentation mode.
I'm so sorry.
No problem, sir. Thank you so much. Yeah. Yes, sir. The video is also seen.
Now you can see?
Yes, sir. The video is also seen. We can see the video too.
So whether we should do a single layer in suturing or multiple layer suturing depends upon the size, location of the myometrium. I mean the location of the myoma, the technique of dissection, and the incision type, and the depth of the uterine defect. Now, I usually prefer to do, if there is a shallow defect, we use single layer interrupted sutures. What I do is, first I take a in the center figure of 8 suture that brings both the edges together. and have a better cooptation. And this figure of 8 suture, as everybody is aware, it's a strong suture to keep the two edges together firmly. Then we put the other stitches on the either side of the midline, and that's the complete suturing, where there is minimal or no intrauterine or intramyometrial sinus formation. Post-operative first 24 hours as the period where the blood supply to the uterus is more, and their probability of having sinus formations are more. So it's important to have a good cooptation of the two edges of the myometrium, whether you do a single layer or a multiple layer suturing. So usually we do multi-layer suturing where the redundant portion of the myometrium is too much. Then we do, or the endometrial cavity is being opened. In those cases, we do multiple layer suturing. You can use continuous suturing depending upon your own practice, or you can do interrupted multiple layer suturing for these patients. So correct reapproximation does not mean number of layers. It is important to avoid hematoma formation that reduces the chances of the weakening of the scar. And there was a beautiful paper which I saw, and even Dr. PG Paul has published this paper where they had done single layer suturing in myomectomy, and the rupture of the scar was hardly 0%. So single layer does not mean it's a weak suturing. You must have a good cooptation of both the edges of the myometrium. Barb sutures have really reduced difficulty in knot tying, maintaining adequate tension, and prolonged time and hand fatigue. I am very skeptical about barb sutures because those barbs can lead to having intestinal obstruction. Sometimes immediately after the post-operative period, when the hemostasis occurs, and later on, the oozing starts within the myometrium. These barb sutures may not withstand or cause dynamic closure of the myometrium, can leave little bit of intrauterine sinus formations. So I'm not very comfortable with barb sutures, but I use polyglactin sutures. Adhesion prevention barrier is not mandatory, and morcellators are been in. Am I audible? Morcellators are in a problem right now since 2014 because of the spread of the dissemination of the uterine fragments, benign or malignant, in peritoneal cavity, which necessitates the further intervention which has happened. So morcellators were really boon for laparoscopic myomectomy, but nowadays morcellators, you have to use it with caution and inform the patient that patient can have a possibly, especially elderly patients, possibility of the spread of leiomyosarcoma. And sometimes the benign lesions, the small fragments of the fibroid can go and deposit into the peritoneal cavity and can lead to what is called wandering fibroid. And in such cases, we started finding out since 2006 or 2007, because in between 1998 to 2005, we started using myomectomies and morcellators left and right, and we then started seeing all these patients with the wandering fibroids getting blood supply from the omentum, and they are so vascular. So you must use the morcellators with caution. And some of the patients, they have this entity called peritoneal leiomatosis, which you cannot avoid. Some patients do have these kind of pathologies, and fibroids are everywhere in the abdomen, including near the kidney, their hilum. So power morcellators have been discouraged by FDA, and they always tell that you inform the patients and take their consent and use an alternative method of removal of the fibroid, such as bag morcellation. But the American Association of Gynecological Laparoscopics, they said we should improve but not abandon the power morcellation. With appropriate informed consent, it should remain available for appropriately screened low-risk women. So we use bag morcellation, and bag morcellations are beneficial and can give a benefit to this patient. Ultimately, we put in a plastic bag within the abdomen and morcellate the fibroid within the bag to reduce the dissemination of the benign fragments or patients with perimenopausal patients where you suspect malignancy. So bag morcellation is nowadays being done. So in short, the patients, you have to be, hemoglobin has to be 10 gram percent when you do a laparoscopic myomectomy. Avoid laparoscopy for multiple large fibroids. So now everybody has their own idea of doing laparoscopic myomectomy, but fibroids which are more than 10 centimeter, one has to be cautious. Fibroids which are 10 in number, one has to be cautious. That increases the morbidity and does not give benefit to these patients. And multiple fibroids ultimately can be done safely with laparotomy. So post-operatively, avoid pregnancy for 3 to 4 months. And all these patients, the pregnancy outcome is really good and encouraging. When you remove fibroids, the pregnancy rates are 50% and more in 1.5 years, and reduction in spontaneous abortions from 60% to 24%. But you must tell the patient that once they become pregnant, they should be screened for placenta accreta and percreta as far as possible. Thank you very much for patient hearing.
Thank you so much, Rajendra. That was a wonderful lecture, and all the videos were also superb. So thanks a lot. And we'll go to the next talk by Dr. Sujata Dalvi. She will be talking on your concepts in managing breast health. Dr. Sujata Dalvi is currently editor-in-chief of Journal of OBGYN India, and she is also office bearer of Mumbai Obstetric Gynaec Society, and she has been, she is now immediate past president of Mumbai Menopause Society. Now over to Dr. Sujata.
I'm Dr. Sujata Dalvi, Editor-in-Chief of Journal of Obstetrics and Gynaec of India and Joint Secretary of Mumbai Obstetric and Gynaec Society. I will be speaking on newer concepts in managing breast health. Breast health concern is the most clinical breast changes which occurs, and most of them are benign, and only 3 to 6% are because of a breast cancer. However, the moment any patient has some breast problem, there's lots of anxiety with regards to development of breast cancer. Benign breast disease is still a neglected entity, and despite the fact that it constitutes a majority of breast disorders, if you actually go to see on this diagram. Mastalgia or mastodynia is a pain which is related to mammary gland. It occurs in about 60 to 70% of women at some degree at some stage in their life. In about 10 to 20% it is quite severe. It may be either cyclical mastalgia, which related to menstrual cycle, or non-cyclical, not related to menstrual cycle. The most common cause of breast pain could be a cyclical pain, which could be because of hormonal stimulation of normal breast glands. It could be non-cyclical because of stretching of Cooper's ligament, fat necrosis, focal mastitis, periductal mastitis, cyst, or it can be non-breast pain like chest wall pain because of some localized lateral chest wall pathology, diffuse lateral chest wall pathology, or radicular pain from cervical arthritis, or occasionally it can be because of gallbladder problem or maybe because of ischemic heart disease. Cyclical mastalgia, the treatment is reassurance, which is a very important part so far as mastalgia is concerned, because what patient needs is lots of reassurance, then only the anxiety gets relieved. Lifestyle changes, definitely. Low fat diet with active lifestyle and use of well-fitting bra, which will relieve them of the symptoms. Painkillers like NSAIDs, which will also relieve them of the symptoms. And in case the breast pain is severe and it does not get relief because of an NSAIDs, then we have other modalities of treatment like tamoxifen. However, it causes irregular menstruation and hot flashes. Danazol, which can cause weight gain, deepening of voice, menorrhagia, and muscle cramp. Bromocriptine also have a severe side effects like having nausea, vomiting, dizziness. And goserelin, which causes vaginal dryness, hot flashes, and decreased libido and irritability. So if you go to see the treatment options available for those who do not get relief with the normal NSAIDs, come with lots of side effects. Now we come to a palpable breast mass or a lump in the breast, which can be diagnosed as only in about 10% of a new breast lumps, and it is essential to have a proper approach for navigating this breast lump because there are some limitations so far as investigations are concerned, and preventing misdiagnosis is very important to rule out malignant breast lesions. Now, evaluation of a breast mass, it goes with history and palpation. Palpation forms a very important modality of detecting a breast lump, as well as breast imaging also forms a very important modality which goes from a sonography to maybe a mammography, and in case of any suspicion maybe a biopsy, so as to rule out benign from the malignant. ACR guidelines for evaluating palpable breast mass could be, if it is less than 30 years, then imaging modality, generally a sonography, what we call it as a sonomammography. Between 30 and 39 years is sonomammography, and in case you find subabnormal diagnosis, then maybe a regular mammography, and more than 40 years is digital mammography or digital breast tomosynthesis. Fibroadenoma or fibrocystic breast disease, these are the common benign tumors which are found. Fibroadenoma almost in about 30% of the patients, and fibrocystic disease is almost about 11 to 30% of the patients. Fibroadenoma, also known as a mouse in the breast, it's a painless unilateral benign breast tumor. It's the most common lump which is found across all ages. 95% of the breast lump in adolescent are fibroadenoma, and about 10% of world's female population suffers from fibroadenoma once in a lifetime. The peak onset is anywhere between 15 to 35 years of age. The treatment of fibroadenoma includes a careful observation and follow. Basically, one can do a core needle biopsy or a fine needle biopsy to rule out in what malignancy, and also one can also carry out a cryoablation. So far as adult population is concerned, surgical excision is needed only if the mass is symptomatic or if it is rapidly growing. Otherwise, such patients with a fibroadenoma can be kept under observation. Fibrocystic disease, breast disease, also known as a fibroadenosis, it's extremely common. It occurs about 90% of the women during their life, and it is not associated with an increased risk of malignancy. However, it is associated with 50% of risk of developing breast cancer under certain histopathological or clinical circumstances, otherwise no. So these patients need to be kept under vigilance. The treatment of fibrocystic breast disease could be, if there is a pain, analgesics. If the pain persists, then evening primrose oil is also can be prescribed for about 3 to 6 months period. In case the breast pain is quite severe and does not get relief by this, then maybe tamoxifen, bromoergocriptine or danazol can be given. They do have 88% success rate. However, on discontinuation of therapy, the recurrence starts along with the adverse side effects. And in case patient does not get relief with the medical therapy, surgical therapy is the only option given to the patient with the fibrocystic breast disease. Diagnosis and management of benign breast conditions, tamoxifen and danazol are quite effective for severe refractory case of mastalgia. So any patients who do not get relief of a breast pain, the tamoxifen and danazol can be given, which does have a relief, but it also comes with its major side effect, and that is one of the reasons one has to be little careful while using tamoxifen or danazol. The other common breast problem, one can also give goserelin, which also comes with some of the side effects, and that is the reason people are looking out for some other modes of modalities of treating this fibrocystic breast disease, and therefore newer advances in the management of the breast health, whereby which we have nutraceuticals, which forms a very safe and effective management option so far as breast health is concerned. Evening primrose oil is an extract from the plant which is omega fatty acid, and women with the breast pain do have a low concentration of GLA and metabolites. And evening primrose oil is a rich source of linoleic and gamma linolenic acid, and it has a good efficacy and safety profile, with very mild side effects. So if you go to see evening primrose oil, it restores the saturated and unsaturated fatty acid balance. It thereby decreases the sensitivity of breast tissue to circulating hormones. It also increases the level of PGE1, which has an anti-inflammatory action, and it decreases the sensitivity of breast to prolactin, and it also decreases the conversion of arachidonic acid to pro-inflammatory leukotrienes. So there are certain textbooks which also go in favor of usage of evening primrose oil so far as fibrocystic breast disease is concerned. There is a clinical evidence whereby which they've had two groups in which one has used a pre-evening primrose oil and the other one has used a placebo, and the dosage of evening primrose oil is around 300 milligrams per day so far as breast pain control is concerned, and they've got better results with women who have had evening primrose oil as compared to placebo, and hence evening primrose oil has a better effect. The other study which shows evening primrose oil on mastalgia, and this also shows they've used evening primrose oil and they found significant reduction so far as pain is concerned, and evening primrose oil is without any significant side effects, so it is found to be quite useful in patients with mastalgia also. Vitamin E in mastalgia and fibrocystic disease. Vitamin E acts as an antioxidant, thereby which it prevents conversion of estradiol to estrone. It also reduces production of prostaglandin, and it alters the levels of adrenal androgens, thereby having anti-inflammatory response, thereby reducing the pain. So effective evening primrose oil with vitamin E in a combination, and if you go to see, they found better results in a patients who have taken evening primrose oil and vitamin E so far as cyclical mastalgia is concerned. So combination also is found to be quite useful. There's another study which shows evening primrose oil and vitamin E as a first line of therapy so far as breast pain is concerned or fibrocystic disease of breast is concerned, and they found good results in the same. So if you actually go to see for fibroadenoma and for breast cyst also, evening primrose oil in the dosage of almost about 4 grams per day for about 6 months, about 52% of the patients have got relief of pain. Similarly, this is 500 milligrams, 6 capsules, so that's almost about 3000 grams per day, and this has been taken for almost about a year, and they found that the evening primrose oil, they found lower incidence of recurrent of cyst in the breast as well as evening primrose oil was found to be well tolerated. Vitamin E in fibroadenoma. So far as fibroadenoma is concerned, there is lipid peroxidation observed in circulation of fibroadenoma. When a vitamin E is administered, it has significantly reduced the concentration of lipid peroxidase, and they found that with vitamin E, not only the breast pain is decreased, but also the nodularity of the breast has also improved, or the nodularity of the breast has decreased. So vitamin E has also been found to be quite useful. It reduces the post of those, there are so few patients who have undergone a surgery for fibroadenoma, but still the pain persisted, and post-operative when vitamin E was given, they were found to have a better relief of pain with the usage of vitamin E. Vitamin B6 in mastalgia, what we call it as an pyridoxine, it's also found to be quite useful because it causes increase in the production of serotonin and dopamine and the synthesis of prostaglandin, an essential fatty acid, which helps in reducing the pain. And the study has found out that vitamin B6 is effective in reducing the breast pain along with the other supplements. It can be given, plus it is also cost effective. It is easily available and the side effects are much less so far as vitamin B6 is concerned. So if you have a combination of vitamin E and vitamin B6, that is 200 IU of vitamin E and 40 milligrams of vitamin B6, when it was given for 2 months, a cycle before the menstrual cycle, before starting the treatment, and 2 menstrual cycles after the intervention, and there is lots of change so far as pain relief is concerned, and they found equal decrease in the pain relief so far as vitamin E and vitamin B6 are concerned, and that is the reason they found both molecules are quite useful in decreasing the cyclic mastalgia. So newer advances so far as breast health is concerned, we have artificial intelligence so far as breast health is concerned, and artificial intelligence has shown a great potential in revolutionizing detecting, diagnosis, and treatment of breast cancer. And it also leads to an earlier breast cancer detection, more accurate diagnosis, and personalized treatment tailored to each and every individual separately, and that is the reason AI is found to be useful so far as breast health is concerned. Another new advance so far as management of breast health is concerned is a minimal invasive surgery. We have something known as a vacuum assisted percutaneous excisional biopsy, which has been introduced in US and UK, whereby which it removes, not only it removes the suspicious lump, but also it gives you a biopsy, so what we call it as an excision biopsy, and this is just with the help of a vacuum. The common up complication could be an hemorrhage, hematoma, occasional pain, and sometimes recurrence of the benign lesion, but this is found to be very useful. It has got positive efficacy and safety profile, as well as a good cosmetic outcome. It's quite cost effective and technical ease of the procedure. So image guided vacuum assisted breast biopsy has gained a wide popularity and support, and it may become a new standard of care so far as benign breast tumor is concerned. Then we have percutaneous thermoablation. This study is still going on in the United States, and it's currently under investigation. Hence, after the total clinical research trial, when the results come out, one will be able to follow this sort of a percutaneous thermoablation wherever when there is a suspicious of a breast lump, whether it is benign or malignant, the same procedure could be useful so far as removal of this breast lump is concerned. Thank you so much for a patient hearing.
Thank you, Sujata. That was really wonderful talk. And Dr. Hema Divakar, will you please introduce the next speaker?
Yeah, thank you, Nandita. On behalf of Dr. Nandita Palshetkar, who is the FOGSI representative to FIGO and also a very key and an important member of the FIGO Committee on Women's Health and Technology. When we have her around here, and someone like me who is totally hooked on to the newer advances in femtech or technology for women's health, we have none other than the born leader, Dr. Rishikesh Pai, speaking to us now on the use of artificial intelligence for reproductive health care. Needless to say that we need as clinicians to unlock the potential of technology to do better than the best for every girl, every woman. And here we have a fertility specialist in the form of Dr. H.D. Pai, who is leading all the way as the trustee of the Oceania region of FIGO and has brought this wonderful conference and putting us all together through the technology platform of this great webinar for the next 48 hours. So we welcome Dr. Rishikesh Pai to deliberate on artificial intelligence in reproductive medicine. Over to Dr. Pai, please.
Hello, everybody. So before I start, I would like to invite you for the Cape Town conference of FIGO, which is there on from the 5th to the 9th of October this year. And I have also had the privilege of being one of the plenary speakers at this conference on the 9th. And I'll be talking on what's new in ART. In artificial intelligence, first you must understand what is human intelligence. Human intelligence is general intelligence, which is cognitive learning and problem solving, and biological intelligence, which is consciousness and emotions. Most of the machines don't have the biological intelligence, and at some point in the future, maybe the machines will develop the biological intelligence. Historically, the word artificial intelligence was coined by John McCarthy and Marvin Minsky in 1956 in Dartmouth. And if you look at artificial intelligence, there are multiple applications. And one of the applications is machine learning, which is the study of computer algorithms that improve automatically through experience. Machine learning is of two types, supervised learning and unsupervised learning. And it is the unsupervised learning which has some things like hierarchical clustering, which is used to discover structure within data, such as the existence of classes. And this is mainly used in developing artificial intelligence. The machine learning has various techniques, and one of the 5 techniques of machine learning is artificial neural networks, including the recently developed deep neural networks. And these are the networks which are essentially used by medical people like us in our field. The artificial neural networks are made up of neurons that mimic human brain. A neural network typically consists of several layers of artificial neurons fully connected to each other by edges, each one associated with a weight. Each neuron receives signals from multiple neurons in the previous layer, integrates those signals, and fires if the integrated signals are above a specific threshold. If there's an increased density of these layers of neurons, it is known as deep or convoluted neural network. And this can be accessed by programs such as TensorFlow and PyTorch from Facebook. The heart of the artificial intelligence is the NVIDIA chip. And this has become so popular that the NVIDIA is the first company in the world to cross the market cap of $4.3 trillion, which is a huge market cap. If you look at the applications of artificial intelligence, we have the artificial intelligence for cervical and ovarian cancer. You can use artificial intelligence in obstetrics, in infertility, and also in precision medicine. If you look at infertility centers, administratively, you can use it for now electron medical records. You can use it for minimizing patient stress and increasing clinical efficiencies. You can do uniform work distribution, resulting in better work efficiency in the clinic and lab. You can do stock taking and inventory. You can also use AI for expiry and replenishment of medicines and renewal of licenses. You can do quality control. You can do key performance indices and quality assurance in the lab. You can do data analysis and conducting cost-effective research using AI instead of costly, long drawn-out clinical trials and systematic reviews. You can also use, so in AI, we need to have a data input, and this input comes from images, videos of uterus and adnexa, done by ultrasounds, MRI, CT scans, colposcopy. You can have images, videos, heat maps of sperms, oocytes, embryos, cervical cells. There are also a lot of stored images such as ImageNet, which has now got nearly 14 million images free to the net. And also other variables such as hormone levels, tumor markers, temperature, blood biochemistry, and big data. All these are input into the machine where machine learning is taking place, and using the CNN networks, machines can do and operate artificial intelligence. AI can also be used in reproductive medicine in the integration with ultrasound. So AI can identify uterine anomalies, pathologies, assess endometrial defects. It can have potential application in infertility workup and in the evaluation of the endometrium and contours of the uterus. You can have automatic assessment of antral follicle count, follicle tracking, and gonadotropin dose calculation using AI. You can also use AI to automate endometrial receptive analysis. And recently, in one of the conferences which I had been to, there's a AI from one of the countries where you can actually feed the data and you can tell the patient what are their chances, the couple chances of conceiving. So using AI, you can also do prediction of conception. You can use AI in the male as well to reliably predict male factor infertility. It can predict the likelihood of sperm extraction in azoospermic patients. It can develop smartphone-based applications for semen analysis as well as sperm viability and DNA integrity, and also evaluate sperm morphology and DNA integrity as well for sperm selection. You can use AI for automatic semen testing and analysis, which is now easily done by AI. You can see that you can just take this sperm and automatically put it in the machine, and the machine automatically calculates the motility, morphology, all that within a few seconds and gives you the report. And this has really become very handy. These machines were very costly once upon a time, but now these are very easily available and they are quite effective and cost effective. You can see, you can just put the syringe and automatically the machine does the testing and gives you the report. The other thing that we are using AI for now is when there is a azoospermia and we do the testicular biopsy, it is very difficult to locate the sperms in the debris of the testicular cells. Now with the AI, you can actually identify where there is a sperm sitting in the debris, and you can easily pick it up and eliminate a lot of time which could have been normally wasted in trying to search for these sperms. The other option is that while doing ICSI now, you can connect the micro manipulator to a server, and this AI using the speed and motility of the sperms can identify the best sperms which you can select and use for ICSI. So AI can be used for now selection of the sperm so that you get a very good outcome. It can give grading of the sperms to the A grade, B grade, C grade, and you can actually pick it. It's called SID, and it has been developed by Badiola, who is one of the leading persons in the field of AI in reproductive medicine. You can use also the robotic ICSI has now come, which is the automatic ICSI machine, and the first babies were conceived using the automated ICSI in 2023, and all the steps are picking up the sperm and penetrating the zona and ulema, and this is used normally using a piezo ICSI process, and all the steps can be done even by non-embryologists. So was a major breakthrough, and some kind of AI has been used in this. And the latest breakthrough has come where a digitally controlled, remotely operated ICSI system was used to achieve pregnancy totally by artificial intelligence. And this has been published recently in RBM Online. The doctors were sitting in a remote place, and through telemedicine, they operated this machine, which is fully automated and could give rise to a pregnancy, and the first baby was delivered recently. AI can also be used in for ovulation prediction, which this can be used for time intercourse, intrauterine inseminations, natural cycle frozen embryo transfers. By just collecting the estrogen, progesterone, LH level on day 8 and feeding it in the AI machine, you can predict the exact date when you can do the embryo transfer of the frozen embryos and get the best results. You can also use AI for oocyte imaging. So prior to freezing the oocytes, we can dissect the oocytes and we can click the oocytes and export the images to a server, and the server tells you whether the quality of oocytes is good enough or you need more oocytes to be frozen. So if there are 8 oocytes, but if they are not great quality, you can do one more cycle and freeze extra oocytes so that later on, when the patient wants to have a child, she can use her frozen oocytes and have this. So you can see this machine which is there, and we have got it in our lab since 3-4 years, and we can use this machine and use the AI in this machine on the server to actually analyze and assess the oocyte quality and predict the pregnancy in the future. This is how the machine takes the photograph and gives you a probability of what is the chance of the patient having a good chance of pregnancy in the future down the line. You can also use AI for identification of the best embryos. So if there are many embryos for transfer, nowadays we transfer only one embryo to reduce the incidence of multiple pregnancy, because multiple pregnancy can cause side effects. So there are various methods for identifying the embryo. You can do PGTA, pre-implantation genetic testing, where you take an embryo biopsy and analyze it with next gen sequencing. But you can use now artificial intelligence to analyze the embryos. You can also do other things like static imaging. You can actually take a photograph of the blastocyst and export it to the server, and the server, by using AI, can tell you what is the best blastocyst for transfer to get the best chance of pregnancy. So you can see here, this is the ERICA system where you can take the photograph and then you can actually use the photograph and assess the pregnancy chance and transfer the best pregnancy. There is also what is known as time-lapse video. So we have embryoscope in our lab. So every 15 minutes, you can take a video of the embryos as they are growing in the incubator, and then using IDS score. So these videos are then exported to a server abroad, and this can be used to assess the score and then actually select the best embryo for transfer. So the machine grades the embryos, gives them a grading, and then you can identify the best blastocyst for transfer to give the pregnancy chance. You can also use artificial intelligence to do prediction of miscarriages, which is coming in the near future. And one thing you must know is what is known as OpenAI, that is ChatGPT. I use it commonly in my practice. I have it on my mobile phone, and it is called Generative Pre-trained Transformer. So GPT is an acronym for Generative Pre-trained Transformer. It's a chat bot, and it can do almost all things that, like a language, conversation, emails, blogs, text, office work, research, programming, translation, continuous client support. And I use it a lot for information, but sometimes the information can be false, and you must use your discretion so that you get the best information out of this system. Artificial intelligence has a lot of disadvantages because there are multiple platforms. There's a lack of standardization. Data bias can be there. There's a small number of data sets and limited ethnic diversity is there. So different ethnicities have different responses to artificial intelligence. And this can be solved by overcoming or pulling multiple data sets from multiple centers. Replicating across cohorts and prospective validation of a study is a must. Small size of data and hurdles in sharing data between centers and countries can be overcome by blockchain systems. And also borderline cases can be best managed by collaboration between machine and the humans. So, of course, there is a danger in AI. AI will spell the end of humans, said the great scientist Stephen Hawking. Once humans develop artificial intelligence, AI will take off on its own and redesign itself at an ever increasing rate. Humans who are limited by slow biological evolution will be unable to compete and would be superseded by the machines. And this was a fear. But technology keeps on evolving. You can't stop the evolution of technology. For example, once upon a time, there were cars, then trains, planes, space shuttle, time travel. Similarly, in our line, we had vaginal delivery, forceps delivery, cesarean section. Then we had delivery with CTG. And maybe at one point in time, we'll have delivery in the machine outside the body. Even in surgery, we had initially vaginal surgery, laparotomy, laparoscopy. Then it evolved into robotic surgery. And maybe we'll have now voice controlled robotic surgery in the future. So you can't stop evolution, but you can definitely regulate technology. And that's why the Global AI Governance, the first World Leaders Congress, was in November of 2023 in United Kingdom, where UK, USA, China, India, and 67 other many countries came together along with companies like OpenAI, DeepMind, Microsoft, and they launched a coordinated global effort to manage the risks of AI, especially from frontier AIs like ChatGPT, Gemini, etc. And there was the Bletchley Declaration on AI Safety signed by 28 plus countries. And the focus areas were catastrophic risk, model evolution, safety research, and responsible innovation. And the first step towards an international framework for AI regulation and governance was made during this conference. And there is a follow-up conferences were in Seoul in 2024 and Paris in 2025. So in conclusion, over the last 3 to 5 years, we have witnessed the increasing utility and exciting applications of artificial intelligence in OBGYN, especially in obstetrics, cancer, and reproductive medicine. Artificial intelligence will usher in a new era of standardization, automatization, and precision, leading to personalized medicine. Artificial intelligence driven approaches are likely to be more objective, more rapid, and most importantly, more accurate. Wider use of AI in precisely assessing the patient characteristics such as ovarian reserve, age, endocrine status, and clinical diagnostic tests will undoubtedly increase the efficacy and efficiency of diagnosis and treatments of all reproductive disorders. The future will be creating super intelligence by merging collective human intelligence with artificial intelligence, helping in this picture you can see Mr. Begin, who is a paraplegic. He had a chip in his brain and the electrodes on his forearm, and by using thought he could actually move his forearm, and all this is not possible because of a lot of AI. So the future of mankind is in the integration of the atom, that is the actual inside of the molecule, which is very important, the gene, that is a DNA, the byte, that is a computer, the artificial intelligence, and ultimately the space. And I would like to conclude by again inviting you for the FIGO World Congress. As the trustee of FIGO for the Asian region, I would like to invite you for the FIGO World Congress of Gynecology and Obstetrics from the 5th to the 9th of October 2025 at Cape Town. And I'm looking forward to meeting you all and interacting with you. Again, I would like to thank the Bangladesh Society, which is our sister society, and we are very lot of fond relations with our sister country Bangladesh, and I'm bringing you greetings from India and wish you all the very best for a very successful conference. Thank you very much.
Thank you, Dr. Pai. Though it seems that artificial intelligence is a thing of future, I think all of you, after having listened to Dr. Rishikesh Pai, will strongly believe that the future is here and now. And with so much of intellectual properties floating all across the globe, most of which belong to Indians, which we can proudly say, we are quite sure that though it's a developing or a low middle income countries, as it's typically called, we will leapfrog and showcase the intelligent modules through technology in our own space. If the audience has any questions to ask, maybe they will post it in the Q&A box and we will take it up at an appropriate time. But now I see that the organizers are ready to make an announcement of the next session. So on everyone's behalf, on the organizing team, we welcome you to sit back and soak in the future scientific deliberations. Thank you.
Thank you, Dr. Hima. As Dr. Hima said, if you have any kind of questions, you can definitely put it in the Q&A box or the chat box, and we will try to address it as many as we can. Up next for the next keynote lectures, I would like to again invite our chairpersons, Dr. Hima Diwakar. We have Dr. Kritika Karkhanis, and we have Dr. Jitika Thakkar. Over to our chairpersons, and I request our chairperson to please invite the next speaker. Thank you.
Yeah, so let me have a look at my beloved co-chairpersons for this session, Kritika and
Jitika.
Yeah. So the next speaker is none other than Dr. Anu Chawla. A brief introduction from my end. Afterwards, the youth leaders can take over the session, if I may say, because Anu is a very strong asset to our FIGO committee on reproductive age, dealing with all the issues in that age under the big umbrella of Well Women Healthcare. So the division of Well Women Healthcare has the adolescent, reproductive, menopausal, breast health, and the technology. And so Anu is one of the key members of the committee, and she's particularly assigned with the talk of endometriosis because she's doing a lot of work at the FIGO community as well on bringing out newer guidelines for endometriosis, collaborating with the who is who on the global arena of endometriosis, trying to bring in some infographics and podcasts as well, because the key to it is prevention, early detection. That is a mandate for the Well Women Committee and the division, because we have to make every girl, every woman ready for the next phase of her life. Delayed diagnosis, when we have already missed the bus, is quite clearly not the mindset of the team members of the Well Women Healthcare Committee. They're ahead of time in all the aspects that they do. So whilst we welcome Anu to make her presentation on the issue of novel therapies for endometriosis, I may ask my co-chairpersons to make a comment or two before we play Dr. Anu's deliberation. I think Anu Chawla is also here. She is one of my very beloved favorite members within any circle, any part of the world she is, we are always connected. So welcome, Anu, and I'll just like the co-chairs to just speak a word or two about either you or the topic, and then we will get on with your presentation. Thank you.
Hi, Anu ma'am.
Hello,
Hope
hello,
you're doing
hi.
very
Thank
fine.
you, Dr. Diwakar. She's been my mentor all these years. So thank you, everybody. Yeah.
Yeah.
So let's start. Hi, Anu ma'am. How are you?
Very good, very good. Let's start.
Let's go ahead with your talk on endometriosis, unlocked novel therapeutics into tomorrow's care pathways. Dr. Anu ma'am.
Hello, everybody, and thank you for taking time to be a part of this wonderful platform today, which is the International Summit on Women's Health and Rights. It is a wonderful platform created with the collaboration of Mumbai Gynaecological Society, FOGSI, and supported by FIGO. And I thank all the organizations, office bearers of all the organizations, and to Dr. Rishikesh Pai to have invited me, and for the very kind opportunity to be a part of very elite faculty here. So I have no disclosures. And the topic itself is very interesting, close to my heart. I think you're all going to look at this, to witness this presentation after Dr. Pai's artificial intelligence based talk. And I think that makes it perfectly placed because I'm also going to talk about novel therapeutics and particularly about what is the new work happening in endometriosis. And obviously, I'm going to talk about the newer modalities, and genomics and AI make a big part of that. So I will be sharing the exact tools specific to endometriosis that are being created, used worldwide. And I'll use this platform to share those, so you can use those open source platforms to collate your data and be a part of this global movement. So, very important part of the presentation is that I cannot help but start my first sentence to put all the focus on one point, which is the central problem of the whole. The elephant in the room is that there's a big diagnostic delay. Even in UK, there's an 8-year diagnostic delay still in this day and age. After the patient says and tell the symptoms, we actually take 8 years before we actually label the diagnosis. And this is appalling. And this is the reason mainly why this is happening is because we are just pleased to call it enigmatic, and we are not getting any further on the understanding. It is only in the last 2 decades that 70%, at least 60 to 70% of all published data on endometriosis have been ever published. So to keep it simple, how interesting it is to realize that most of the evidence-based learning that has come to us has only come to us in the last 2 decades. And many of the papers are still not very powerful though, because the outcome parameters are not set in a way that we wish. For example, when we look at the studies submitted for a topic of a combination of endometriosis and artificial reproductive technologies, meaning when fertility treatments are offered to these patients. So for example, if we look at the paper submissions, most of the papers submitted do not have live birth rate as the one of the outcome parameters. So if we do a powerful study, then only we can get to the bottom of the problem. So for example, if we have correct methodology and the correct outcome parameters, then we would not have to call this disease enigmatic when the next generation is grown up. So in the editorial of the RBM Online written by one of my colleagues, he has very appropriately addressed that there is a clinical experience and there's an evidence-based medicine. So we say that this is context-based medicine. Okay, so basically we know evidence base is important, but what if we don't have enough evidence yet? Not enough good quality data yet. Even some of the classifications itself have not been very helpful till now, to be honest, and forget about creating good understanding after collecting data based on them. So it is very important that experience is never underestimated. The context is basically something which is the combination of the number of experience, I call it the number of mistakes, and plus the evidence-based medicine. So for example, my very earnest colleague Erton Zeridogan and along with very bright Joe Kirsten, they have devised this classification. I would request you all, whenever you get a chance, to go through this classification. It's called NZN classification of endometriosis. They have simplified it. They have standardized it better, I think, and they have created exact codes so that we can pass on the information and reproduce exactly what we are saying, which site, location, which type of lesion, the extent, all of that is graded in a much more reproducible, standardized way to be able to gather the data in more useful way. And in this classification, I want to highlight that I think the DIE has been highlighted like never before because that was kind of not classified very well. in the previous classification. So that bit has been looked after very well. And overall, I would say it is more simpler and reproducible. Now, to use this classification, they have created a fantastic open source database. Now, anybody can download. This is not a girl. This is an open source database called Glenda. So Glenda stands for Gynecological Laparoscopy Endometriosis Dataset. This is freely available. There's no cost. You can easily download this and start collating your data on this. It's a global open source platform. So you use the NCN classification, and then you upload the data in Glenda. And that is how, in the next few years, hopefully, we should not call endometriosis an enigmatic disease. Briefly talking about particularly how AI has evolved, it started with the rule-based algorithms, and then it became like a medical image analysis and computer-aided diagnostics, and then like image analysis and predictive modeling. And then current applications still are majorly not in gynecology, but in radiology, dermatology, oncology, and gastroenterology. And the limitations that we still have to look into are the ethical, regulatory, and technical. And the early milestones of how this is going to play a big role is already emerging. How you will see the surgeries happen in near future is exactly like this. So when you'll be focusing the camera while doing a laparoscopy, the AI generated after collation of all the data on a platform like Glenda, they have actually identified 68 exact lesions, and the machine learning has helped the platform learn and analyze the data. So as soon as you focus the camera properly on the various locations in the pelvis, the AI will automatically identify the type of lesion so that we don't give different names to the same lesion. So one lesion is identified with one name throughout the world, and it is diagnosed with a particular set of characteristics, which the AI will automatically hint. Obviously, we have to check how accurate is it, but what I understand is it is pretty accurate so far. And it will tell you the lesions, and then it will help you map the pelvis accordingly, and hence make the decisions accordingly later on. See, when we see about the future in reproductive medicine, I'm just touching this point because it is really important to highlight how the novel therapeutics will work. Despite public assumptions about general AI, including REI, currently it only uses a narrow spectrum of AI. Looking ahead, the generative AI-powered systems will enable advanced human-like interactions with patients. That is the game-changing part, facilitating continuous and high-fidelity data acquisition. This persistent and context-aware engagement will enhance the precision of the predictive modeling, allowing for more accurate forecasts of patient trajectories and the potential clinical outcomes. Now, the avenues where we can see the outcomes can be enhanced are diagnostic, the data analysis, minimal bias in the studies, enhanced quality control of the practices, accessibility to the care, mainly a country like India, very applicable, ongoing knowledge integration and learning, and scalable solutions for the widespread practice, and then cross-referencing in terms of when we hold the multidisciplinary team meetings through cross departments. Now, when we talk about transforming fertility treatments in specifically endometriosis patients, we can see that we start by seeing that there are difficult decisions because they are poor responders. We have many questions we have to deal with. It detects the early subtle signs of DIE. It identifies the lesions, and sometimes even those which are missed by the conventional imaging, and improves the early detection, first of all. And for this, the platforms currently very actively being used. Glenda, I've already spoken. I will speak about very interesting European Union research-funded treatment called Female Project in my coming slides, and predictive modeling. is the next part of this, which is for personalized planning. Like for a particular case, the age, AMH, the stage of the disease progression, surgical history, ovarian reserve. Now, these will help us address the important questions during the consultations, which is, should IVF be started early in this case? Is repeat surgery beneficial in this case? Or can we expect the spontaneous conception in this case? So reproductive planning optimization is by the pattern recognition. So it pinpoints the ovarian endometriomas and subtle fertility threatening changes and supports the timely fertility preservation related decision making, which is egg freezing for these patients or not, or early IVF for these patients or not. Just imagine, without this background of clarity and explanation, if we offer, it can be medico-legally challenged. But when we have a substantive, objective ground to apply this, then we can say, okay, there is a reasonable background based on which the patient is being offered egg freezing or early IVF. Similarly, these patients also would need AI in the embryo selection. There are platforms like FOGSI. Violet is being very widely used in UK. I know Bloom IVF is already happily using that. And enhancing the endometrial receptivity assessments. I wouldn't want to speak too much on that. AI-based decision support tools. So the next step in the guidance, which is whether this patient should try naturally now, whether this patient should do IUI or IVF, or should we do a repeat laparoscopy. So all this trial and error which we otherwise do, and all the emotional, financial burden which otherwise comes, is more justified when we make decisions for the patients, and the platforms that are going to really help us a lot, and we may get very addicted to the kind of evidence and help and objective data that they will give us in the coming years are Glenda, Violet, AIVF, and Female Project. So I would want to at least share the introduction with you so that you can go through them and maybe start introducing to your practice. From diagnosis to the embryo transfer, AI is going to empower clinicians to personalize and optimize fertility care in endometriosis with earlier decisions, better outcomes, and less guesswork. This is very crucial. Now, a few papers which I want to highlight to you. If you have time, you can go back and have a look at these papers. This one is basically the utilization of PGTA via AI is correlated with the single thawed euploid embryo transfer. So basically, this significantly increases the euploidy classification rates and the live birth rates, and decreases just the biochemical pregnancy rate when compared to the NGS. So this is very interesting. I love how they have framed the impact statement. So basically, it's the AI-based pre-implantation genetic screening tool. And what we know is that for the deselection of the at-risk and aneuploid embryos to prevent the unnecessary PGTA biopsy and the transfer, that is how, I don't think there's anything else we can use to do such a thing. So when it comes to the rectosigmoid deep endometriosis, I wish I had more time because this paper needs a long time. I want to introduce this to you, how they have devised this methodology of this, this framework, how they have done the neural network model to use the suspicion of the rectosigmoid endometriosis. I cannot completely explain in this much time, and that is why I request you to go through this paper when you have time. But it is a very clever idea how this analysis is done by this particular neural network model, and this is how the algorithm is set after the data is fed. So this is how it is analyzed. I want to bring your attention to the next section, which is very interesting. The newer research projects, various departments, different interesting projects are based on single cell transcriptomics. It's a new black in the industry of pharmaceuticals. I'm sure anybody attached with the R&D of the pharma companies are already aware of this terminology and they love it because it's a game-changing thing for them and very promising and probably is going to enhance their profits by multiple margins. So when we speak about diseases like endometriosis, these lesions are made of different populations, different small subset of populations of cells. Some are immune cells, some are endometrial cells, some are epithelial cells, and these cells may behave very differently, and they contribute disease in distinct ways. So it reveals the cellular heterogeneity in lesions, identifies disease-contributing cell populations, and novel insights for biomarker and drug target delivery. Now, think of a lesion as a mixed crowd of people all talking at once. The single cell transcriptomics is actually something which lets you listen to each person individually so you can find out who's shouting, who's whispering, and who is the troublemaker. So this is where we can develop proper drug therapies. We know there is no clear nail on the head kind of a drug for endometriosis in the terms of medical therapy yet. And I think that is where this is going to increase our understanding how to develop medical management of endometriosis. When we look into this, how it works, there are various integrative personal omics profiling, genome, antibiome, epigenome, microbiome, metabolome, or proteome, and all taken together, these advancements represent a remarkable opportunity to harness computational power and AI across multiple scales, transforming how we analyze, predict, and engage with the complex systems. This is where I was waiting to come to. So I want to ask all of you to maybe take some time and go through this even on the internet. This is a very interesting, very cleverly designed project, which is called FEMALE project, and it's an acronym for Finding Endometriosis Using Machine Learning. It is a project which is funded by the European Union Research and Innovation Program, a platform that converts multi-dimensional population data sets into the personalized predictive model to improve the continuum of care of women with endometriosis. This is not open source yet, and it is started to be used in France. It is developed in France, and it is approved by Columbia IRB, but we'll be looking at the progress with very keen interest. I have stuck this in front of the space where I see patients, and I think it is very important to share that whenever we talk about novel things, we must make sure that anything new is fulfilling the criteria of the threshold of the principles of medicine: beneficence, justice and fairness, transparency, trust, autonomy, utility, acceptability, and patient-centered. This is very important. So ethics is one of the major barriers, I would say, so that we only go slow enough to make sure it is a safe style of progress. When we speak about the novel therapies involving genomics, in terms of endometriosis, these are the two simple ways to highlight how the progress is currently happening. So the deconstructing of the human endometrial cell states at the cellular level. So just like how I just mentioned single cell multiomics, even in my previous slide, this is making the principal technology base the foundation on which many of the R&D for the medical therapies are now being created. And the second one is, how do you store data? Modeling endometriosis so basically you copy that in the lab environment in the organoids. So you create endometriosis in the lesions in the lab, in the organoids, and then you study that. So these are where the applications of genomics are heavily changing and shaping the future of endometriosis understanding and then treatment. Future is super AI and the world with organoids. With so much tough data to be stored, there will be computer systems built using human brain organoids. cultivated from the stem cells, and this is signifying a bridge between the biological and artificial neural networks. I was very shocked to see this slide when I saw this first. So this is the tiny human brain tissue. It's called organoid, and this was taken from the Neuroscience News. So this is how we will be preserving the data in future, as opposed to heavy tech data centers that we see. This is another way to store huge amount of data in the organoids. Thank you very much. I hope I could do some level of justice to the time that you spared to listen to the presentation. And I wish you all of you very good luck in the journey. And please stay in touch and write any feedback, even good feedback, to this email, which is office@londonfertility.clinic. And I'm very grateful to the opportunity once again. And thank you, everybody.
Thank you, Dr. Anu. That was such a wonderful presentation. And as always, you've been so informative and always been out there putting your point out.
Thank you. Thank you very much.
If they have any questions, they can put in the Q&A box and we will be able to take them up. And now we can move ahead for the next session. Hema ma'am, I would request you to introduce.
Yeah.
It will be a pleasure for all the speakers, I think, if you're introducing them. So
yeah, thank you both, and thank you, Anu, for that wonderful presentation. And then we are expecting a lot more of work from Anu on the FIGO arena. So this is a very good start to pitch the ideas on endometriosis, and we'll see more of it by the time we meet each other in Cape Town, I hope. So thank you very much. So all the way, swinging from endometriosis to the issues of cervical cancer. Now, women's health, what should be our priority? I would say wellness should be the priority. Prevent illness and promote wellness should be the mantra. And for that mantra of 90-70-90, which is in keeping with the WHO, the song, if I can say, of all the world leaders related to the work of elimination of cervical cancer. Here is someone who has the dream of making India cervical cancer mukt. Yes, you have guessed it right. It's none other than Dr. Priya Ganesh, who sees, eats, breathes, reads, lives on the mission of CCE, cervical cancer elimination, across the country, and her very good work has spread beyond the boundaries. So over to Dr. Priya to tell us more on what she has done and what each one of us can do and what the situation demands in the countries like ours, where the feasibility of anything and everything is a challenge. There could be many barriers, but I think Priya would say, where there's a will, there is a way, or else there are only excuses. Yes, Priya? So over to Dr. Priya Ganesh for her deliberation on the issues related to cervical cancer.
Thank you, madam. Thank you very much. Yeah, it's really an honor that you are chairing the session, and what more we can have. Like having you as a chair is a dream for everyone. Thank you. The tech team will, hello?
I think they moved to Ajay Bharadwaj, who is probably the next speaker in the next session. So this is the right one. Yes.
Yes.
Super. Thank you.
You'll be playing that tech team?
Yeah, that was Dr. Priya Ganesh's brief bio sketch, which can never be brief, of course. Now we move on to her actual presentation.
Hello, everyone. Hello, everyone. This is Dr. Priya Ganesh Kumar. I have been asked to, talk on Delphi consensus study on cervical cancer prevention strategies optimizing HPV vaccination and screening protocol in the prestigious first online conference of ISWHR, which is International Summit on Women's Health and Rights. This is organized jointly by FOGSI and MOGS, which is an online conferences. It is endorsed by FIGO, and thank you very, very much, Professor Rishikesh Pai, to involve me in this prestigious conference. And I am Dr. Priya Ganesh Kumar, National Convener for FOGSI HPV Vaccination Project, which is funded by ACCFI of FOGSI and trained, with this, we have two phases. We have trained 10,900 FOGSians in 2023 to 24 about vaccination, and also have been the national chairperson for Oncology Committee FOGSI from 2021 to 2024. So now, dear friends, let's delve into what is Delphi Consensus. It's a structured method for reaching agreement among a group of experts on a particular issue, often when there is certainty, uncertainty, or limited evidence. So we really want to come into a consensus. Involves multiple rounds of anonymous questionnaires and control feedbacks to refine expert opinions and coverage towards a consensus. So ultimately, the goal is to come to a consensus and aims to leverage collective intelligence to address complex issues, problems, and make informed decisions. So when we talk about cervical cancer, there are hard-hitting facts that it's the 8th most common cancer worldwide, with fourth most common cancer among women. And of course, when you talk about India, it's the 2nd most common cancer after breast cancer. We all know that HPV is the responsible factor for approximately 99% of cervical cancer worldwide. And when we talk about the global burden, it is 662,301 new cases globally in 2022 and around 350 deaths globally in 2022. Now, it can be cured if diagnosed at an early stage and treated promptly. And also prophylactic vaccination, I tell you, it's actually the blessings. And in this era of, the awareness in HPV vaccination, people are taking it up. And that's exactly how we can truly, delve into 90-70-90 to meet the 2030 targets of 90% vaccination, 70% screening, and 90% treatment of the precancerous and the cancerous conditions. And these are the list of countries with high incidence of cervical cancer. And if you see this, this thing, the graph, or we can talk about the figures, globally, the new cases in 2022 has been 662,301. ASR is 14.1, age-adjusted standardized rates. Now let's talk about China. Now this I'm talking about is the incidences. China has got 150,659 new cases, 17.7, followed by India, 127,356, 17.7, and followed by Indonesia. Now, when I'm talking about this incidences, let me take you through the mortality, So now let's talk about the mortality related to cervical cancer. Now, worldwide, it is 348,874 and 7.1 is ASR. Now here, India is topping the globe with 79,906 deaths per year with 11.2 ASR, and followed then by China, 55,694 and 4.5. So definitely India has to have a lot of strategies to be pulled up to know how we can really, combat this high numbers. So we had round 1 at FOGSI South Conclave at New Delhi. And we had a lot of questions being put up to a national, international, group of the panelists. And I was moderating that as well. And so here we are with what did the consensus say? So we had few questions. Let me just take you through it. What are the key barriers in reducing cervical cancer mortality in LMIC? And now all our panelists, 81%, the maximum said, lack all of above. That's lack of awareness, a limited screening program, vaccine hesitancy, poor health infrastructure, and socio-economic disparities. How can cervical cancer be prevented? 90% were with the consensus of vaccine screening and early detection and treatment. That's all of the above. Which of the following is a mode of transmission of HPV in India? So you see now over here, skin to mucosa contact has been told by 34%, skin to skin contact by 33%, 33% said it's sexual contact, but blood transfusion, nobody. So can HPV vaccine cause fertility issues in the future? Absolutely no, that was 100%. What are the major challenges in achieving 90% coverage, vaccine coverage? So you see over here, there were varied answers. Cost and affordability was the maximum consensus. Lack of awareness among HCPs, followed by lack of government prioritization, and secondary concern, parental inhibitions and safety. Should HPV vaccination be included in UIP? 100% consensus. What is the most feasible screening method in India? So now over here, we really wanted to stress on, can we introduce self-vaccine sampling? Now, most feasible in India still we are with VIA. A combination of VI with HPV testing can go ahead, but of course, our DNA sampling, self-sampling has taken a little backseat when you talk about feasible screening, because yet it has not come up everywhere. How can India align with WHO's 90-70-90 targets? Now, here you see the national mission has been the major, consensus. You put it up into the national mission for cervical cancer elimination. However, then followed by public-private partnership, that is PPP model, followed by decentralized, district level programs. Is screening needed even if HPV vaccine is given before a sexual debut? So the 100% consensus was, that screening is not needed. Of course, screening is needed. I'm so sorry. Even if the HPV vaccine is given. So that's like 100% consensus. It strongly agree. Yes. For Indian women, when should the screening for cervical cancer begin? So 64% consensus were at 30 years. Apart from the age, what should be the exit criteria for cervical cancer screening? So the answer was after 65, 82% said after 65 with 3 consecutive negative cytology results. Should we adopt HPV testing every 5 years as a gold standard in India? So this was mainly India specific, this part of our Delphi consensus, and it was strongly agree as 50%. What is the primary target group where HPV vaccination is recommended? And we see 9 to 14 years, about 80% were the consensus. Is the resource limited setting, is twice lifetime 35 and 41 strategy acceptable? So yes was with a minimum benchmark was 50% consensus. When HRHPV is unavailable, which interim strategy is most available? So it was like VIA, of course, is the interim strategy. And then we can also have, added up to that VIA or cytology every 3 to 5 years, whatever is available. Should India adopt screen, triage and treat and screen and treat approach depending on the regional healthcare capacity? Strongly agree was the answer. Can HPV test be used as screen and treat single visit approach? 90% said strongly agree. That was beautiful. In limited resource setting without colposcopy, what should be the triage method? VIA, 94% consensus. And based on the current global strategy data, what is the best characterizes HPV vaccination safety? Almost 70% said that it has, it's a very safe one. Only minor injection site reactions occur. That's the consensus. Then we had panel 2. Now here we had major people from international, from across the globe, like Europe, we had from UK, we had from Africa, we had from South America and Italy. And, you can see over here, UAE, Argentina, Nigeria, Rwanda, Thailand. So we had across the globe, Brazil, and then this was the group which we had, and I had conducted this as a moderator. I was, given the opportunity to conduct the Delphi consensus. So let's see. These are also wonderful things coming up out of this consensus. So let's go now into the Delphi consensus. Now, of that part 2, what are the key barriers to reducing cervical cancer mortality in LMIC? Now, we are raising above India and we are talking about LMIC, and we have with our, the panelists who are all from across the globe. And it was the 100% consensus came all of the above. There's lack of awareness, limited screening program, vaccine hesitancy, poor health infrastructure, socio-economic disparities. Can HPV be passed from a mother to her child during childbirth? Now, 100% is yes, because we all know if there are warts, there can be that, the child can get infected from the mothers while conducting through this, passing through the conduit, vaginal conduit. So that was consensus. Now, can HPV vaccine cause fertility issues? No. 100% consensus, there was no. What are the major challenges in achieving 90% HPV vaccination coverage? So all of the above was the consensus, like cost and affordability, cultural religious beliefs, vaccine hesitancy, lack of government prioritization, and misinformation about side effects. What is the most feasible screening method for LMIC? 80% still, the feasible method. Now, here comes the major change. Now our consensus group has talked about self-sampling. So that would be the most feasible screening method for LMICs. That's going to be awesome. 80% consensus came for HPV DNA test self-sampling. Screening needed even if HPV vaccine is given before sexual debut. 100% consensus, yes. When should screening for cervical cancer begin? And the 70% came up with 30 years. And there were 30% who said that 3 years from sexual debut. But for LMIC, it's 30 years. And apart from the age, when should be the exit criteria from cervical cancer screening? So 40% said that 65 years with 3 consecutive negative cytology results, and 30-30 were shared by consecutive negative HPV tests within 10 years or most recent tests, and some few said all of the above. But maximum consensus came up with 65 years with 3 consecutive negative cytology result. In LMIC, is twice a lifetime strategy of HPV testing 35 and 45 years acceptable? Yes, as a minimum benchmark, came up as 100% consensus. When HRHPV is unavailable, which interim strategy is most available in LMIC? And definitely VIA or cytology every 3 to 5 years was set by the consensus. Should LMIC adopt both screen, triage, and treat? One screen and treat approach, depending on regional healthcare capacity. Strongly agree was given by 70% maximum consensus. Can validated HPV test be used for screen and treat single visit approach? Again, strongly agree was 70% consensus. It's wonderful. And should an optimal dose HPV vaccine schedule be piloted in LMIC for girls and boys aged 9 to 20 years? And optimal dose means complete dose, like 2 doses, 9 to 14 years, through 14 years, and then 3 doses from 15 to 26 years. So it was strongly recommended by all the consensus, all the panelists, and now comes another answer. Shouldn't compromised dose, that is single dose or the low dose schedule. So the compromised dose, that's off-label WHO, off-label strategy, SAGE strategy, be piloted in LMIC for girls and boys aged 9 to 20 years. The whole consensus came up to be, highly discouraged. Because they said that LMIC still it has not been, so that's how the consensus came up with, that they said in LMIC, where there is a lot of cervical cancer cases, it's better that we give an optimal dose. Compromised dose was not was not much recommended, and so it was highly discouraged by the expert panelist. And based on the current global strategy, what's the best characterizes HPV vaccine safety? And the 100% came up with the mild local reaction are common, and serious adverse effect are really extremely rare. So here comes our understanding that so we are done with our this presentation, and I come to the last thing, that thank you very much, first of all, that you have given me this opportunity to be in front of you and discuss with you all the consensus guidelines. So consensus are taken, in a very strategized manner. Initial consensus rounds were taken up by for the national international group for specifically India. Then we went ahead taking the next group, which was more of international people from across the globe, and thinking these are the think tanks. They thought about what will be the strategy, which will be the best strategy, affordable, achievable, and adoptable strategies by LMIC countries. So thank you very, very much, Dr. Pai and the team, FOGSI, MOGS, to give me this wonderful opportunity. And thank you very much. Bye.
We see the leader himself has joined us. Dr. Rishikesh Pai is here now in Hall 2 with Dr. Nandita Palshetkar. And just like anemia, HPV is another huge movement that Dr. Rishikesh Pai wants to create, and he's well on the journey to make a global consensus happen at the forthcoming Cape Town meeting. So thank you, Priya, and over to our leaders, Dr. Pai and Dr. Nandita, to express their vision and mission towards cervical cancer elimination, not only in India, but across the globe. Over to you.
So, thanks, Hema. I think that it's a wonderful. Is Priya there on the screen? Is Priya there? Bring Priya on the screen.
Yes.
Yeah. So, I
Yes.
would like to say that it's very appropriate. Hema is our FIGO divisional head for Well Woman, and Priya has been very active. She was a chair for the Cancer Cervix Committee of FOGSI, and I think she is in the AOFOG. Priya, are you on the AOFOG committee as
Yes,
well, right?
sir. Yes, sir.
And there are two really important, important topics which are really influencing our, preventive areas, and those are the areas of anemia and the area of cancer cervix, that is HPV vaccination. And as trustee of FIGO for Asia, I had planned this, and in April we had a South-South conclave in Delhi where we called 7 African country presidents of societies, of FIGO societies, and 7 Asian countries were present. And my colleague, trustee from Blami Davo, from the trustee for FIGO from Africa, was present. And we had our first Delphi consensus meeting on anemia and cancer cervix. And Priya was the one who conducted that meeting. And we had a lot of learning. Excuse me, can you just, hello? Tell him to stop talking. We had a consensus meeting on this subject, and we had a lot of questions that were discussed in this meeting. And following that, we came to a conclusion, and then we followed it up with the Femtech 5 meeting in August in Mumbai, where we had Nestor Garello, who is the FIGO trustee for Latin America, and there was Agnaldo from Brazil. He was the vice president of Brazil, immediate past president of Brazil, and there were a lot more people from Turkey, the Turkish president, the Nigerian president, the Spanish president. We had Sambit Mukhopadhyay, who was the EBCOG new president-elect, the European board. So we had a kind of we added and layered on the learning and the decision of the April meeting, and we have now come to the next phase of the Delphi. And what Priya has presented to you is the joint consists of the 3 continents, so to say: the Asian continent, the African continent led by Blami, Asian by me. Then we have the Latin American continent led by Nestor Garello, who is the trustee of FIGO. And of course, we have Hema and we have Nandita, and all of the people are around us. And now we go to the next phase of this consensus. We will be having a Zoom meeting, and then the final consensus and a declaration on this we will do in our Cape Town meeting. Basically, the whole, I think Priya and Hema and all of you, Nandita, you will agree, the whole thing is hinged on the vaccine, whether 1 or 2. I mean, it's a no-brainer. We all know that we need to give 2 vaccines and it's going to preventable. Everything is easy. Everything is crystallized. The question is 1 or 2. And yes, maybe in the larger sense, 1 single dose would be better. At least everyone will get covered 90%. And that's what I think is going to happen. Hema and Priya and Nandita, you have the few contributing discussion points, and then we can close it.
Yeah, Priya, I think that was a wonderful presentation, and the whole Delphi consensus meet that we had came out with some really interesting facts. I think, 2 versus 1 is going to be an eternal debate. And we do know, of course, that 2 will give better coverage. But looking at the whole scenario, if you really want to reach to a lot more people, I think that is where the WHO comes from, that, at least 1 is required. So it is really important. And I think what we are targeting now is prevention. I mean, healthcare is really moving in that direction also. And even in India, we have preventive, PM Modi's initiatives, which are on, non-communicable diseases, prevention of diseases. I think all this is becoming very important, and especially FIGO taking it up and, along with in this meeting, I think was very important. Rishikesh, I must congratulate you on taking these two aspects, which are which are big killers actually in the world. And I think it's really important. Rishikesh, before we wrap up, is Anu Chawla also there? Because we have some questions. We have about 15-20 minutes of
Anu was
discussion.
there a little while ago, but I don't see her
Yeah,
now. She was very much there to respond to those questions, but at that point, we didn't
we
seem
will
to have
call
any
her.
question.
We can call her just now to the screen. In the meantime, Hema and
Yeah.
Priya, in the 1 and 2, what was the Delphi consensus ultimately on the 1 and 2, especially in the Mumbai meeting? There were a lot of, I think, opinions. And what was the general thought process of the
The
leaders?
consensus came up was optimal dose is what 80% of our people, our panelists supported. And that is optimal doses means the proper two doses. And for reduced dose schedule, it was the consensus was around only 10%. Because for the
Right.
LMIC, they were all talking about that LMIC hasn't yet started properly. So we do, if we are able to give, the optimal doses, then let's stick to the optimal doses. Once it comes in the UIP program, and then we develop a herd immunity, then it would be, then we can talk about reduced dose schedule. But as of now, since it hasn't come into the UIP, immunization government schedule, we will all stick to that was the consensus. Of course, it came up as optimal dose schedule.
Hema,
Yeah.
you have been the overarching, you have seen FIGO and you have been in a lot of preventive programs. So how do we trade off this? How do we trade off our ideal situation with a compromised situation? What is, I can't, really, in my mind, I sometimes feel that no, we should not. Equity is very important, and we should see that even a poor person gets the same treatment as a well-off person. But what do you think? How do we compromise this?
Yeah. For one thing, Dr. Anu Chawla is back with us. So, Nandita, you will shoot the questions to her soon after I finish my comment. But then, the thing about HPV, we are also going to be having a global commitment at the Cape Town meeting, because from the Division of Well Women Healthcare, we're running a whole panel on success stories, because we want to hear some positive, useful, meaningful success stories from right across the globe, how they have been able to do it. And just like hyperglycemia in pregnancy, the diabetes, all the leaders came together, and it was a good photo opportunity, very symbolic, to sign off a global commitment, where global commitment is there with every national body. The global consensus, we have not yet reached there, because in different countries, different issues, even for 90, 70, 90. But we want 90% of our girls 9 to 14 vaccinated. How many doses? One or two? 68 countries have taken one dose, because their opinion is that, yes, right across, at least let's give one, something better than nothing. Indian government, universal immunization, they have not yet embarked, because the specialists are also not in consensus with what to advise the ministry. So I think we should come together in a pragmatic way. That is the 90. 70 is again there, it's a bigger pain point, because as of now, the government recommendation for screening is only visual inspection, which is like, we don't want to go on that line. We want to shift to HPV DNA testing as early as possible, because that's the gold standard. And Make in India products are also coming, IHPV, etc. If it stands the test of time in the next 2 years, maybe that would be a feasible method of doing. So that's where we're going. And the last 90, of course, Priya has set up so many of the triaging, colposcopy units, and then the treatment, and we can seamlessly do it. So let's focus on getting the global commitment, Rishikesh, at the Cape Town, that each one should do what best they can do. At the moment, that all the countries may not agree, put their head round, because the options are given by WHO itself. They say, guys, if you can do only one dose, get started with that at least. So what we are actually proposing is, let's aim for the ideal, but let not the best come in the way of the good. That has always been our thought process. So internally within the countries, state by state, and the recommendations to the ministry, it should come from the global FIGO voice to the local FOGSI voice. And as you have always maintained, Rishikesh, the global voice for local solutions. Let's get our act together and do that. But I think the two important issues, as Nandita said, the anemia and the HPV vaccine, HPV and the the entire issue of cervical cancer elimination, we should not let it off our focus, and we are all there in solid support for you, not only in your journey as a trustee, but the future global leader, to make a difference and make things move in the right direction and on a fast track. That is very, very crucial. We can't be waiting forever and forever slowly to progress, because many more millions of women will die either during childbirth or after that because of these NCDs. So we need to get our act together for sure. And we are very hopeful and very positive with the way we are moving ahead in our own country with our own leadership, that we will be able to together make a difference and make things better than what it is right now. So that is my 2 cents for this big issue. And Anu is back with us so kindly, with whatever time it is in London. She's there. So if Nandita has garnered some questions from the audience, which I too was so eagerly waiting. So Nandita, go ahead.
Yeah, hi Anu.
Thank you.
That was a very wonderful talk which you delivered. And there are some questions which are there in the chat for you. I don't think you can see it. I've got it on my phone. So Anu, what is the role of elagolics today in endometriosis management? Can she hear me? Can you hear me, Anu?
Anu has an expression as if she cannot hear you.
Hello. So basically what is happening? So first of all, hello everybody. And 1 second.
Can you hear me, Anu?
What is happening right now is that the audio from the hall is 0 to me. So I have to use the audience link to hear, but I heard your first question, which is regarding elagolics, through the audience link. So very applicable. It was 2015 August when I first saw New Hope Clinic in New York using elagolics in the mini IVF that they were using. John Zhang was using elagolics at that time already. So they had it available 10 years back and in application. So I think it is one of the very patient-friendly ways, and how we can employ this in many of the fertility treatments. Premature LH surge is a common problem when early career doctors face in even IUI cases. So I think not just in IVF, but even when a patient has taken any gonadotropin injection, even in a normal induction phase of the IUI, oral antagonist is going to help. And endometriosis and fibroids and all the estrogen dependent conditions will be heavily dependent on this in the near future.
So basically, I think elagolics, because of its oral route, will be more patient friendly in the future. And the one more question on endometriosis would be, obviously the standard question is always about fertility preservation. And what is your take on that? Patients who are having severe endometriosis and they still don't want to have a kid and they want to have it in the future. What are your takes on that? How is it going on in has it taken up in a big way in your part of the world?
She cannot hear us. That's the problem.
Why is it? Why she's not getting our? Why
by the time Anu comes here, what I was telling you all is, we've started using elagolics in embryo transfer, before embryo transfer.
So basically, I want to highlight, otherwise everything is going well, but the audio from the hall in the faculty link is nothing, 0. So I have to switch to the audience. So I think I'll not take too much time and you can progress till the time maybe they can work on it. I'm still there to take questions in future once they settle this. You can send me the questions in a written text maybe, and I'll come back later.
No problem. So elagolics, basically, we are using it a lot before embryo transfer. That really helps in clearing the uterus for adenomyosis, for endometriosis. So prior, rather than giving a GnRH analog, we've started using elagolics. Patients are happy with it, and we are getting very good results with it. The other thing I think, Rishikesh, we should discuss about the fertility preservation. I think it's very, very important that a patient is subjected to an AMH whenever you get a patient of endometriosis, because even in adolescent and teenagers, it is important to figure out their ovarian reserve, and especially once they turn 20, 21, I think egg freezing should be an option given to these people. So egg freezing is definitely something that one should think of when there is endometriosis. And a lot of couples who are married and have endometriosis do a lot of embryo freezing. Recently I've had a couple of patients where there was endometriosis, deep infiltrating endometriosis, and surgery was done. The complete endometriosis has been cleared off, and then we've done the embryo transfer. Of course, I've frozen the embryos before. I've done the embryo transfer, and they've got very good results. So sometimes in patients who have had multiple IVF failures and you have these precious embryos which are left over, I think it is quite reasonable to do surgery and then go in for embryo transfer. What is your take on it?
Yeah, I think definitely endometriosis, even in DIE cases, see what happens is endometriosis elicits an inflammatory reaction, and that is what is reduces the implantation rate. So even with patients, because the one of biggest problem of endometriosis is you can't clear everything, isn't it? You can't remove the whole endometriosis. So what is our strategy is try to get the embryos, freeze them, and then if you can do it surgically or you can do it chemically you can give GnRH agonist for 2 months, or you can give GnRH antagonist for a long time, but that is the oral GnRH antagonist. So both of them have ultimately expressed to the same route. The inflammation gets reduced, and because of that the implantation is better. So that is what it is all about, ultimately to reduce the implantation in these patients. So I think that we are more or less on track for the next session at present. And so I would like to say that we need all to come for the Cape Town conference, which is there in from the 5th to the 9th of October in Cape Town. And I hope to see all of the participants. Incidentally, Hema, we have got nearly 3,000 people online at present. So it's a very good online presence that is
Great
there.
number.
So I think this is one more thing, because we have some time, Priya, and one of the things that we like when I was a president of the federation, we did was the American Cancer Society had given us a big grant for doing training of trainer program.
Yes.
That we nearly trained, under Priya. I had asked Priya to lead that program, and we had done nearly training of nearly 10,000 gynecologists. And in fact, 10,000 and odd gynecologists were trained. And
10,900. Yeah.
maybe Hema, as a divisional head, this is a program one can take to the international level as well, because through the digital media, Zoom, we can really do a training of, it's a force multiplier kind of. We can
Absolutely.
train.
That's why, Rishikesh, I was telling you that you have played a very, very proactive role in furthering the implementation of all the FIGO initiatives, because that requires a very different level of commitment, because everything is there on the shelves, but how does it move onto the ground? So that has been your strength. And of course, needless to say that globally also, we in general have all kinds of support, because they're very appreciative of the kind of lead that our country has taken, and together we can do a lot more. So from the FIGO banner also, just because there is a varied mix of low and middle and high income countries, to come to a consensus, a bit of give, a bit of take, is very challenging. But what we have recognized is we need to be aspirational. The low income countries can do only this much for now. The basic evidence based, let's at least get on with that. then you build over it to the next level of your aspiration about what more you can do, and then you reach the ideal situation. So I think stepwise is what you are taking us ahead, and I really do appreciate that, and I think we can get our act together across the entire globe. Thank you, Rishikesh.
I think, Priya, you want to say something?
Yes, yes. Now, so that was Dr. Pai's vision that I mean, during his tenure as president, FOGSI, 10,900 gynecologists were trained, and truly that was really applauded very well. It was acknowledged very well by ACS, and this is some, a benchmark which was put. And then they said that if this can be done by the LMICs in such a nice short time of 1 year, why not? You can have a replication of this across. And now, beyond that, they came back, and Dr. Pai's tenure had just finished, and now it came up with IMA. So 50,000 IMAs. The FOGSI had 135 master trainers. Now the master trainers have to train 50,000 IMA members. So now the understanding is, why only restricted to gynecologists? It is the general practitioners and the other this thing also to take it up. So sir, the foundation stone which you had put has really taken up a great stepping stone, and is now it's like flaring up, and I was going to all the IMA members as well, sir.
I was just saying that now I was just reading yesterday only about artificial intelligence. So, many of these things are going to be taken over by the computers, the training programs, and probably the computers will be empathetic also. Like when I talk to my chat GPT and I tell sometimes, okay, chat, can you make it more personal and more human? So the computer comes out with a more personal and human kind of interpretation. So, Dr. Anu, are you audible? Are we audible now?
Yes, now you are. Yeah.
Great. So, Dr. Nandita, you wanted to ask another question about.
Yeah, Anu, welcome.
Hello, thank you.
I think we've sorted out the problem. So, Anu, endometriosis, we are seeing a lot of cases. Do you think it's on the rise, and why? What is the reason? And do you think it's because awareness is not there? It takes longer time to be diagnosed. What do you think about it?
So the central aspect of endometriosis, anybody wants to work, is on first step is the diagnostic delay. Even in UK, it is 8 years of delay when the patient first says something until the time she's diagnosed with a known case of endometriosis. It takes 8 years in this day and age in the developed countries, and forget about it may take a whole lifetime in maybe other countries. So that is very important. And most of the research, 60% of the PubMed indexed data has only been published in the last 2 decades regarding endometriosis. So all of the knowledge that we have has actually come only in the last 2 decades. Until now, we were very pleased to call it enigmatic. So already the percentage of prevalence is 10 to 15% easily, depending on different locations. And because now we are more focused on this, we are understanding the effect on the quality of life, and various governments have, including France, New Zealand, they have incorporated in the government policies to acknowledge the quality of life issues that these patients face starting from adolescent age group. So I think because of that, we notice this more, but already the prevalence has been as significant as 15% in the society. So I think we have got more eyes and ears towards that.
Thank you, Anu. And I think you're very right. The diagnostic tools have improved also. The sonologists are picking up more of endometriosis. And I think the gynecologists, the obstetricians are tuned to it, that if there is pain during periods, please wake up, please look at it, please follow up the patient. So I think it's really, really very important.
I think Dr. Sangpal is still there with us, and he's our president of the Mumbai Society. And I wanted to ask him a question that now that is here. Because you see a lot of endometriosis, do you think that because you have been practicing endoscopic surgery for the last 3 decades, you think that endometriosis has increased in the developing countries like India as well? Because when we were students, we were always taught that endometriosis is a disease of the advanced world. Now, are you looking at it? And second question is it as prevalent in the not so well-off class as the well-off class? What is your quick thought on it, because we are now closing the session?
As you rightly said, we are seeing a lot of endometriosis in today's time, irrespective of the class of patients. whether they are economically low income strata, where endometriosis has widely spread. Maybe because of what I see personally, I feel it's because of the lifestyle change. The change what we eat, that's what we produce, our body produces. The junk food, which is probably related to this, we see a lot of endometriosis in reproductive age groups, starting from right from adolescent, 15 years, 18 years, 27 years, a lot of deep infiltrating endometriosis, adenomyosis we are seeing. And this is, I think, totally related to lifestyle. Means what we are eating. If you see example, we eat milk. The Indian population requires 65,000 million liters or some 65 million liters of milk every day, but we produce hardly 14,000 or 14 million liters of milk. And what extra milk is coming from? It is all by powdered milk or some other sources. The buffaloes are given, estrogen injections. That's why we see a lot of fibroids, endometriosis, adenomyosis going infiltrating to surrounding other than sticking to the uterus, bladder, and I mean all that is been getting affected. So in summary, endometriosis is rising because of the lifestyle, and we need to study that whether really this lifestyle is related to endometriosis.
Thank you. Thank you so much. And on that note, we will end the session. Thank you very much, Dr. Anu Chawla, Dr. Priya Ganeshan, and of course, I think Hema is still here. And Rajendra, thank you for being here.
Thank you.
Thank our younger chairmen, Dr. Krutika and Dr. Jitika, to be here with us today. And I think we'll conclude the session.
All right, ladies and gentlemen, so that was the session is being concluded now. I'd like to thank all our speakers and our chairpersons. We'll now quickly go ahead with our next session. And I would like to invite our chairpersons once again. May I request Dr. Nandita Palshetkar. We have Dr. Hema Divakar, Dr. Priya Ganesh Kumar, Dr. Kritika, and Dr. Jitika. So they are the chairpersons for our upcoming session. And we also have Dr. Pai here. I request our chairperson to please invite the first speaker.
Before we do that, are they online? Dr. Haynes and Dr. Asha Kasliwar, have they come online? Not yet. Okay. Can we put Dr. Haynes biodata on?
Please. Yeah, but enlarge. So now to take the session ahead, we have Dr. Haynes van der Merwe, and he's going to be speaking on surgical treatment of early cervical cancer. Dr. Haynes is a gynecologist oncologist and is the current head of gynecologic oncology unit at Tyberg Hospital and Stellenbosch University. He is a member of the International Gynaecological Cancer Society and member of the South African Society of Gynecologic Oncologists. He is a member of the South African Society of Gynecology Oncologists, the SASGO. He is also a member of the HPV board, and he's the current secretary and serves as a director on the HPV Cervical Cancer Research Fund. Dr. van der Merwe is immediate past president of the South African Society of OBGY, the SASOG, and as such is the member of the executive committee and council. Can you please play his talk?
So we're going to play his talk.
Good morning, colleagues, and thank you very much for the invitation to speak to you today. The topic under conversation is the surgical options in the treatment of cervical cancer. My name is Haynes van der Merwe, and I have no disclosures. Just by way of introduction, I'm a gynecologic oncologist, and I work at Tyberg Academic Hospital in Cape Town. And on the slide, you can see a nice aerial picture of both the hospital and the university buildings at the hospital where I work. So when we talk about cervical cancer, I think it is important just to have a little bit of perspective. And I want to take you back to this call that came from the WHO only about 5 years ago that set the targets of the global strategy to accelerate the elimination of cervical cancer. And the targets include vaccination of 90% of eligible girls against HPV, the screening target of 70% of eligible women at least twice in their lifetimes, and then also to effectively treat those with either a positive screening test or who already have a cervical lesion, and that obviously includes palliative care for those who might unfortunately have presented at a very late stage. I also just want to remind you about the histologic types that we get of cervical cancer, squamous and adenocarcinoma, obviously by far the most important, but then don't forget the rarer histologic types that I've listed here on this slide. We don't see them that often, but the important thing about the rarer histologic types, they are often very aggressive type of tumors, and one needs to individualize treatment. Just a few general considerations about the management of patients with cervical cancer. I think it is important to centralize care of these patients in specialized centers. My view is also to have a multidisciplinary planning of treatment, if at all available. This is what we do in our unit, where not only us as gynecological oncologists, but also the clinical oncologists get together once a week to discuss patients. And then once you deal with a patient, to have a careful and comprehensive approach to counseling of the patient. And of course, the treatment should be by a dedicated specialist team, which in my mind should include the services of a gynecological oncologist. Just a few words about the clinical and diagnostic workup. This is now once a patient has been diagnosed with cervical cancer. I don't think we can move away from a comprehensive clinical examination of the patient, especially where I work in South Africa. We're a lower middle income country, and many other regions in the world, the majority of Africa. I think the first step is to examine your patient thoroughly, and that should include a pelvic examination with full assessment of the pelvis. This examination is obviously to look for any findings or signs of metastases outside of the cervix. If you have the luxury of access to MRI scanning, I think one can use MRI. We use it in our unit in patients who present to us with fairly early disease. I don't think it has a lot of value in patients with locally advanced disease. And if you don't have pelvic MRI available, I think ultrasonography in experienced hands are also very good. We should image the chest, the lungs, and the abdomen. You can include cystoscopy if you want to exclude bladder invasion. We've stopped doing that for all of our patients presenting with cervical cancer. Only if they have hematuria, we will follow that up with a cystoscopy. Nodal disease will, in early disease, be surgically, pathologically staged. And I think any equivocal extrauterine disease should be biopsied or FNA. So if you feel enlarged nodes supraclavicularly or inguinally, I think it is imperative to do either a biopsy or a FNA of those nodes. Just to remind you about the new staging, the stage 1A, which is regarded as microscopic disease, which is further divided in 1A1 and 1A little 2. The new or the latest staging of cervix cancer, the 1B category is subdivided in 1B, 1, 2, and 3, depending on the size of the tumor. And then patients with stage 2 disease might also be considered for surgical management. So I'm swiftly going to move now to the surgical management of the early stages. And just if I can make a general comment here as well, as far as treatment goes, we've got 2 treatment modalities available for patients with cervix cancer. The one is surgery and the other one is radiotherapy, sometimes with addition of chemosensitization. And as a general rule, patients will qualify for surgical treatment if the disease is confined to the cervix. Any locally advanced disease, those patients should not have surgery and should have chemoradiation. So if we can just subdivide the stage 1 disease in 1A little 1 and 1A little 2, the majority of patients with stage 1A little 1 disease are LVSI negative, because we know in the first 3 millimeters of the cervical stroma there is hardly, or there are hardly any lymphovascular space, so it is infrequent to find these patients to be LVSI positive, but we do find them from time to time. So the majority will be LVSI negative, and these patients do not need any further surgical assessment of their lymph nodes, and they can either be treated by a simple conization, or I think if a patient's family is completed, a simple hysterectomy, and the recommended route is a vaginal hysterectomy. I think is doable. Patients who are LVSI positive in stage 1A little 1, I think should be treated the same as 1A little 2, and they need surgical assessment of their lymph nodes. If sentinel lymph node biopsies, if that is available in your unit, you can use that. If not available, I think you should do a full pelvic lymphadenectomy. 1A little 2, the management of the primary tumor, I won't say is controversial, but there is some contention about it. In our unit here in Cape Town, the 1A little 2s for the primary tumor, you can either, if you embark on fertility sparing treatment, I think a simple cone is sufficient. Again, the patient whose family is complete can have a simple hysterectomy, but I know there are many units that will propose these patients to have a modified radical hysterectomy. in our unit, we, as I say, do simple hysterectomy, and we find that to be sufficient as the approach to the primary tumor because of the risk of lymph node involvement. In patients with stage 1A, 2, I think they need assessment of the lymph node, surgical assessment. Again, if you have sentinel nodes available in your unit, you can do a sentinel node. If not, I think proper pelvic lymphadenectomy is to be done. Let's move on to the stage 1Bs. Again, I think there would be different opinions about the various subcategories of stage 1B. I think there would be agreement amongst most colleagues that 1B1 and 1B2 should be treated by or surgically. There might be some discussion about the 1B3s, the tumors bigger than 4 centimeters, the big 1Bs. We know their risk of having adjuvant treatment is also a little bit higher, and therefore some units will say primary radiotherapy, but I think those patients can be treated surgically. So the surgical option for these patients are a radical hysterectomy, and we'll have a look just at the various types of radical hysterectomies as we go along. I'll show that in the next slide. And again, if you have sentinel lymph nodes available, you can do a sentinel lymph node. A controversial area in these patients will also be if they are node positive. So if you have access to an MRI or good imaging of the pelvis that indicates the possibility of positive nodes, some people will first go in and do a proper surgical assessment of the nodes, surgical and pathologic assessment of the nodes. You can either do it as a procedure, a single procedure, or at the start of the radical hysterectomy, if you have the pathologic services available in your hospital, to come to theater and do a frozen section, remove the nodes the suspicious nodes, and if they are positive, some people will say that this patient will in any case need adjuvant radiotherapy, and you should abandon surgery and give the patient treatment. There is some controversy. Some people will say, no, let's continue with our surgery. At least we get the tumor out, we get all the nodes out, and there's less to irradiate post-operatively. Then just a few words on the types of hysterectomy: simple extrafacial hysterectomy, modified radical hysterectomy, and then the proper radical hysterectomy. On this slide, I just want to show you the different classifications: the Piver and Rutledge classification, the Quello and Morrow classification, and at which stages the different types of hysterectomies are indicated. And then just the comparison is really about how much vaginal cuff you take. Firstly, with a simple hysterectomy, there's no cuff taken. With the radical hysterectomies, at least 1 to 2 centimeters of cuff is taken. The ureteric dissection is not really indicated or necessary in a simple hysterectomy or extrafacial, but then mobilization of the ureters and to mobilize them laterally out of your field to get access to the parameter is definitely part of the either modified or type 2 or type 3 radical hysterectomy. Again, also the extent to where you dissect the cardinal ligaments differ between the two types of radical hysterectomy. As the same applies to the uterosacral ligaments. The bladder is mobilized to the upper or middle vagina in the case of the radical hysterectomy, which is not really necessary in extrafacial hysterectomy, and the rectum is also mobilized to way below the cervix in a radical hysterectomy. Colleagues, just a few words on adjuvant treatment. We do have to accept that probably between 10 and 15% of our patients that we have preoperatively assessed to be surgically treatable will require adjuvant, either just radiotherapy or chemoradiation. And we divide those indications into major and minor criteria. So any patient with positive lymph nodes, positive margins, or parametrial involvements regarded as a major criteria, any one of those positive, that patient should have radiotherapy, and definitely if there is lymph node involvement, the addition of chemosensitization is paramount. Then there are the so-called minor criteria, looking at the depth of invasion, whether there's lymphovascular space invasion, and any two of the minor criteria being positive will also be regarded as an indication for adjuvant treatment. I think we just have to say something about fertility sparing treatment as well, because some of the patients referred to you will be young and will desire future fertility. Now, the patients that qualify for fertility sparing treatment should be very well selected. First of all, fertility sparing treatment does not apply to any of the rare histologic types. Patients should either have a squamous or adenocarcinoma, which is HPV associated. Any other rare histologic types do not qualify for fertility sparing treatment. Then the patient should have radiological assessment of lymph nodes. If there is clearly pathological lymph nodes on radiological assessment, again, they don't qualify for fertility sparing treatment. If they aren't, then we look at tumor size, and only patients with tumors smaller than 2 centimeters would qualify for fertility sparing treatment. Those who are then assessed to qualify for fertility sparing treatment will the surgery will start with intraoperative assessment of the lymph nodes. So and there again you should have the pathologist in theater with you to do a frozen section. If unfortunately the patient has positive nodes, that patient does not qualify for further surgery and should have definitive chemoradiation. Patients who are lymph node negative, one will then decide about the extent of the surgery of the primary tumor based on the size of the tumor. Patients with 1A disease is a simple conization should be fine. Stage anything more than that should have a trachelectomy, which could either be a simple or a radical trachelectomy. Then just a few words about what do we do with patients who now had a simple hysterectomy? We find that sometimes patients are referred to us. They've now had a simple hysterectomy with undiagnosed cervix cancer preoperatively, but now it comes back. So anything more than a 1A little one, the patient needs to be properly assessed, and a decision should be taken about the assessment of the nodes. The challenge here is, well, you've got two options. You can either go back and do a proper lymph node assessment. That means a pelvic lymph node dissection with or without the parametrectomy, because if the patient has negative nodes and the parameter is clear, she does not require any further treatment. Whereas your other treatment option is to just irradiate all of them, but that will mean that you will probably irradiate a lot of patients unnecessarily. So my recommendation is to to go back, go and do a pelvic lymph node dissection and decide whether the patient really needs a trachelectomy. We hardly ever do a trachelectomy, but assessment of the lymph nodes is very important. Cervical cancer in pregnancy is obviously a whole big topic on its own. But again, just the patients whom you diagnose in pregnancy with a cervical cancer, who at that stage you feel is surgically treatable, but the patient is not yet at fetal viability. We would carefully counsel those patients, and they have to decide whether they want to proceed with the pregnancy or not. So if they don't desire to proceed with the pregnancy or continue with the pregnancy, then you can terminate the pregnancy and then treat them with whichever form of treatment you think is appropriate. In early stage disease, most likely a radical hysterectomy. If, however, the patient decides to continue with the pregnancy, we would follow a fetal maturity approach. In other words, we will continue or allow the patient to continue with the pregnancy, but she will, in the meantime, receive chemotherapy. They will either get single agent platinum or platinum plus Taxol at 3 to 4 weekly intervals. And then I think by 34 to maybe 36 weeks, you should take a decision to then deliver the baby, and at the same stage, at the same time, do a radical hysterectomy and pelvic lymph node dissection. Lastly, colleagues, a few words about recurrent disease. We, from time to time, see patients who present to us with disease recurrence after chemo radiotherapy. Those patients needs a very, very comprehensive and thorough assessment. First of all, to establish that the recurrence is only central and that the patient does not have any disease outside of the cervix. For those with central disease, I think a patient qualifies for pelvic exenteration. There are braver surgeons amongst us who will even attempt surgical treatment of the patients with pelvic sidewall extension of disease, the so-called Lear procedure. But we do not do that in our unit. Patients who have a recurrence after primary surgery, who have not had adjuvant treatment, can then be managed by chemoradiation. Colleagues, that is what I had to say about the surgical treatment of cervical cancer. I know that was a whirlwind tour through the topic. But thank you for your time. Thank you for listening. And just I want to remind you about the FIGO Congress that will be in Cape Town from the 5th to the 9th of October. It's 5 weeks from now. And I want to use this opportunity to invite all of you to come to Cape Town. I know it is a little bit late, but you can still register, book your flights, get your visa in order, and please come and join us in Cape Town. I'm personally looking forward to meet a lot of you in Cape Town, as I'm the co-chair of the local organizing committee. So a warm invitation and a warm welcome to all of you, and I hope to see many of you in Cape Town. Thank you very much, and enjoy the rest of this meeting.
It's on. Thank you, Dr. Haynes. Is he there online?
Asha, where's the TV and this?
Good afternoon. Now we have the next speaker, that is Dr. Asha Kasliwal from UK. And welcome, Asha. She's the chair of the Contraceptive Committee of FIGO, and we're really happy to hear the talk on use of contraceptives to manage gynecological conditions. I think this is a very important part of oral contraceptive pills, which is really required in our day-to-day practice, and we need to talk to people about it. So I think, Asha, the stage is all yours.
Can you play the talk?
Hello, everybody. My name is Dr. Asha Kasliwal. I am a consultant based in Manchester in UK, and I'm also chair of the Contraception Committee for FIGO. Thank you very much, Rishikesh, and your committee for inviting me to give this talk today. I am going to speak about contraception for gynecological care. So I'm not going to read this slide, but this is some of the work that I do. For this talk, I have no conflict of interest to the care. So this is what I'm going to cover in my talk today. So I'm going to talk about some of the non-contraceptive benefits of contraceptive methods, focusing on gynecology and various gynecological conditions. You all may be familiar with the Palm-Cohen classification of abnormal uterine bleeding. This is a FIGO classification. This is very commonly used, and it's really self-explanatory if you haven't heard of this before. But I'm going to use this classification to talk about how we could use contraceptives for managing common gynecology conditions. So the PALM is polyp, adenomyosis, leiomyoma, malignancy and hyperplasia, and Cohen is coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and not yet classified. So let's use this classification to give a bit of information about how we can manage some of these. So let's start with endometrial polyps. Most polyps are benign, as you all know, and less than 5% are pre-malignant or malignant. Having said that, of course, it is really important that for the symptomatic patient, surgical management is used. All of us have anecdotal cases, don't we, where we weren't expecting a young patient with a polyp, we weren't expecting it to be pre-malignant, and it turns out to be. So it's really important that we don't use contraceptives for managing polyps routinely. For symptomatic patients, surgical management remains key. However, hormonal contraception is an option for treatment in asymptomatic women. And what are the treatments? Combined hormonal contraception can be used. The levonorgestrel IUD, for example, the Mirena, I know it is available in India, although the other lower progestogen ones aren't. And of course, you could use oral progestogens. In those with sessile polyps, resolution is common, but the pedunculated ones are harder to treat and may need surgical intervention. Progesterone treatment can be given in luteal phase for 7 days, in the luteal phase for 3 months. The study that I had put on the previous slide, it showed a 47% resolution versus 12.5% in the control group. So quite effective, just giving progestogens in the luteal phase. And of course, there is a role for hormone therapy after hysteroscopic management to prevent any further growth. What about adenomyosis? So hormonal contraception is very, very helpful to manage adenomyosis. Pain, bleeding, as well as uterine volume, all can be helped and can get affected. Dynogest is really good for bleeding control. There can be a bit of spotting, but it can help with the heavy bleeding. Combined contraceptive pills can regularize bleeding. It can even be used in a tailored regime. So you can give that continuously for good control, and even bicycle or tricycle, 2 packets or 3 packets together. The levonorgestrel IUD like Mirena is one of the top treatments for managing adenomyosis. It will help decrease the pain, blood loss, as well as the uterine volume. And large uteri with adenomyosis is not a contraindication for levonorgestrel IUD, because sometimes people worry that, if the uterus is 12 weeks, 10 weeks, 12 weeks, 14 weeks, should we try it? It is worth trying. If you don't achieve a proper fundal placement, you may, or in a very large uterus, you might want them to use, in addition, a different method of contraception. But for the management of the adenomyosis, it will still work. What about leiomyomas, fibroids? Hormonal contraception, again, is really useful for bleeding leiomyomas. Combined hormonal contraceptives can help with the heaviness of the bleeding and with the pain. And injectable contraception can also help with decreasing the uterine volume and bleeding. And the Mirena coil, of course, is a top choice again for fibroid uterus. But you have to bear in mind that if the cavity is very distorted, in the picture I have put there, it can be really difficult to fit a Mirena coil. And then, of course, the injectable or an oral route would be your preferred choice. Hence, a scan and identifying where the fibroids exactly are and checking out the endometrial cavity is really key to the use of a Mirena for fibroid uterus. Just a bit of caution here. Progestins have unpredictable effect on the uterine volume, so they may or may not reduce them fully. And I've already spoken about the distortion of the endometrial cavity, but also expulsion rates are much higher with fibroid uterus. However, if the fibroid is abutting the endometrium, or if maybe a little bit into the cavity, it is not an absolute contraindication. You could try, maybe even under ultrasound guidance. That is what we do sometimes, and check whether you are able to fit it in. Of course, if there is a large cervical fibroid, for example, then a Mirena is not really an option for managing the fibroid. Moving on, malignancy, of course, the primary strategy is surgical management. But even in endometrial cancers, those with, those who are maybe very old with multiple complex medical comorbidities and are not suitable for surgical management, they can be treated medically with hormones. Also, in some young women who desire to preserve their uterus, of course, you will discuss with them that the primary management strategy is surgical. However, there may be a role in some patients with endometrial cancers to consider other options. Hyperplasia is different. Hyperplasia is, of course, pre-malignancy, and particularly without atypia is very, very well can be managed with hormone management, with contraceptives. So Mirena IUD, a levonorgestrel IUD, can reverse hyperplasia both short and long term. So what we do is we fit the Mirena, we keep them under observation. In 6 months, we repeat an endometrial sampling and continue doing that 6 monthly for a couple of more biopsies. And we've seen excellent results with that for hyperplasia, particularly without atypia. And in levonorgestrel users, there are lower rates of hysterectomies compared to oral progesterone. So if you are choosing between the two, then your recommendation really would be to use a Mirena coil rather than oral progesterones. Okay, moving on to the Cohen bit of the FIGO AUB classification. So C for coagulopathy. So in women with bleeding disorders, combined oral contraceptive pills may increase factor VIII and von Willebrand factor. So that is useful. Levonorgestrel IUD is ideal for long-term use. A really good method because quite often these women have menorrhagia. And we tend to, the guidance from our national guidance from the Faculty of Sexual and Reproductive Healthcare is that an experienced fitter should be the one fitting the Mirena under these circumstances, and try to avoid a trainee fitting it, for example. But also we do that as kind of early on in the clinic, so that the patient can wait outside for half an hour. We monitor whether there is any bleeding from, where you hold the cervix for the fitting, and then patient can go home. So that is the care we take around fitting for women with coagulopathies. Women on anticoagulation can also be given progestogen methods Progestogen contraceptives are not contraindicated for women who have had VTE. Of course, you won't give them combined pill, but you can give progestogens and they can reduce bleeding problems. You can also give injectables, Depo-Provera or Cyanopress. And if somebody is on anticoagulation, then certainly we would recommend the subcutaneous injections. They can be self-taken, but the risk of bleeding is much less than having a hematoma at the site of a deep intramuscular injection. So if you're using injectables, and we do know that there can be initial irregular bleeding, that settles down to amenorrhea in most women by the end of the second injection. Implants can be used. I am less convinced about implants because of irregular bleeding in some women. Of course, it can cause amenorrhea in some women and can be helpful. If they are on anticoagulants, again, a pressure dressing, an experienced person doing the procedure, applying a pressure dressing is really, really important. What about anovulatory cycles? So, for example, in polycystic ovarian syndrome, cycle regulation can be very, very well achieved with the combined hormonal contraception. So taking the pill 3 out of 4 weeks, like we usually prescribe, will give regular periods which are less heavy and less painful because they are anovulatory. Endometrial protection can be achieved with a Mirena coil, injectable like Depo or Cyanopress, implant, rod, and also with oral progestogens. They can all provide endometrial protection. The combined pill has a really good role in particularly PCOS, because there is good evidence from the Cochrane collaboration database and other papers. A couple of them I have put on my slide, that it suppresses ovarian androgens and raises SHBG. So it reduces androgens in the body and can help with a number of things with the androgenic side effects, including acne and hirsutism. If you're giving a combined pill, consider a lower androgenic one rather than the first generation one. And the progestogens with anti-androgenic activity are like cyproteron acetate, which was in the Dianet. You could use Dynogest or drospirenone. And of course, use this with caution, because we do find that a number of women with polycystic ovarian syndrome struggle to lose weight, can have multiple risk factors. They could have cardiovascular disease, they could be, their BMI could be quite raised. And if it is over 35, you would use a combined pill with caution. So it's, of course, we are also mindful that the risk needs to be weighed against the benefits, because the risks that pertain to using it as a contraceptive may be different from using it for polycystic ovarian syndrome, a gynecological condition. What about dysmenorrhea? We do know that dysmenorrhea can occur due to a number of reasons. So we've spoken about adenomyosis, but sometimes ovulatory cycles are very, very painful. And the combined pill is such a good treatment for dysmenorrhea because it suppresses ovulation. So periods become regular, less heavy, less painful. Control of endometriosis is also, a combined pill is really good. What we tend to do with those is to bicycle or tricycle, so that they have a period every 2 or 3 months. We can sometimes also use a tailored regime for endometriosis. What we do is we say to them, take the combined pill continuously till you start getting breakthrough bleeding. Then give it a break of 4 days and then start it again continuously. And a recent Cochrane review showed that the continuous regimes are more effective. But of course, you can get the spotting, and some people can get side effects and may then want to discontinue. And the Marina, of course, Marina is a king method, isn't it? It can help with so many things. And it can help control endometriosis indirectly by helping the dysmenorrhea. Also, we have found that even though it's fitted inside the uterus, it can act in the pelvis. What about PMS and PMDD? Again, combined pill can be used. That containing drospirenone is ideal. Other contraceptives can also have a beneficial effect. For example, Clara, which contains ethinyl estradiol. There is currently no evidence that the progestogen-only pill can help. However, some people will try the progestogen-only pill, particularly those which cause anovulation, for example, SLIND, or something like Cerazette. These that cause anovulation can sometimes help, but there isn't good evidence really around that. That wouldn't be your first choice. What about prevention of cancers? Both combined pill and progestogen-only contraceptives are protective against endometrial cancer, and the effect can last for 10 to 20 years after stopping. So that is really, really good. And the Marina, of course, as you all know, can be used as part of HRT. It is licensed for endometrial protection for 4 years in Britain. However, its effectiveness, we know there is good evidence that it can last for 5 years. So although you would use it for as a contraceptive for 8 years in Britain, it's licensed for 8 years as contraceptive. It can be used for 5 years as endometrial protection. And for treatment of menorrhagia, we use it till the menorrhagia recurs. Prevention of ovarian cancer. It also reduces ovarian cancer risk. And very interestingly, it is seen even with women with BRCA1 or BRCA2 gene mutations. That was really interesting thing for me when I was researching for this talk. And progestogen-only injectables and implants also can, because they're anovulatory, they offer similar benefit of reduction of ovarian cancer. Of course, we are talking about the benefits here, so I am not talking about the increased breast cancer risk. So I have covered everything in terms of using contraceptive methods for gynecological conditions in my talk today. And I would be very happy to answer questions. Thank you very much.
Hi, thank you, Dr. Asha. Are you online?
Yes, very much so, Nandita. Thank you.
Yeah, what a pleasure to see you. And that was a beautiful talk. Just for the sake of everybody, can you just elaborate the benefits 1, 2, 3, 4? Everybody's heard your lecture, but if you could just highlight that point, I think it's very, very important.
Menorrhagia, contraception, of course, very, very great benefit, reliable contraceptives. Menorrhagia, dysmenorrhea, and cancer prevention.
I think it's very important that, especially when patients come, they are really worried, especially the PCOS patients, which I deal with, Asha. Young girls come in and the mother say, oh, we don't want to give them any medications and all. It's so important to be able to advise them and tell them what are the benefits and all. Question which I had was, it's a very large uterus, sometimes you see. So does the IUD Mirena, I mean, does it actually act as a contraceptive in that case?
It's a really good question, Nandita. It depends on where you are able to fit the levonorgestrel IUD. So sometimes we do ultrasound guided procedures, and if we have achieved a fundal placement, then you can rely on it for contraception. And the guidance here says that if it is within 2 centimeters of the fundus, so even if it's a little bit lower down, but if it's within 2 centimeters of the fundus, it can be reliable. However, sometimes you can't achieve a fundal placement, particularly it's kind of a different uterine shape with multiple fibroids or with adenomyosis. And in which case, but still fitted because the benefits are so great, but then they could use condoms in addition. It'll provide some benefit, of course, but not entirely. And then using condoms in addition would be a good idea, but it wouldn't stop me from allowing them to get the beneficial effects of this and sometimes even avoid surgery.
Yeah, I agree with you. But, I had this patient with multiple fibroids and we had done a Mirena insertion because she was not willing for surgery and stuff. But the Mirena got expelled. So what do you think is what is the percentage of patients where it does get expelled?
I think it's normally we quote 1 in 20 expulsions, and I think it is a bit higher in these women. But there are so many women who are still benefiting so greatly that it's worth trying. Particularly, saving the uterus, uterine preservation, because hysterectomies are major surgery, isn't it? With even though in today's world, they are common and they are reasonably safe, they're still major surgeries affecting your bladder and other things. It's preserving the uterus. If that is top of your agenda, then certainly it would be very helpful to try it.
Thank you. Thank you. And then the final question before we end this session, in endometrial hyperplasia, if you've put in a Mirena, what follow-up will you do for this patient?
Yeah, so endometrial hyperplasia is an interesting thing, isn't it? So we are not talking cancer. Cancer, I've been really upfront and said surgical management is top choice always if it's cancerous. Endometrial hyperplasia, as you know, can be typical or atypical. In atypical hyperplasia, very often if you did nothing, it can regress. But I mean, how many of us have the courage to find atypical hyperplasia and do nothing? If I always think, if it's my sister, my mother, it's me, what would I want? And I think it's difficult to just sit back. So if they are lower risk patients, we would do, for example, BMI is less than 35, etc. Is when I say no history of Lynch syndrome, low risk patient. We would fit a Mirena and repeat biopsy in 6 months and do it every 6 months till you get 2 negative biopsies. And then you can discharge the patient because they are low risk. But if they are high risk, then you might want to do an annual follow-up after that, just to be on the safe side. It could be a scan and a biopsy, because if you can see a thin endometrium, you're quite happy then. If there is atypia in the hyperplasia, then you might want to reconsider again their risk factors. But in some women with low risk factors wanting to protect the not have a hysterectomy, you could put a Mirena in. You would probably do 3 monthly in that case, and then annual once you get 2 negatives. Okay. I hope it answers your question.
Yeah, thank you, Asha. I think that's very important that follow-up is required. I feel whatever the guidelines say, I think we should do the follow-up because it's not worth that even 0.1% risk. Rajendra, do you want to ask her anything or do you want to?
Yeah.
The final question.
Finally, it was really a lucid presentation. I'm Dr. Sangpal, President of Mumbai Obstetrics and Gynaecological Society. I wanted to ask you, there are some conflicting reports about the Mirena intrauterine device. I had given a lecture on the intrauterine devices, and I saw one reference that the intrauterine device, especially levonorgestrel, it increases the incidence of breast cancer overall. So, and one of my patients, she had a breast nodule, and incidentally, before that, I had put Mirena. And she was basically, she was a doctor, physician. She asked me the same question, Doctor, this is because of, she had a nodule and which turned out to be a malignant. And she was asking me whether this is related to Mirena. And then I saw there are many reports, and in fact, all the medical legal issues have happened on the company based on the increased risk, 15 to 20% increased risk of breast cancer. That's what those reports were saying. What is your?
Yeah, so I agree. More and more recently, there are reports of increase in breast cancer with progestogens alone, not just the combined, not just estrogen with progestogen. So I totally agree with you, and you've raised a very good point. And incidentally, this morning, I have sent off for publication a statement on breast cancer risk and hormonal contraception to the IJOG, the International Journal of Obs and Gynae. So I have, it's quite interesting and coincidental. So it is always, there is a small risk. It is in 15 to 20%. Or the studies are showing much lower than that. But what we didn't realize before was that we thought progestogens are relatively safer. So we know now that there is a slightly increased risk that needs to be weighed against the benefits. And also, what is your background risk? So if your background risk is high, then the absolute risk will increase because it's a question of relative risk. It isn't as high as 15 to 20%. And also on the other side, you have to balance it with the protective effect on the endometrium. And other things like if it's anovulatory, then the protective effect on ovarian cancer, which is a much harder cancer to diagnose and treat. So it is about a balance, and that's what we've written in our paper today, which we've given for publication. So yes, there is a risk, and we need to acknowledge the risk benefit whenever we talk to the patient.
Yeah, thank you.
Asha, if we talk about the risk, patients will just refuse it.
We don't find that because we talk about risk benefit, and we find, we here increasingly we are finding, that patients are very keen to have minimal kind of invasion and be treated with things like this. So that is, our experience is slightly different. And also as HRT is gaining momentum, because menopause is kind of one of my pet subjects, and we are finding that using it for endometrial protection is increasing. And we are careful to say to them that combined HRT increases breast cancer risk. But this doesn't lower it, but it lowers endometrial cancer risk with HRT as well.
So what I have modified into my practice, patients who are more than 40 years of age group, patients who have family history of breast cancer, especially in sisters or a mother or a grandmother, and patients having already a nodule in the breast. I mean, those I feel sometimes I exclude those patients for Mirena insertion.
And I would kind of agree to disagree, because if somebody has benign breast disease, there is no evidence that that leads to breast cancer. In our country, it's 1 in 8 breast cancer risk, but worldwide it is 1 in 13. So as we grow older, all of us have a breast cancer risk. In Britain, it's 1 in 8 anyway. But family history, I would agree with you that you have to tread with caution. At the same time, it is a risk-benefit ratio as always, and the risks are small.
Thank you. Thank you so much, Asha. And thank you, Rajendra, for bringing up that point. I think it was very relevant, this conversation and this discussion, because it's important to, counsel the patients. So thank you very much. We've had a very enlightening session and we will end this session now. Thank you.
Thank you.
Thank you.
Thank you so much. So I would like to thank all the speakers and our chairpersons for chairing the session. We move ahead to the next session now. For the next session, I would like to invite our chairpersons. That's Dr. Nandita Palshetkar, Dr. Hima Divakar, Dr. Priya Ganesh Kumar, and Dr. Shantanu Prabhu. So our chairpersons for the upcoming sessions, and it's a pleasure to see so many people online worldwide. I would also like to let our viewers know any questions if you would like to ask to any of the doctors, please ask in the chat box and we try to address them all. Over to our chairpersons to invite the next speaker. Thank you.
Hello. Can you show me the CV? So we are starting the next session. And who else to introduce? Dr. Rishma Pai, she's the chairman of this International Summit of Women's Health and Rights. And she is a consultant gynecologist and president-elect of the IFFS. She's attached to Leelavati Jaslok Hinduja Hospitals, Mumbai, and the past presidents of FOGSI, ISWHR, and IAGE. So Rishma is going to talk on ART in PCOS. Can you play the video?
Hello. It's a pleasure to participate in this International Summit on International Women's Health and Rights. I'd like to thank FIGO, FOGSI, MOGS, and of course, Dr. Rishikesh Pai for this invitation. Today, I'm going to be speaking on a very important topic which affects all of us day to day. Let me begin by saying the challenges are what makes life interesting, and overcoming them is what makes life meaningful. And one of the most important challenges we as gynecologists face in our practice is that of PCOS, and of course, all the associated problems of infertility, particularly when these patients want to undergo specialized IVF treatments. And so today we are going to be focusing on ART in patients with PCOS. We all know that 8 to 13% of reproductive age women have PCOS, to some degree at least. And it's the most common cause of anovulation, affecting up to 80% of women with this condition. The diagnosis, of course, is Rotterdam criteria, and all of us are well aware of it. But there are many other features which we don't focus so much on. The obesity, the metabolic syndrome, mood disorders, such as anxiety and depression, and of course, infertility, which is a huge component of this problem. So PCOS, as we know, the physiology behind this problem, these women have high levels of anti-Mullerian hormone, and with the granulosa cell having a 75-fold increased production of AMH, and even the serum levels are extremely high compared to their ovulatory counterparts. And you know the given negative regulatory effects of AMH on FSH signaling, then there is a negative development of the follicles caused by AMH. And so elevated AMH is one mechanism which actually precludes cyclic follicular development in this group of women. These mechanisms, along with the effects of insulin resistance, hyperandrogenism, all of these contribute to anovulation and infertility. And even when they do ovulate, these women are at higher risk for infertility due to oocyte quality issues and, of course, reduced endometrial quality. So many different factors impact fertility in women with PCOS. So what is the treatment that we can do? Obviously, we go step by step. We start with ovulation induction with letrozole, which is the first-line treatment. We can combine it with intrauterine insemination or just go ahead with planned relations. If that doesn't give us results, we can add gonadotropins and go ahead and do an IUI. Laparoscopic ovarian drilling is rarely done nowadays in very few select cases. And of course, the last resort is IVF for this group of patients. The patients who are treated with letrozole, they definitely have a higher pregnancy rate and live birth rate compared to those treated with clomiphene. But whether a patient will continue with ovarian stimulation cycles, keep on doing the same thing over and over again, or go ahead and do IVF will really depend upon her desire, the value system, her risk tolerance, the expenses involved, the age of the patient, ovarian reserve, and so many other factors. So eventually, if the basic treatment of letrozole, IUI, gonadotropin IUI doesn't succeed, she may have to go on to IVF. So once the patient decides to go into the IVF process, we should do good preparation. So what is the pre-ART preparation we need to do? It's important that all her pre-existing medical issues should be addressed. We should really plan how to achieve best ovarian stimulation and the trigger to use. And of course, we have to address how to best prepare the endometrium for implantation and pregnancy. And so with this in mind, we can really go ahead. The preparation of IVF involves lifestyle modification, cycle priming, and the use of various adjuvants in certain cases. We all spoke about the metabolic syndrome, and this, all of this causes the patient to have insulin resistance, excess weight, hypertension, hyperlipidemia. And so we should focus on this prior to starting her on the ART journey. One of the main problems is insulin resistance, and we can test this with a simple glucose tolerance test. An important issue, and all of us are well aware of this, is weight and its relationship to insulin resistance. Knowing fully well that even a 5 to 10% weight loss in PCOS patients can lead to a resumption of normal ovulation. So if the girl is overweight, she has a 69% lower pregnancy rate per cycle start and a 71% lower live birth rate compared to the lean PCOS patient. So this is how important weight is in this group of patients. And recently, we've had these wonderful international evidence-based guidelines for the assessment of management of PCOS. They came out very recently in 2023, and we will bring up some of these guidelines during my talk. And these guidelines suggest that women with PCOS should definitely be counseled on the adverse impact of weight. We should tell them about an entire reproductive life plan, right from a young age to menopause and beyond. The implications of PCOS should be explained to them. We should definitely avoid weight stigma, but we should very, gently and sensitively approach this topic of weight. And of course, manage their other conditions like diabetes, high blood pressure, depression, anxiety, which many of them suffer from. Very often, these patients have irregular periods or amenorrhea for periods of time, and we often give them oral contraceptive pills to bring on the periods. But if they are been given OC pills prior to an IVF cycle, the results are inferior. And so it's better to let them have a natural menstrual cycle, natural periods, the results will be better, or maybe give them some progesterone if necessary to bring on the periods rather than OC pills. Adjuvant agents are very often used in patients with PCOS, and one of the commonest ones is myoinositol. This is a natural insulin sensitizer, and large meta-analysis, and many of them have shown that the use of myoinositol, pregnancy rates are better with lower gonadotropin amount. So the dose of gonadotropin reduces. Another drug which is now being talked about is melatonin. And we know it's an essential regulator of circadian rhythm. It's also a key in obtaining good oocyte quality. It works as a free radical scavenger, and this helps mitigate the effects of oxidative stress. And so with all these benefits, the PCOS patients who have disruptions in melatonin signaling, they benefit. So if you add 2 milligrams of melatonin, you'll get better mature oocytes with better pregnancy outcomes. So a combination of folic acid, which we give to all our patients who are trying for pregnancy, along with the myoinositol and melatonin, it may be a promising adjuvant for this group of patients. And in fact, there's this very large position statement which has come out just now, along with the Polish Society and the International Scientific Association for Support of Medical Technologies. And all of them have made this position statement saying that myoinositol is being considered as a potential pre-treatment strategy prior to ovarian stimulation with gonadotropin. So definitely a role to play for myoinositol and these adjuvants. Another very important insulin sensitizer which we use in PCOS patients is metformin. All of us have good clinical experience with metformin because they are a very attractive adjuvant. The OHSS risk, the hyperstimulation risk is reduced. There may be a little bit of weight loss achieved. So there are benefits. However, if this metformin actually improves pregnancy rate and live birth rate, we don't really know. There's no significant proof of that. But particularly in patients using a long GnRH analog protocol, metformin definitely helps reduce the risk of ovarian hyperstimulation, may reduce miscarriage rate. And so in this protocol of long GnRH agonist, we should definitely use metformin. It has a role to play in this group of patients. The addition of LH hormone, definitely not recommended. It has been found that PCOS patients are very often deficient in vitamin D, and this has been linked to abnormal metabolic outcomes in this group of patients. So definitely higher live birth rate for patients who have normal vitamin D levels compared to the deficient group, and less ovarian hyperstimulation with vitamin D supplementation. So simple change of vitamin D, supplementation, improving their levels helps these PCOS patients. So we know that like the seasons, medical therapies are constantly changing, and we have to change along with it. So our therapies have to be constantly updated. So when we start doing IVF in PCOS patients, what are the drugs and protocols that are being practiced today? What is the scientific proof behind these protocols? So as far as downregulation is concerned, there has been a change. All these years, long GnRH agonist protocol was used in majority of the IVF cycles. But in patients with PCOS, there are many meta-analyses. This recent one with 10 RCTs has definitely confirmed that with the use of GnRH antagonist protocol and GnRH analog trigger, there is much safer outcomes. The incidence of ovarian hyperstimulation is significantly reduced. Of course, there may be slightly lesser oocyte number, but the pregnancy live birth rates are similar. So a much safer protocol is to use GnRH antagonist. We can also use the newer protocols of progesterone-primed ovarian stimulation. So you can start with progesterone instead of GnRH antagonist, and you'll get similar downregulation of LH, lower ovarian hyperstimulation, but maybe slightly higher dose of gonadotropins is needed. This is one area where the role of minimal or mild stimulation is important. So mild ovarian stimulation really means 100 to 150 units of gonadotropin right from the beginning of the follicular phase to prevent the LH peak. And this protocol definitely reduces the incidence of ovarian hyperstimulation, reduces the incidence of gonadotropins, and of course, since the eggs are less, there may be higher cycle cancellation. But pretty good outcomes with the use of mild ovarian stimulation, low dose of gonadotropins. What about minimal ovarian stimulation? According to ISWHR, we can, using minimal ovarian stimulation, you just get about 2 to 7 oocytes. So start with either letrozole or clomiphene, add a small dose of gonadotropin, 150 units from day 7 of the cycle. And you can see a significant decrease in gonadotropin use, in the incidence of OHSS, obviously less number of eggs, but eventually outcomes are good. And so minimum ovarian stimulation with small dose of HMG may be one of the most optimal methods in PCOS patients. So good outcomes, less risk, less cost because of low gonadotropin use. And even the American Society of Assisted Reproduction has said that, 150 units of gonadotropin or less is mild stimulation. So minimal stimulation IVF definitely is a very good option for PCOS patients, especially if OHS's risk is excessive or the cost, has to be reduced. And this whole thing makes IVF more patient-friendly, affordable, and more accessible. So this is one area where minimal and mild stimulation has a good role to play. But remember, the body weight is very important in adjusting the gonadotropin dose. There's no one size fits all because, FOGSI has also said 150 units of gonadotropin is good in high responder patients, but the dose has to be individualized because the excess weight affects the ovarian response to gonadotropins. LH and AMH level are lowest in the group of patients with body weight over 70 kg and highest in the group with weight less than 50 kg. So there is a cutoff, 53 kgs and 70 kgs as the cutoff values to predict the initial gonadotropin dose. So keep it less than 150 or go to 225 based on the weight. So keep the weight in mind when adjusting gonadotropin doses. Remember that obesity may impair the response to ovarian stimulation because AMH levels are significantly lower in the obese PCOS compared to the lean PCOS. And the ovarian sensitivity index is proportionally decreased along with the BMI increase. So there's an inverse relationship. And body fat definitely affects the peripheral distribution of gonadotropins and their dosage. And obesity also impacts oocyte quality. So in many ways, the obesity is a negative factor when the patients with PCOS are undergoing IVF. And not only that, the HOMA insulin resistance, that is associated with decreased ovarian sensitivity. Normal range should be 2.1 to 3.8. And when it's worse, then this group of patients definitely has poorer response because the ovarian sensitivity index is a better representation of ovarian response than the number of oocytes that you get. And so the initial gonadotropin dose was, always calculated based on age, BMI, ovarian reserve. But when you add HOMA insulin resistance score and you can adjust the gonadotropin dose, the value of the ovarian sensitivity index is increased and the outcomes may be improved. So adding HOMA IR is also an additional benefit in planning stimulation in this group of patients. So once you've reached this stage, what is the type of gonadotropin you should use? It's a very nice recent study in 2024 itself, which compared all the types of gonadotropins, the FSH, the HMGs, and they found no statistical difference in the fresh cycle clinical pregnancy rate. So eventually, whatever the gonadotropin you use, the outcomes are going to be similar, but it's a possibility that the highly purified HMG may have a small advantage because of the lower risk of OHSS, good number of embryos, cost is slightly better, so that may be a choice. In fact, now the whole planning has become pretty mathematical. Using BMI, FSH levels, basal FSH levels, basic LH levels, AMH, AFC, and the luteal FSH, you can actually calculate the initial FSH dose. So using these parameters, put it on a graph, you can get a number at which the gonadotropin dose should be started, whether it should be 150 units, 225 units, or whatever is the recommended dose according to this normogram. Once the stimulation achieved, very important in this group of patients to plan the trigger methods because we know there's a very high risk of ovarian hyperstimulation in this group of patients. So if you use a GnRH analog trigger compared to HCG trigger, the risk of OHSS is substantially reduced. However, remember, you have to adjust the luteal support if you give a GnRH analog trigger because, small dose of HCG or LH when you add, you'll get much better implantation and live birth rate. So it's best and safest to give a GnRH antagonist downregulation, GnRH analog trigger, and then retrieve the follicles. In fact, the segmentation technique focuses on this, and with this you can get OHSS-free clinics. So agonist trigger in an antagonist protocol, freeze all the embryos through vitrification, and do a frozen embryo transfer to achieve an OHSS-free clinic. Once this is done, should we do fresh transfer versus frozen transfer? Now, we just spoke about segmentation, which encourages vitrification of all embryos. And there are many reasons behind this, because the altered hormonal milieu in PCOS patients, the higher androgen levels, the high estrogen levels, they're definitely negative to the endometrial receptivity and the implantation. And therefore, frozen thaw embryo transfer gives you better outcomes. Also, the freeze-all strategy has shown in many studies to lead to a higher live birth rate, lower miscarriage rate, and of course, lower ovarian hyperstimulation rate. And so whichever way you prepare the endometrium, natural cycle or letrozole or stimulation, whichever way you prepare the endometrium, eventually outcomes are more or less similar. How does the outcome of PCOS patients undergoing IVF compare with that of non-PCOS patients undergoing IVF? So also obese PCOS compared to the lean PCOS. It has been found that, when you compare the lean with the obese, the BMI cutoff of 25, and this very large study in 2023 showed that lean PCOS phenotype is associated with a significantly higher live birth rate compared to the obese counterpart, 61% versus 54%. So significant, the lean PCOS have better outcomes because the miscarriage rates are significantly higher amongst the obese PCOS. And so that is one major reason for the live birth rate being better in the lean PCOS patients. And one of the prime reasons is also the disturbed follicular microenvironment in PCOS patients, because this really impairs the oocyte quality. So the follicular fluid and microenvironment has significant alterations in PCOS patients. There is a pro-inflammatory milieu, increased levels of cytokines, interleukin-6, etc. There's a heightened reactive oxygen species levels in this group of patients. Multiple microRNAs are dysregulated. Proteomic analysis actually shows changes in the pathways related to immune responses, metabolic perturbations, angiogenesis, and hormone regulation. Even metabolomics identifies disturbance in glucose metabolism. So collectively, these pathological outcomes may adversely affect oocyte quality, embryo development, and fertility outcomes. Even the group of patients with very high DHEAS, free androgen index, this also has an impact on the pregnancy outcome. So a higher free androgen index is associated with a decrease in pregnancy rate. So also high DHEAS levels, significant decrease in pregnancy outcomes. So make sure that all these are corrected prior to starting your IVF treatment. This may be all attributed to the influence of adrenal-derived DHEAS and the ovarian-derived free androgen index. All of this has a negative impact on pregnancy outcomes. A short mention of in vitro maturation, because in this group of patients, the use of this technology of in vitro maturation can come in useful. In fact, the evidence-based guidelines have said that IVM, of course, should be considered only in services with sufficient expertise. There are many areas or many IVF centers where there is not sufficient expertise for IVF. It's a difficult technique, and so you should offer it as an option only in women who've had severe ovarian hyperstimulation in the past, who are very, very high risk for OHSS, because IVM outcomes are definitely inferior to, normal ICSI procedures. So when the outcomes were compared of in vitro maturation versus conventional ovarian stimulation for IVF, it was found that only a small group of patients, who the IVM and ovarian stimulation resulted in comparable reproductive outcomes, was only in that group which had AMH of more than 10 ng per ml. So in most of the patients of PCOS, in vitro maturation gave inferior results, except comparable results when the AMH levels were very high. So so much effort we make, and finally, when the patient is pregnant, even the obstetric and perinatal outcomes are unfortunately not as good as in a non-PCOS patient. The adverse effects of PCOS on general perinatal outcomes, especially when the patient is obese, are significant. You know, gestational diabetes, hypertensive disorders, preterm birth, macrosomia, all of these are common. And not only that, a higher risk of ectopic pregnancy following fresh embryo transfer, significantly high, 7% versus 2.4% has been observed. So that's one more reason to do frozen thaw embryo transfers in PCOS patients. So the patients who really, do not have weight loss, who are quite obese, then that group of patients will eventually have poorer outcomes and will have a higher cesarean section rate compared to the lean PCOS patients. So let me end by saying that PCOS may slow us down, but it won't stop us from reaching our goals and dreams. And that is to give every patient, irrespective of their PCOS status, a healthy child at the end of the day. Thank you. Thank you very much.
Hello. Thank you, Rishma ma'am, for the enlightening session on PCOS. Now we have a few questions for you, ma'am. So we'll have Dr. Rishma on stage. It was a wonderful session which helped us all know and go into the depths of the PCOS and the ART in them. We have a few questions for you, ma'am. Firstly, you had a few slides on weight loss management in PCOS. So do you recommend just the normal physical activity, or are you in support of the medications for weight loss, ma'am?
Thank you, Shantanu. We all know the interrelationship between PCOS and overweight and obesity, and the poorer outcomes, poor prognosis in patients who are overweight, particularly BMI more than 25. Their results are poorer, success rates, IVF pregnancy rate, and then the subsequent obstetric complications are much worse. And so we know that even a 5% loss in weight can have significant improvements in outcomes in PCOS patients. So for weight loss, everyone tries a lot of things. Everyone starts with diets and exercise, calorie in, calorie out. But we all know that PCOS patients find it extremely difficult to lose weight. And so the addition of metformin very many times, sometimes even inositol, mannitol combination, may help the patient to reduce a small amount, maybe 2 to 3 kgs of weight. But to achieve better weight loss is really difficult. Fortunately, we now have significantly, good results being achieved by newer drugs like semaglutide or tirzepatide. And these drugs, oral or injectable, will actually help patient lose 2-digit weight loss, so 10, 12, 14 kgs of weight loss. And this is really giving dramatic outcomes in terms of a lot of PCOS patients are conceiving themselves even without requiring any treatment. The only precaution to be taken, of course, is that these drugs all come with some side effects. So make sure the patient is explained well about the nausea, vomiting, constipation, diarrhea, and very rarely more serious side effects than that. And that after the patient has achieved the desired weight loss, then to possibly give at least a month or 2 of gap period when they are not on any medication before they actually plan the pregnancy, because we don't want them to become pregnant on the drugs. And so we have, fortunately now, a basket of choices, which we didn't have earlier. Because earlier it was either simple therapy or directly bariatric surgery. And now we have good medical therapy in between. So I think it's very individual what each patient needs, what is a medical situation. A lot of them have a lot of medical problems as well, hypertension, diabetes, and these drugs may help them solve a lot of those problems as well.
Thank you, ma'am. And we have another question. It's like you recommended HMG for stimulation of PCO patients. Is it universally, or is there any select group of patients where you still prefer recombinant FSH over HMG for stimulation?
So this is, all these years we did believe that because PCOS patients have high LH typically, we should go only with FSH. And there are now lots of studies, including a very recent Cochrane review, I think it's 2024, saying that whichever type of gonadotropin you use, whether you use recombinant FSH, whether you use a highly purified gonadotropins, or you use highly purified HMG, the results are pretty similar. And when I say results, the clinical pregnancy rate, twin rate, multiple pregnancy rate, live birth rates, miscarriage rates, all are comparable. And so we also have to consider many other factors, for example, the cost of the drugs and, the ease of usage and all that. But end result typically appears to be similar, whichever gonadotropin you use. The thing to do is avoid OHSS and ovarian hyperstimulation at any cost. And so once you really are following the segmentation technique, planning the dose of gonadotropins well, seeing the patient's AFC, her AMH, her BMI, and planning your dose, going slowly, monitoring well, and then giving maybe antagonist protocol with the agonist trigger and vitrification of all oocytes or embryos, and then frozen thaw transfer. Whichever the gonadotropin you use, I think that the outcomes are fairly good.
I think we don't have any more questions in the comment section. So thank you, Dr. Rishma. It was a very enlightening session. And we'll have the slide for the next presenter, please. Dr. Rohan Palshetkar. Thank you, ma'am. So our next presenter is Dr. Rohan Palshetkar. He is the professor at D.Y. Patil School of Medicine, and he's the head of unit of Bloom IVF Reproductive Medicine Fellowship Program, the D.Y. Patil School of Medicine chairperson, FOGSI Young Talent Promotion Committee, the first joint secretary of MOGS, managing committee member of MOGS, ISWHR, MSR, FOGS, YGA awardee of FOGSI Korayan, Kumut Tamaskar, Shanti Yadav, Praveen Mehta awardees, and MOGS Best Committee Member awardee. He is also the awardee for FOGSI Yuva Orator 2020, ISWHR Yuva Orator 2019, and MSR Yuva Orator 2019, and multiple publications in national and international journals to his name. So we'll start with his presentation. Thank you.
Hi everybody. Today I'm Dr. Rohan Palshetkar and I'm going to be talking about lifestyle modification, the need of the hour. So if we look at India, the prevalence of obesity is over 251 million people who live with obesity, out of which 31.6 million women and more than 25.4% men are affected by obesity, out of which 49.6 women and 28.8% of men are affected with abdominal obesity. So approximately 1 in 3 women live with generalized obesity and 1 in 2 women in India live with abdominal obesity. If we see, the prevalence of obesity has doubled from 2005 to 2020, and it's something that we really need to pay attention to, especially when we look about the fact that the number that obesity is linked with over 230 diseases or more all across the globe. We can see that obesity increases the risk of actually developing different obstetric and gynecological conditions in women, and you can see how they affect various parts of the body from head to toe. So what we need to do is try and tackle this very early. The same thing with obesity. If you look in women specifically, it causes infertility as well as cancers. It can cause urinary incontinence as well when we just look at the female reproductive system. Well, if you look at this study, which was published in Australia, it had over 1,544 schoolgirls who were followed up for 25 years. And what they saw was, if there is obesity between the ages of 7 and 15, they ended up having an increased risk of infertility more than anything else. Generally, we end up looking at obesity and PCOS together. And generally our treatments are more symptom driven. We're looking at either the menstrual cycle, trying to tackle their irregular periods. We're looking at the acne treatments for the increased acne. We're looking at lifestyle just for obesity, SSRIs for depression, and metformin. However, we need to look at these 3 major things and tackle them all together. If you can see, obesity leads to increased insulin resistance, hyperinsulinemia, as well as increase in the androgens due to this. And if you look at the hyperandrogenism, obesity causes, as you can see, hyperinsulinemia. The liver also reduces the SHBG. There's an increased pulse frequency and GnRH at the hypothalamic and pituitary level, which increases the LHI and FSH. There's increased ovarian androgens, and this all together causes hyperandrogenism, menstrual dysfunction, as well as ovarian dysfunction as well. If we look at weight loss, it improves the clinical features, the long-term metabolic health in women with PCOS. It basically, if you look at weight loss, it's going to reduce the insulin levels, it decreases the resistance and decreases the androgen levels. Menstrual cyclicity, ovulation and fertility all get improved with just a 5% weight loss, which I will come to in the next slide. When it looks at the psychological outcome, obviously a lot of these women are underconfident, maybe worried about how their body appearance is, and could even suffer from depression. In addition to this, it also reduces the risk of cardiovascular disease as well as type 2 diabetes as well. There's also a reduction of hirsutism and skin affections as well. We keep talking about 10% body weight loss, but just a 5% weight loss on clinical outcomes will just reduce the ovarian volume by 18%, microfollicles by 20%. Now remember, whenever we're doing these scans, we generally look at the bigger antral follicles, but now with AI you can see multiple antral follicles that could be there, and these can be picked up. The biggest I've seen is about 40 to 50 when the AI actually is able to map all the follicles. Improvement in the live birth rate in more than 25%. It improves the menstrual regularity. It also improves the spontaneous ovulation, and obviously by that the spontaneous pregnancy conception as well. So let's look at this new kid on the block, GLP-1 agonist. At least it's new in India. It may be been there in the market across the globe for a much longer period of time. How does the GLP-1 receptor agonist actually work? On the pancreas, you can see it improves the beta cell function, insulin biosynthesis, reduces the glucose-dependent glucagon. On the liver, it decreases the hepatic glucose production, increases the insulin sensitivity, decreases the lipogenesis and steatosis. On the brain, it basically what it does is it reduces the body weight by reducing the food intake and improves the satiety. It acts on the muscles by improving the insulin sensitivity, and these drugs are usually recommended for BMI of more than 30 kg per meter square or more than BMI of 27 kgs per meter square with a comorbidity. If you look at semaglutide, what it does is it basically reduces the hunger pangs and the frequency of cravings. It improves the satiety of the food intake and makes you feel full much faster, and this altogether reduces the body weight. I myself am on semaglutide 14 milligrams orally, and this has helped me reduce my weight quite a bit. As you saw my image at the start of my presentation and what I am today. When we look at the role of obstetricians and gynecologists, how is it going to be there? If you look at what WHO has recommended is 1 doctor to 1,000 patients. However, in India, the population rate is 0.62 to 1,000 in the private sector, and in the public sector, it's even worse where it drops to 0.09 to 1,000. How can we help as FOGSians to tackle it? We're a society of more than 45,000 gynecologists. This is going to reduce the burden of women healthcare in India. If we are also tackling obesity as well, it'll improve the doctor-patient ratio as well. Benefit of weight loss in various comorbidities is going to help us reduce the burden on the healthcare system as well. In India, we didn't really have any clinical practice recommendations. So under ISWHR, under the leadership of Dr. Nandita Palshetkar, we were able to publish this algorithm to optimize obesity weight management. It begins with anthropometric assessment, evaluation of obesity, then risk stratification, where the BMI cutoff is 23 in a country like ours, and then you can see the various grading of obesity, which begins from 23 to 24.9, which would be considered overweight, 25 to 29.9, which would be class 1, then 30 to 34.9 would be class 2, and more than 35 would be class 3. If we choose the treatment modalities, there's diet and exercise, which would be the first step. If these don't work out, then medical management, and semaglutide was the drug that we considered, because at that time tirzepatide had not come into the Indian scenario, but now that it's there, it can be included as a part of the medical management as well. And then last would be considered surgical management with the various indications that's noted. Please remember that all these algorithms are present on the ISWHR website, and they can be gotten there. You can see in which all special considerations where patients can and cannot be given semaglutide or tirzepatide for treatment. If you see tirzepatide, it acts on GLP-1 and GIP receptors, enhances insulin production. Let me just go to the next slide. It basically acts on the receptor, it basically reduces the appetite and calorie intake, reduces the intensity of cravings and preferences for the high sugar foods. It also basically improves your satiety. But the GIP receptors, they basically regulate the glucose uptake and modulate the lipid uptake as well. So why am I talking about these drugs? Because when you look at body weight and a body weight reduction in women, it has a variety of benefits. It's improving the risk of osteoarthritis. It decreases the severity of sleep apnea. Even non-alcoholic fatty liver disease, it improves the situation over there, improves the insulin sensitivity, reduces the risk of type 2 diabetes, or may also reduce the may cause remission of it. It lowers the glycosylated hemoglobin level, reduces the blood pressure, improves the lipid profile, lowers the cardiovascular risk in these women. When we look at women-centric parts, it lowers the androgen level, lowers the risk of breast cancer, improves the health-related quality of life, prevents PCOS, improves the fertility, improves the ovulation, improves the stress incontinence, lowers risk of dysmenorrhea, and also lowers the risk of certain gynecological cancers. Now that I've spoken so far about women's health, we have to understand we as doctors don't really end up looking at our own health as well. So why do we need lifestyle management? Doctors face high rates of burnout, stress, and non-communicable diseases. There's long hours, erratic meals, lack of sleep, and emotional fatigue is extremely common in doctors. According to the IMA in 2023, 32% of doctors in India report moderate to severe burnout. And WHO itself has recommended self-care practices for all the healthcare professionals as a core strategy to ensure long-term health system resilience. This was a small study which I went through, which has been published. It's a study in Delhi NCR. It's a very small area, but 75% of doctors had reported alcohol use, not abuse. 42% are physically inactive, 15% smoke, 40% have abnormal cholesterol levels, and 5% are undiagnosed disease, and over 44% were obese. So we as doctors need to set an example for our patients before we can actually counsel them. So what are the common lifestyle pitfalls in doctors? We have prolonged OPD, surgical hours without breaks. We don't concentrate on our food habits. We are irregular. Generally, as soon as we're done with OPD or we're done with surgeries, at that time we realize we've not had our meals, so we'll try and take in the first thing that's available to us, which would be packaged food or fried foods. In India, at least, one of the most common foods that's eaten are these samosas, which are sort of like fried dumplings filled with potato, and that's why that could be one of the major reasons for our increased incidence of obesity. Sleep deprivation, I think we have terrible sleep habits, especially during emergencies and on-calls. Emotional fatigue, I think that's something we don't even talk about in our field. I think we are so empathetic, especially when we're looking at patients of obstetrics and gynecology, where we're dealing with premature babies, IUFDs, infertility issues, and that can take a massive toll on our health. And we do not take care of ourselves at all. We have delayed health checkups, unmanaged comorbidities, because they're not identified at an early level where they could be possibly prevented or tackled early before having any permanent solutions. Remember, you can't pour from an empty cup. So unless we don't set an example for our patients, it's very difficult to counsel them regarding it. So a practical lifestyle modification for doctors could be you do 5-minute stretches every 2 hours. While you're in the OPD, stretch, touch your toes, twist, turn, do some exercise that's going to improve your movements. Mindful eating. Please ensure that when you're leaving from work, from home, take some pre-packed healthy snacks. Keep hydration reminders on your phone. Put an alarm every hour so that you drink water. Delete Zomato and Swiggy. That is the food delivery services that are available in India. So if you have your Uber Eats or Grab Eats or whatever that's available, please make sure you stop, delete those. Make sure you are taking healthy foods from home, packing your lunch, so that even when you have a break, even after prolonged hours, you have something that's healthy that you can eat from home rather than having those snacks from your hospital canteen. Schedule your self checkups annually. Make sure you're vaccinated, especially with the adult vaccines. Make sure the annual screening is done. I know we recommend it for patients for patients once you turn 40 and above. I would say for doctors, we should try and reduce the age to 35. I think we lead a lot more high stress life. A tech detox, I think that's something we all need. Get off the screens, sleep hygiene apps, download whatever you need. Make sure that you have at least 2 hours before you go to bed away from the blue light. That's going to improve your REM sleep definitely. Mental wellness, that's something that we definitely need to pay attention to. Meditation, peer support, therapy if required. Why not? We need to be promoters of mental health, and we need to explain to our patients that it's okay to do it if we are doing it ourselves as well. So I'm just going to play this small video about my own weight loss journey. For me, it was a journey of 5 years. I did it with diet and exercise, and now over the last 6 months, I've started semaglutide to ensure that I can maintain it. But I'm honestly, I've always been able to lose weight, but never been able to maintain it. And this is something that's actually helped me. So I would genuinely, if anyone's suffering from obesity, feel free to reach out to me at any point of time. So thank you so much for a patient hearing. And I hope I've been able to give you all some good take-home messages which you can use for yourself as well as for your patients. Thank you very much.
Hello. I think we have had a fantastic two talks by Dr. Rishma Pai and Dr. Rohan Palshetkar. And nearly 3,000 plus people are logged on at present listening to the program. As you know, there are two halls that are there, and simultaneously the program is going on in both the halls. And I would now have a 10-minute tea break, and we'll be back at exactly 5 p.m. Indian Standard Time for the next session, which will go until around 9 o'clock. So, of course, at any given point in time, you can listen to only one hall, but those who have registered will be able to access this program for at least the next 2 weeks on the net. So that if you have missed out on any of the wonderful lectures that are being given by our speakers who are very experienced, you can easily access them. And I would also like you to remind you that the Cape Town conference is there next month from the 5th to the 9th of October. And I'm sure you will come in large numbers. If there's still time, you can go on the net, register yourself. The hotels are still available. And I'm sure you'll get a South African visa is very easily available. It is an online visa, and you can easily get it in 3-4 days time. So don't hesitate, come for the conference and have a great time. So see you soon in the next 10 minutes.
once again, we welcome you back and we go ahead with the next session. I would like to invite our chairpersons for the upcoming session. We have Dr. Shantanu Prabhu and we have Dr. Tanya Vijayan with us. And I would request our chairpersons to please invite our first speaker. Thank you.
So our next speaker is Dr. Narendra Malhotra, and he is going to be speaking on the topic of regenerative gynec, what is new. So Professor Narendra Malhotra is the Managing Director of Global Rainbow Healthcare and ART Rainbow IVF. He's the National Director of Ian Donnell School of Ultrasound and serves as a professor at the Sarajdev School of Science and Technology, Dubrovnik International University, and IMA. So we'll start with the talk. Can we play with the talk now?
Professor Dr. Narendra Malhotra. I'm sure everybody knows sir, though he's our mentor of many like mine. Sir is the past president of FOGSI, is our ISPAT, and just named the organization, and sir has headed it, and he's the managing director of Ujala Signals Rainbow Hospital, and he's going to speak on what is new in regenerative gynecology. Over to you, sir, for your speech.
A very good evening to all of you. Indeed, a pleasure to be here in Mumbai for this ISWHR beautifully organized. This is, of course, the last session, the fag end of the conference, and people are more outstanders and baggers, bag collectors and outstanding people in our conference forever. So what we're going to take you through very quickly is a huge topic called regenerative gynecology. And what's that? My objectives are that I'll try to tell you what are the advances, what are the new therapies, and what is the ongoing research in it. What is regenerative gynecology? It is the use of medicinal products which have a potential to heal the tissue and the organs which are damaged by age, disease, trauma, and to normalize these defects. And a gene therapy also comes in it, but we're not going to touch gene therapy today. We will discuss a little bit of definition, which I've told you, how its role is in cosmetic and aesthetic gynecology, which is the new branch, and restorative treatment, and finally reproductive health. So what causes aging is, of course, your genetics. It's all in your genes. Menopause, low estrogen status, repeated pregnancies and childbirths, smoking, obesity, weight fluctuations is what makes the difference on your body. This not only to the skin, to the organ. And this manifests in a woman as what we call as her unspoken problems, like an overactive bladder, fecal incontinence, pelvic pain, abnormal vaginal discharge, vulval vaginal itching not getting cured by any of your antibiotics, and a lot of cosmetic issues with the genitalia. And these are just not cosmetic, they are functional and regenerative. So we have a new specialty called aesthetic and regenerative gynecology. And we have a new organization called the Indian Association of Aesthetic and Regenerative Gynecology, which you all can join in. And that is my textbook, which we have come out in, Aesthetic and Regenerative Gynecology, and which will deal with all these issues. So it is a revolutionary field aimed at restoring, rejuvenating, and enhancing the structure and function of a female reproductive tissues. And that is what we call as her unspoken problems. So what is included in this? PRP treatment for all vulvovaginal rejuvenation, lichen, thin endometrium infections, which will show you, stem cell therapies, exosome therapies for vaginal atrophy, energy-based devices like lasers and anti-aging therapies, oral, intravenous, and the others. And what we can do with this: rejuvenate the vagina, rejuvenate the endometrium and Asherman's, treat all the benign vulval and vaginal disease, handle urinary incontinence without surgery, genitourinary syndrome of menopause, which is the most biggest problem which we're going to face now with the increase in menopausal women, dyspareunia, ovarian rejuvenation, and improving vaginal health. So what is the role of these? What we can do? You can do PRP, you can do exosome, and you can do stem cells in your way. And a whole lot of
things which can be done, right from the external genitalia, vaginal tightening, vaginal lightening, post-delivery rehabilitation, mommy makeover, clitoral augmentation, clitoral hood reduction, surgical, non-surgical, infections, vulvodynia, Botox in the vagina, Botox in the bladder, all that. The need is real. And the need is real by women. And if women need it, we gynecologists need to provide what they need. Of course, don't overpromise. So here we have, quickly go through that. The first thing which now women are asking coming is the vulval and vaginal problems, or what we call as the designer vagina. And this designer vagina term came in 1986. That was the first international conference in Singapore I attended. And there was a stall saying that designer vagina is there. Now, when there is aesthetic concerns about designer vagina, and these aesthetic concerns are that you need to be well versed with the anatomy before you touch, cut, do energy, because there are a lot of vessels, a lot of nerves. And here is our good friend, Professor Red Allensod, explaining all this in this wonderful webinar which we had and the workshop which we had in Hyderabad. When a woman comes to me asking for a change in vulval shape or this thing, I show her this wall. Now, this is a normal, great vaginal wall made by John with a plaster of Paris in 100 normal women. And we tell them, if you got something like this, you're normal. If it is functionally disturbing you, then you need to do it. So designer vagina and the Barbie look, which has come into is alteration of the vulval and vaginal shape for functional reason, cosmetic reason, models wearing see-through clothes, walking on the ramp, don't want the mons pubis protruding, don't want the labia majora and minora to be looking through see-through. So that what the vaginal changes will occur because of physiology, age, functional, aesthetic. So remember that before we go in, all this has to be medically indicated and just not a cosmetic indication. How do we do it? Now, this patient came with such big vaginal lips, which were not letting her wear see-through clothes or bikinis, and you can do a surgical reduction with labioplasty and give her a normal look with the no overcutting. And if you do it only for cosmetic reason, it may come as genital mutilation also, because you're cutting a normal tissue or a normal genital. Then what we can do is put in what we call as a vampire vaginal injections. You have all heard of a vampire facial. Maybe a lot of women have undergone that, where PRP is injected into your wrinkles, into your face, and make it shine bright and make you look 10 years younger in one sitting. Similar things can be done by the patient's own blood, and the PRP is made meticulously, and 5 to 6 ml is injected into various areas. Where it will help is in the genital urinary syndrome of menopause. And that is where the dryness, the burning, the lack of lubrication, discomfort, pain, impaired function, urgency, dysuria, all can be handled by these simple things, or what we call as the atrophic vaginitis, which is GSM. And what treatment you have? A lot of infections which don't get treated by any method. You need rejuvenation therapies. Like infections like this, all these are cases which we've held and done by regenerative medicine, by doing laser and by then injecting PRP and exosomes in these areas for rapid healing. All these wrinkle removals, problems, episiotomy scar which is painful, redoing the episiotomy scar, redoing surgeries, genital ulcers like this. This was methotrexate injected ulcers. Methotrexate doses were given for ectopic in very high doses, and she landed up to us with this. What was interesting was pruritus any, and this is indication not come anyway. We and Dr. Leela from Jaipur and did it in a workshop, and you see those laser patches which you have done, and then injected PRP. Now we are doing it with exosomes. Here is how you inject PRP. So you take the area where is there, you make the PRP 3 or 4 ml. If it is SUI, it is injected 1 to 2 centimeters below the area of the urethral opening, and that will cause healing of this tissue, regenerative of the collagen and the muscular area of the tissue, and she is going to get used. This will treat I don't say surgery is not required. Surgery is required for grade 3, grade 4, severe, and followed by regenerative therapy. This is just going to reduce the symptoms, or a mild SUI or a mild problem is going to be treated. How does this work? It works by generating all the growth factors in that area. And this is what regenerative. The labial skin color, again, post-delivery, pigmentation, skin pigmentation on the labia, on the thighs, in the axilla, metabolic syndrome patients, PCO patients, all that can be again handled by the energy-based devices and by injection of PRP and exosomes. We have special laser probes for this, and the same machine which is used to do intra-vaginal can be used on the surface. A couple of days it will look like that, like patchy and dots, because it is fractionated carbon dioxide laser which is causing mini holes in that area, and then you smear it with PRP and exosomes. So what we call as a light scan for removal of wrinkles and for removal of the color change. Patients with vulvodynia, no treatment at all, and that 1 million cases are there. And here is a simple modality, which is the surface laser. And once you see that it is firing, the laser is firing in a rectangular way, we can fire it in the, there you see that laser is firing in the rectangular way in that area, and that regenerates that and makes that area better and more responsive to your drugs, and the pain and the touch problem goes away. Lichen, again, benign lesions of the vulva again can be treated similarly by these energy-based devices and by injection. So what we were doing for these lesions, injecting hydrocortisone, antibiotics, whole lot of things, and getting frustrated. You got to take a biopsy first, prove it is benign, then do the vaginal. The other thing which you can do with the same machines is use it as a scissors or a knife, and to use for all these huge number of benign problems on the vulva and the vagina which may arise. Surgical reduction, clitoral hood reduction followed with injections of exosomes, or this again with all PCOS patients will show you this, prove it is not hyperandrogenic, treat that medically and correct this surgical hood. And that is how we use the laser tip or the laser knife, what we call. And that's the laser knife being used for doing all the operations for that area. So that laser, and that same machine does it for you, which could be a diode or could be a carbon dioxide laser. So these are the regenerative treatments or therapies to improve the menopause. Then again, post-delivery, you have the vaginal relaxation syndrome. It is a reality, and it is a reality that women are going to face with this and have sexual dysfunction post-delivery. So in our vaginal delivery birth package, we have a laser treatment and a SCUI high-fem chair treatment for them. How do we do it? The laser machine is used intravaginally, and the PRP is injected in the areas. Can be done by the diode laser, can be done by the carbon dioxide laser. Whole lot of problems of women can be handled by these energy-based devices, where you had no treatment at all. How do they work? They cause photostimulation, they cause heating, aseptic wound, and whenever there's a wound, the body tries to repair with its repair cells, and those cells go there and repair that area and remodel the collagen below the epithelium. Causes no damage to the epithelium, no bleeding, no scarring, nothing. Or you can use the other device, which is the radio frequency, and the radio frequency works, the radio frequency waves will come here. You have the jelly, you can do it in the vagina on all the walls for vaginal rejuvenation and vaginal tightening and post-delivery rehabilitation. And for SUI, you do it in the SUI area. Then also on the external skin. Now this is done on the face also. A lot of you must have had radio frequency facials, which is very simple device where the radio frequency and the ultrasound is done on your face and the laser. And the same things can be used for the genital areas. So regenerative treatment by radio frequency. Now, radio frequency energy can also be delivered below the skin by micro needles. So we have micro needle radio frequency, and these needles go a little bit inside your skin, and the radio frequency is there, and so they work where you want them to work. Whole lot of indications, And that's what we've been doing with all these energy-based devices. The major indication is now SUI, because otherwise they'll go in for a surgery, and only if they are going to an expert like Prakash for surgery is the correct outcome. Otherwise, the tape and the TOT problems are there. Or if you tell them to do Kegels. Now, a proper Kegels is not possible. So either give them this device to do a Kegel master, or make them sit on the high frequency chair, which gives you 11,000 Kegels in half an hour. And that chair is there being demonstrated in the exhibition hall at one of the stalls. Please go and sit on this red chair and see how it works. One of the good evidence-based, proven to be results and documented scientifically that this is going to give some results where you're advising Kegels exercise. So mild prolapse, mild perineal weakness, mild SUIs, prostate in men, erectile dysfunction in men, all that this chair, just sitting half an hour, twice a week for 3 months is when you can see the results of such. Otherwise, the intravaginal laser is done like this. The machine comes with settings. Once we have set it, the robotic probe automatically measures the length of the vagina. And once it has measured the length of the vagina, see, laser will heat the water. So we don't clean the vagina with water or betadine. Only some oil is used. Otherwise, it will burn there. It will cause burns. And you see that the robotic probe is rotating, and that red light is rotating 360 degrees. You can set it only on SUI, where it rotates only this area, or you can do a complete. It's going in 1 centimeter each and firing the laser all around. And that is what the robotic carbon dioxide laser is, or what we are using. With this, you can inject just after the procedure, inject PRP or exosome or even stem cell preparation here if the problem is severe. So get an early results, and that is how it is done. What is exosomes? Exosomes are now available. It's a microparticle. They are available commercially, and they're not very expensive. And once there are 2 vials, 1 and 2. And once you dilate, you get about 5 ml of exosome solution. On the face, whole face rejuvenation, about 2 ml. In the SUI, only 1 ml. And whole vagina, 2 ml at various places. So that's how we prepare and what we are using as what we call as the regenerative exosome therapy for complete vaginal rejuvenation, for ulcers, for scars, for striae gravidarum, a lot of other things which I'll just show you in a second. So here is these patients. She had severe cervical erosion. Before doing a cautery or before doing a cryo, we have injected exosomes in her just 2 days before I came. And in the next period, I'll do a cautery to get the upper healing. So the healing starts from below, and hopefully we get very good results. A lot of multiple ulcers like this. She is pregnant, so we cannot use any lasers here. So we've just injected exosomes in multiple places at the skin. Skin infection not getting treated, well, loads and loads of dermatological diseases. The other where you can use all this regenerative is pregnancy, stretch marks, facials, warts, dark spots, skeloids, scar marks, evolving indication every day. Use it same for cutting, do for double chin, for nose contour, for breast contour, for abdominal contouring, for wrinkles, for dark circles, for crow feet, whole lot of things, and that can be done. Why should they go to a cosmetology or a beauty clinic? It's a woman, and women's health should be always in our hands. Next is stem cells. Stem cells will regenerate. You make the stem cells, and you can use it for thin endometrium. We are injecting it hysteroscopically under the endometrium with the ovum pickup needle, where the endometrium is patchy. And here is some of our data and some of our cases. That's how I'm doing it, and we run a training course for doing all this. And then with the ultrasound we have done, and so many of our cases are doing quite well. We still have to publish this because I'm waiting for a significant number so we can publish well. Ovarian rejuvenation, reversing menopause, which you can use. I was doing it laparoscopically because ovaries are very small, difficult to do ultrasound, but then laparoscopy by this needle we were doing, but then laparoscopy means an operation. So we've just started doing this about some 20-30 cases now. We are doing vaginally with transvaginal, and that's how we do. And see how the needle has gone just under the cortex. Be careful, withdraw it right up to the cortex and inject exosome. We're not yet injecting exosome because it's not cleared for intra-abdominal use. It's only cleared for skin use. But we are injecting PRP and a fresh made stem cells from it. We are also injecting this after removal of endometriotic cyst in the base of the endometrioma. So the healing is much better, the damage is much less. This is not over, so use it for all skin lesion, use it for hair fall, use it for inside the joints, for joint pains, use it in PROM, a very, very new indication for injecting stem cells and exosome and PRP inside the sac in leaking women. It seals the sac. But a lot of people will say it's a hype. And it's a hype. Yes, it may be a hype, but there is science behind a hype. And a lot of people say there's no evidence. Evidence will come only when we use it and we practice it. Who should be doing it? It should be the gynecologists, trained urologists, trained plastic surgeons, and very few dermatologists who are certified dermatologists, not a beauty clinic. In India, there are still no legal laws, but we have the ICMR guidelines, and the ICMR guidelines allows you to use unmanipulated stem cells, where you take out from the iliac crest, wash them and use them immediately, and not culture them or bury them. Lastly, artificial intelligence is like anything is going to help with us. So there is going to be some safety and ethical concerns. There is going to be a future to all this. It's personalization of regenerative techniques. It is combining regenerative medicine with AI, and it is innovating all these. So regenerative medicine, ladies and gentlemen, is here to stay. We are going to have a huge amount of emerging therapies to show various promises, but continued research is required. This is our association, the Indian Society of Aesthetic and Regenerative Gynecology. These are the office bearers. We started this in 2019, the only national society. The private societies are many, and private courses are many. But do join us to know more about this. Thank you very much.
Professor Dr. Narendra Malhotra.
That was a wonderful session by Dr. Narendra Malhotra. Can we have the next speaker presentation on the screen? Our next speaker is Dr. Prakash Trivedi. He's the honorary professor and head of department on gynecology and the past president of FOGSI and IAG, and a leading IVF specialist and endoscopic surgeon. We'll start with the presentation.
Comfortable. I'm going to talk to you about there are too many subjects which are very, very close to my heart. The closest to my heart is fibroid. And in this year, our research is going to come out, which will skip the need of surgical treatment in 60% of the fibroid. So it's already given to the company. I don't know why the company is taking time. But as a fact of the matter is, I was fortunate to do 55,000 surgeries, of which we did 32,000 laparoscopic myomectomy or laparoscopic hysterectomy with fibroid. And our entire research on fibroid and infertility got the Health Minister's Award and so many other things. And our technique, which I'm showing now, got surprisingly the AAGL, which banned sort of morcellation. I got the biggest breakthrough award in Vancouver at AAGL for the best breakthrough in tissue retrieval for fibroids. So you have to remember, I just recently finished PhD in numerology and Vastu. So these numbers, I don't know how my son or daughter-in-law picked up. But there are many ways in which you can remove the specimen. Some of the worst ways I would suggest is you widen the port size. My purpose is if you widen the port size, it automatically becomes a mini lap. I was talking to one of the famous film star, I cannot name, and I talked to the husband that if I was given a choice to remove a fibroid, whether I widen the vagina or whether I widen the umbilicus or I do with the in-bag technique, which I am going to show it to you. And in 2 minutes, he agreed, no, it has to be in a contained bag morcellation. So mini laparotomy, colpotomy is a poor man's morcellator for small fibroid. There are a lot of other things going on. And in India, we have experts who remove tonsil from the vagina. So big size uteruses are removed from vagina. So we will focus on conventional methods of practice. Now, conventional methods, there are two conventional methods. So you widen the port. You may do transvaginal extraction. And I always tell, it's like pulling an elephant from the tail. But believe me, not in India, but in Vienna and many places, expert vaginal surgeons remove so much of tissue vaginally. But that's not the purpose. What you can do doesn't mean it is safe for the patient. So it's not clear that while removing in this fashion, you are causing spread, and by widening this incision, you are losing the purpose of minimal access surgery. So this is if you are born abroad. If you are born abroad, then they will widen the umbilical scar or one of the port side scar. And very often I have seen people are very good in removing anything from anywhere. But my point is the bag gets punctured. You have made 4 ports for laparoscopy. Then you are widening the port, then widening. I remember once with Narendra, I think so, we were at an event and a workshop wherein the morcellator was causing a problem. So those are different things, but I have 7 morcellators in my OT. So this is the technique in which things are done. The popular technique in India is they will remove any damn thing vaginally. But you have to remember, if it is multiple fibroid, you cannot do a colpotomy in an nulliparous patient. But this is the way in which, it's like, it's an L-shaped removal. Tip is held, then you start resecting, keep pushing, and a long strip comes. Way back, a couple of years back, when I had a live workshop in Calcutta, with my morcellation strip itself, it was 1.5 centimeter, but 56 inches in length, a single strip. In the left side, what we are showing is that you can do a myomectomy and you can introduce a bag from the colpotomy and remove it from below. So that is the other method. This method doesn't guarantee you no spillage. There will be spillage, so you have to be careful. So on 14th May this year, we are going to complete 10 years of contained bag morcellation. This is what we had introduced prior to a major event in Bombay with AAGL. This is a Morcev bag which is available in 3 sizes, and we put it through, after separation of fibroid, we put it through one of the side port, which is 1.5 centimeter, and just the plastic trocar is withdrawn. The bag goes inside. Bag will have some amount of pneumoperitoneum, but at the same time, you open the mouth. Once we have standardized, I think me, my son, and there are a few other 100 people in India who do contained bag morcellation. So this was a patient from Australia, wherein she was told she had a nephrostomy done, and it was 11, 8 and 8 centimeter fibroid. So once you go inside, the primary tail of the trocar comes from your visual port. You start the pneumoperitoneum, so the entire thing is contained. So specimen weight 2.2 kg. Now this was, we have gone up to 2.45 kg. But I always feel that as an obstetrician, we know how to adapt and maneuver. Molding is not necessarily in obstetrics. You can do molding even in the bag. So you can gently negotiate and put a large specimen inside. I do remember once we had to use 2 different bags. Now, there are lots of people who always debate, once you have made an incision, you have already spread. The fact of the matter is, in leiomyosarcoma, the moment you do any surgery, already 50% spread is there. So this tail is railroaded back to the umbilical port. You take it out and you widen the incision. You are seeing the fibroid. Now I'm reinserting the trocar from the umbilical port. Once it goes inside, the whole stomach was inside and the mouth of the stomach was on the left side. So now you just create a pneumoperitoneum, and then once you go in, you find everything protected. I have done post in anesthesia for 6 months, and it also means that entire carbon dioxide used during morcellation doesn't go into circulation. So that is another advantage. We have used various morcellators, and we were fortunate that prior to the ban, we kept 4 morcellators of one company and 3 morcellators of other company, because I was pretty sure, and now on 15th May, we may, by the time our device comes, we will finish almost 2,800 patients. That left side, if you see, is a long strip, a single long strip, and that's the way in which the morcellation, it comes out. Now, as you can see, there is nothing which spills. This we are showing because your tissue blood is so much that it will spill otherwise in the peritoneal cavity. So the mini lap and all those things, all those modifications, this was around 1.8 kg. And then we tie a knot, and you can understand how easy our method is. We have trained plenty of people. The largest number in the world at present is with me, along with my son, and you can remove that. Now, this is 28-week size with plenty of fibroid. We have removed as many as 43 fibroids, 51 fibroid, and sometimes with an assisted mini lap, even 78 fibroid. So it is only that you have to be patient. Introduce one major fibroid in the, while you are inserting in the bag, you have to remove the head low position, because you'll keep the head low position, the specimen will slip upwards. So the assistant holds at 12 o'clock, you hold at 6 o'clock, and with one instrument, you guide the specimen inside the bag. And fortunately, in our 55,000 surgeries, we had only 3 cases of sarcoma. One sarcoma was on the psoas muscle with the nerve involved. One was a subserosal cavitary sarcoma, which we resected, and she didn't have any vascular involvement. And one which we ourselves decided that we will do straight away an open surgery. If you see in this, it's like a big egg with a yolk. With such big, you cannot even morcellate the specimen. So we tried with a spoon forceps. We tried with many things, and ultimately our good old suction and ovum forceps was useful through the port through which we removed. Now you remember, all this thing will spill all over the abdomen if you do naked morcellation. I appreciate people who do naked morcellation, but I appreciate those people who have tried in-bag morcellation, and sometimes they find that it is difficult. So moving further, as we go, another degeneration is, if you see, we find so many various degenerations which can take place. If you see over here, there is massive fluid degeneration. Fibroid itself are of 13 type. Once our research is published, you will realize that so many things now we know about fibroid, including genetics and many other things. And that's the reason why our device, which is coming in maybe 4 months' time, will almost prevent 60% of fibroid surgery for 6 centimeter fibroid up to 6 in number. That is our first trial, and then we will extend it. So here you are preventing the spillage of material anywhere else. This was an unusual case. One of our IAG president, Krishna Kumar, every time he gives me some unusual case. And he told there is a variegated mass and patient is not conceiving from 14 years. So I started operating and suddenly I realized that in the audience there was pin drop silence. Because nobody was asking me question, because normally we use a myoma spiral to stabilize a fibroid or a tenaculum type of thing. When I went ahead, I had only asked, on the same morning in the workshop, they had opened much simpler than this patient, which was done by somebody else, because the tissue was looking. I told if the color Doppler, and I trust, Narendra is sitting here, I trust a good color Doppler gives you a lot of information. MRI will give you information more with respect to endometriosis, but a good color Doppler is very helpful because at present there are no diagnostic modality which can take you to diagnosis of leiomyosarcoma. So we resected this area, and if you see, I'm using a atraumatic forceps. So it was posterior and anterior fibroid. So what happened is, I thought maybe posterior might be difficult. So I removed the posterior, then went anterior. But anterior also, when we inject dilute vasopressin, another important fact for fertility specialists, from 2012, we do ligation of uterine artery in all hysterectomies. Prior or in majority of myomectomy, and people have conceived within 3 months of uterine artery ligation. So that uterine artery ligation decreases fertility is the biggest myth in the world. On the contrary, it reduces recurrence. And as our friend Sailesh always tells, there are 9 uterine arteries. There are 9 branches. So you have to remember. So we removed this. And as you can see, when we removed this, we ultimately had specimen inside. You can't make out whether this is dermoid or whether this is sarcoma or whether this is fibroid or whatever it is. We removed this and it turned out to be 29th case of angiolipoma in the world. And when I was asking the film, then Kumar told me, I don't know what magic you do. Within 3-4 months, the patient was pregnant and she's gone to village. So we had done many surgeries at his place, as we have done all over India. And we ourselves believe what causes fibroid is not known. What causes infertility in fibroid is absolutely not known. So basically you have to remember when you're operating, when you say you're doing a minimally invasive surgery, do minimally invasive. This is a classical example. Laparoscopic hysterectomy done for multiple fibroids with morcellation, naked morcellation. And then we go back and we find that there are more uterus still left. It is not more uterus, but it is leiomyomatosis peritoni. There are so many leiomyomatosis peritoni which are there. So basically, we went ahead, then we removed all those individual fibroid, and post hysterectomy you have to be very careful because fibroid will take blood supply from surrounding viscera. So you can easily enter inside a bowel. So we separated all the fibroids which are here, and then we put it in a bag and we removed. Again, if you go for vaginal, this was a gynecologist. I remember prior to Bangalore conference, I had done a laparoscopic hysterectomy with appendicectomy. And my anesthetist told it was the most beautiful surgery I have seen. Then after some time prior to Bangalore AISWHR, she came and she told, no, sir, there is some problem. And during first surgery, on third day, she had peristalsis only on the left side. And then she told, sir, no, I am a museum, because in AIMS, after my cesarean section, I had bowel obstruction. So then when I did a repeat scopy with surgeon standing, only one port could enter. So with a blunt probe, I told there is only 3 cc collected low down. So we separated everything. She was fine. Then she came and she told that there are multiple masses seen. Because the specimen we had removed was vaginally. So again, vaginally keeping myoma cells, if you see, there are not only 1 or 2 fibroid, and I was very happy to see her in ISWHR in Bangalore. She was nice and hale and hearty and moving absolutely fine. So we had this one big fibroid. Then there were other 2-3 fibroids which came. So basically you have to remember that you have to understand minimal access surgery is a magic in your hand, provided you have compassion of patient care, provided you have completeness of care, and provided you have mastery. Now the vagina is open and you can see still there are fibroids which are coming. So obviously we removed all this fibroid vaginally and there was no problem. This is a very interesting case. A teacher, unmarried, 45, 46-year-old, and she was kept for a surgery from xiphisternum to pubic symphysis, exentration and removal of peritoneum, removal of everything. We went inside and in 1 second, even before I can utter, even my son told, this is leiomyomatosis peritonei. So we removed almost 50 fibroids and kept another 50 fibroids. We removed in bag and we told to the patient, the biggest news is, though we have kept 50 fibroid, your diagnosis is non-malignancy. So you don't have to worry because those fibroid were not causing any problems to her. So I think so, as you do more and more cases, your wisdom and now the important question, 160 meta-analysis revealed, as I told you, out of 55,000, we had only 3 sarcoma, of which 1 was of psoas muscle. So out of 55,000, so even a meta-analysis of 136,000 cases found that leiomyosarcoma was extremely rare. Vienna study of 71 cases of leiomyosarcoma backtraced. They found none were fibroid. And most important is, pathology textbook Novak current explains that leiomyosarcoma is a case of selective gene expression. Whereas fibroids are usually SMA, HMGA, we have done all work in the genetics, it is of some amount of gene expression. So no fibroid converts into sarcoma. We had removed this 47 fibroid, we removed 78 fibroid, and I will just mention a word about one of my late friend, Dr. Rakesh Sinha, who we both used to do sometimes an in situ morcellation. Now here what happens is, this is, I have finished almost. Saint lantern over St. Thomas, some word is used. So you have a big fibroid, on top of it the uterus is sitting. So we actually do morcellation of the fibroid in situ. In Japan, in fact, there is a study which says that it can be an ideal method to dissect large fibroid, which will give you better tissue plane. So this is again, I will not go into the entire detail of the surgery, but our current data is 3,586. Conventional morcellation we have totally abandoned. 2.48 kg size, 22 centimeter, 3.4 with dual bag, highest number of fibroid 51, 8 bag ruptures, of which 5 were with tenaculum, which didn't affect the surgery. And we had to cut, sometimes, you know, the bag get twisted. In bag, we had 1 calcified fibroid wherein we wasted 4 morcellators. So finally, to conclude, you have to remember, problems and difficulties aren't going to be solved by themselves, simply staring at them. We have to take a giant phase of leaf with your skill in your hand, with the vision, with the equipment, with the camera, with the morcellation technique, innovative solution, and move past the hurdle. Looking at the solution rather than the problem is the way forward. And I, throughout my life, have always liked, my numerology is exactly like Narendra Modi, but I like struggle, difficulty, and difficult situation, because a real genius is not born in crisis, but exhibits in crisis. Thank you very much for your patient ear.
Thank you to Dr. Narendra Malhotra and Dr. Prakash Trivedi for this wonderful session. And we'll prepare for the next.
So we are going to have a break for 15 minutes. The other hall is going on, so you can move on to the next hall and listen to the sessions and come back at 5 o'clock, 6 o'clock, 6 p.m. Indian Standard Time for the next session. In the meantime, you can have a break as well. It's very good news is that 3,700 have registered for the conference, and presently 1,900 gynecologists are online listening to the conference. And we'll be, of course, keeping this conference open for a few weeks from now, so that you can access the other hall or any other lecture of interest if you want to do it at your own leisure. Also, I would like to request you that the Cape Town conference of FIGO is there from the 5th to the 9th of October. And we are looking forward to a lot of participation from all over the world, especially from the Asian region. Thank you.
All right, welcome back, ladies and gentlemen. And for the upcoming session now, I'm going to invite our chairpersons, Dr. Rishma Pai, and we have Dr. Tanya Vijan. Welcome, ladies, and I would request our chairpersons to please invite the upcoming speaker. Thank you. Over to you.
Thank you. I hope you had a nice short tea break. And now we are going into a very interesting session in the second half of this conference. Our first speaker for this session is none other than Dr. Verda Hicks. She's the past president of the American College of Obstetrics and Gynecology, an extremely academic person, and her publications have been in some of the leading journals. So it's going to really be a feast to listen to her talk on something we encounter very often in our day-to-day practice, and that is the diagnosis and management of endometrial atypical hyperplasia. So thank you, Dr. Verda Hicks, for joining us, and over to you.
Thank you very much for that very kind introduction. And I want to add my sincere thanks as well to Dr. Pai for the opportunity to be here today, for the wonderful hospitality that you have shown each and every one of us, and your presence here today speaks volumes. So thank you so very much, for that. I am a GYN oncologist. I practice in the state of Kansas, in Kansas City. My state is a little bit to the west and a little bit to the south of Iowa that was just shown to you by Dr. Gelhaus. And I want to say thank you to Dr. Gelhaus because you have been a mentor as ACOG president to many of those of us who have followed in your footsteps. So thank you very much for that. I'm going to talk today about a clinical topic of atypical endometrial hyperplasia. I have no disclosures, and I hope that after this 20-minute brief talk that you will understand the definition of atypical endometrial hyperplasia and endometrial intraepithelial neoplasia. We will discuss its diagnosis. We will review current clinical consensus guidelines on treatment options, and then a brief discussion on prevention. And this material all comes from a recently published clinical consensus document by ACOG on the management of atypical endometrial hyperplasia, published in September of 2023. First and foremost, endometrial intraepithelial neoplasia and atypical endometrial hyperplasia are the same entity. Their definition pathologically depends on which classification system you use to give one subject title, endometrial intraepithelial neoplasia versus atypical endometrial hyperplasia. But this lesion is important because it is often the precursor lesion to endometrial cancer. So first big take-home message is endometrial intraepithelial neoplasia and atypical endometrial hyperplasia are the same entity. It just depends on which pathologic definition is being used. This is ACOG's look at what the pathologic definition is, comparing on your right a normal endometrium versus on your left an atypical endometrium. The atypical endometrium shows crowded glandular architecture as compared to the normal endometrium. You also see altered epithelial cytology, and you will see entrapped benign glands within the complex crowded glandular architecture. So this is the pathologic definition that we are looking for. And for the rest of my talk, I'm just going to call this finding atypical endometrial hyperplasia. An important also pathologic finding that we see with this entity is that it is not a uniform across the endometrial lining process, that you could have a lesion in the fundus of the endometrium as well as a lesion in the lower uterine segment or upper endocervix. And this will become important as we talk about surgical management of this process. The cause of atypical endometrial hyperplasia is really estrogenic overstimulation of the endometrium, which is often caused by unopposed progestins. And this results in first an hyperplasia, which can then ultimately change to atypical hyperplasia. Atypical endometrial hyperplasia expresses both estrogenic as well as progesterone receptors, and this becomes important when we talk about medical management of this process. So the distinction between hyperplasia and atypical endometrial hyperplasia is important, as each condition has differing cancer risk and interventions to avoid under or over treatment. Atypical endometrial hyperplasia is associated with pathologic microsatellite instability, RAS mutations, as well as loss of immunoreactivity to PTEN, PAX2, and the mismatch repair proteins, which we can see related to Lynch syndrome. So, warning and importance regarding the diagnosis of AEH. is that upwards of 30 to 50% of patients who have this pathologic entity will have a concurrent endometrial cancer at the time of diagnosis. 30 to 50%. And this is based on studies where preoperative biopsy of atypical endometrial hyperplasia was compared to final pathologic diagnosis at the time of hysterectomy, showing the high association with cancer and this diagnosis. So this is important because obviously our goal is to prevent endometrial cancer from occurring or to make the early diagnosis in the case that cancer is present. Part of ACOG's consensus recommendation regarding the diagnosis of atypical endometrial hyperplasia is the importance of the diagnostic sampling. So it is our recommendations that in order to have the best preoperative diagnosis to exclude a cancer is to perform a hysteroscopic evaluation and targeted biopsy based on the visualization that is seen at that time. So do not depend only on a office-based Pipel type sampling to attain this diagnosis. Our consensus recommendation is hysteroscopy with directed biopsy. So now we'll switch gears from diagnosis to talking about the management of this diagnosis, surgical and medical, starting with surgical. The consensus recommendation is if you have a diagnosis of atypical endometrial hyperplasia, that the primary treatment should be a hysterectomy. And it is very important, as we reviewed earlier, the pathologic findings of atypical endometrial hyperplasia, that a supracervical hysterectomy is not appropriate for this diagnosis because it may miss the lower uterine segment upper endocervical lesion that could be present at that time. Hysterectomy is the primary treatment and the #1 recommendation by our consensus station because our primary goal is, 1, to rule out cancer, and #2 is to prevent a cancer from developing. And by performing the hysterectomy, we have completed both the primary as well as the secondary diagnosis. Other surgical considerations when you start to think about hysterectomy for these patients are the decisions of salpingectomy and or concurrent oophorectomy. From ACOG's work on looking at salpingectomy at the time of hysterectomy, we do recommend salpingectomy to be performed at the time of hysterectomy for this diagnosis, as well as salpingectomy when you are considering hysterectomy for any patient who has completed their fertility. The decision to perform oophorectomy is much more of a shared decision process, particularly in the premenopausal or perimenopausal patient. And that discussion is also a very important part of maintaining the woman's health for the long term. We do also recommend at the time of surgery consideration of intraoperative assessment of pathology. But if you do not have immediate pathologic evaluation available, as well as the availability of GYN oncology consultation, then consideration of intraoperative assessment of pathology may not be appropriate and best to just wait for final surgical pathology evaluation. Another part of our consensus recommendation for atypical endometrial hyperplasia is that there is no role for endometrial ablation, whether it be thermal, radiofrequency, or electric cautery. And this is because of the high persistence rates that may occur with any type of endometrial ablation, as well as the potential difficulty of reevaluating the endometrial cavity should recurrent bleeding or other findings necessitating evaluation of the endometrium occur. So now we will go to medical management. Our consensus recommendations are that progestational agents as treatment are the primary recommendation medically if hysterectomy is not an option. Studies have found a very high response rate to progestational therapy. Depending on the individual studies, regression rates can occur 60 to 90% of the time. These are the current progestational agents that are recommended, as well as the regimens for the recommendations. We do not have a consensus recommendation of one of these progestational agents over the other. Looking at the data on superiority of oral versus intrauterine progestational agents, we do not have a very robust clinical background to say that oral versus intrauterine administration is superior. However, there have been studies that do show that improved regression rates with combined intrauterine and oral progestins may be more significant than the use of intrauterine progestation IUD alone. So we do have some evidence by this reference by Fang et al. Showing combined intrauterine and oral therapy may have the highest regression rate. Compared with systemic therapy only, adverse events using intrauterine progestational source are uncommon. And so patient adherence with intrauterine progestational agents have a much higher success rate with less systemic side effects such as weight gain and other medical complications such as with MEGACE, there can be increase in deep venous thrombosis related to oral therapy use. So from a consensus guideline standpoint, there is insufficient evidence at this time to recommend one formal oral progestational agent over another. Treatment follow-up. For those who are initially treated with progestational agents, reevaluation at 3 to 6 months after the diagnosis of AEH is our recommendation. And this is a table summary looking at response rates compared to recommended follow-up. If in the first 3 to 6 month reevaluation, a biopsy shows a complete response, then a repeat biopsy 9 to 12 months later, and to continue to reevaluate at approximately 6 to 12 month intervals, up to 24 months, can be followed. Hyperplasia with no atypia result at the initial post-treatment follow-up. Again, continuing to rebiopsy at 3 to 6 month intervals is recommended. If there is persistent disease but no cancer, again, continued follow-up at 3 to 6 month biopsies can be considered. But if a 3-month biopsy shows a cancer, then management as appropriate for that change should be attained. So following initial progestational treatment, if you get regression to a normal endometrial biopsy, you can consider long-term maintenance therapy with progestational agents, particularly in patients who have risk factors for endometrial cancer. And those risk factors can be summarized here. Modifiable risk factors are those patients that presented to you with estrogen stimulation with no progestational agents, so removing the unopposed estrogen therapy. Another modifiable is obesity. Today, with our GLP-1 receptor agonists, we can see that there is definite improvement in obesity, which can certainly affect the long-term outcome of response to therapy. In the non-modifiable risk factors, diabetes is kind of moving over into a potentially modifiable process as we look at the new medications that are being evaluated. So, looking at lifestyle changes are important as we try to prevent not only atypical endometrial hyperplasia, but to prevent cancer from occurring. And attaining weight loss, glycemic control can certainly improve the overall health of our patients that had this diagnosis initially, but more important for our patients who have risk factors to try to prevent this diagnosis as well as the diagnosis of endometrial cancer to occur. So, part of our charge, I do believe, is talking to our patients about lifestyle modifications, as nearly 70% of endometrial cancer survivors have obesity. And most of these patients are unaware that their cancer or endometrial hyperplasia, atypical hyperplasia, are cancer linked. And even a weight loss of 7 to 10% is found to have significant change in outcomes for these patients. One comment on post-treatment pregnancy rates are approximately 30 to 40% in patients who had desired to attain fertility even in the presence of atypical endometrial hyperplasia. But for the majority of these patients, assisted reproductive technology was required to attain the pregnancy. So in conclusion, one, we do recommend hysteroscopic evaluation to rule out cancer with a diagnosis of atypical endometrial hyperplasia. Number two, hysterectomy is the definitive treatment of choice, but not a supracervical hysterectomy, nor an ablative therapy. Non-surgical management for those patients who are not candidates or who desire to attain or retain fertility is very possible with progestational agents, but the superiority of oral over intrauterine progestational agents are lacking with minimal scientific data, as previously discussed. Follow-up, as we discussed, at 3 to 6 months after the initial treatment with progestational agents, and looking for our future to continue to look at prevention of this diagnosis as well as endometrial cancer by assisting our patients with lifestyle modifications. So thank you all very much. I want to give a thanks to our ACOG Clinical Consensus GYN Committee. It is people like you who sit at ACOG who make these recommendations, and also thanks to Dr. Chris Zahn, who oversees our GYN and our Clinical Consensus Committee. So thank you very much.
Thank you. I think that was an excellent rendition. And I think the timing is a little off, so I don't think Verda is online. But definitely, I'll take some questions. We have some questions from the audience. We'll definitely take them. And I have some questions also, which we will also take. Yeah.
So, ma'am, we'll take the questions from the audience.
Yeah.
The first question is, for endometriosis, do you rely more on the imaging, which is TVS or MRI, or proceed with the diagnostic laparoscopy early on?
I think this is a question which should have been in the previous session, but I can definitely answer that. I think the ultrasound today is the most accurate diagnostic modality. You don't need to do a laparoscopy just to confirm endometriosis. So definitely a good ultrasound would definitely be good.
That's so true, ma'am. The second one is, do you find AMH levels to be a reliable marker for PCOS diagnosis and monitoring?
Oh, wow. This is a controversial topic, but yes, AMH is something which is really coming of age. And though it cannot be used singly as a marker, ultrasound findings, biochemical findings, the clinical features, etc., you combine with them. But For monitoring also, what happens is, especially in infertility, I think AMH is very, very important. Along with antral follicle count, it really gives us a good insight into it. And in fact, even in adolescents, though we say that AMH is not reliable in adolescent, but the monitoring of that patient can be done with AMH as she grows older. So yes, AMH is important.
And ma'am, the last question. Yeah. The last question is, what diagnostic method do you rely on the most? An endometrial biopsy, a hysteroscopic biopsy, or a DNC?
I think that's something very important, and I'm sure Verda would have answered it. The best part is a hysteroscopic directed biopsy. I think it's very important that you see the lesion and you can take a biopsy. So hysteroscopic biopsy would be good, but of course, for screening purposes, other tests can be done. And here are some questions which we have, because we have Dr. Nick Leland, who will start in about 5 minutes. So there was a question that in a young woman with atypical hyperplasia who desires fertility, what is the best line management? I think obviously conservative, you give oral progestins or you can put an LNG, but surveillance has to be done every 3 to 6 months. Welcome, Rishikesh. I think surveillance has to be done 3 to 6 months. And once she's better, get her pregnant. And then, of course, we need to take a decision what to do. What is the progression risk of atypical hyperplasia to endometrial carcinoma if left untreated? In fact, about 25 to 30% progress to invasive carcinoma if it is not treated, and 40% may already harbor occult carcinoma. So I think it's really important to treat these patients and get rid of the uterus wherever required. When should hysterectomy be considered without delay in atypical hyperplasia? I think in postmenopausal women, women who have completed childbearing, and also those who don't respond to medical therapy. I think if within 6 to 12 months they don't respond, we would definitely head to, hysterectomy. I think, would you like to add to it? Okay, so I think these are all the questions that we had. Any more?
We're done.
No. Okay. How do you monitor patients on conservative therapy with progestins? Yes, repeat endometrial biopsy every 3 to 6 months until regression, and then long-term follow-up, since recurrence always remains a risk. I think these are some important points which the audience has asked, and I'm glad we were able to answer that. And I think now we can head, since Dr. Nicholas Leland is already there, we can actually head to his talk. Can we have a slide, please? Dr. Nicholas? Yeah. Dr. Nicholas is a professor in the University of Hamilton, Ontario. Dr. Leland developed a 2-year comprehensive research and clinical fellowship training program in endoscopic surgery and clinical fellowship training program in endoscopic surgery. He's developed a multidisciplinary program in endoscopic surgery also, and developed a multidisciplinary complex gynae surgery and endometriosis clinic at McMaster. He has more than 150 scientific papers, clinical practice guidelines, and book chapters published. Dr. Leland completed a Master of Science in Healthcare Management from the Harvard University in 2006. And of course, he's a great friend, and it's a pleasure to see you, Dr. Nicholas. Looking forward to hear from you. But before that, Rishikesh would like to say a word.
Hello, welcome, Dr. Nicholas, our friend from Canada. And I think he is going to be the next president elect of the SOGC. I think he's the incoming president. Hi, and he's an expert. He has already been in India. He's a friend of India. He's come and given a lot of information about the new drug, the oral GnRH antagonist, which he has also done a lot of research in. And so without much ado, I would like to invite him to give the talk. So can we have its talk? And then we, of course, we'll have a lot of questions from the audience.
Okay, can you hear me okay? Okay.
Uh, can you hear me?
Yes, yes.
Okay, great. So thank you very much, Rishikesh, and all of my friends in India. I'm speaking to you now from Canada. And in fact, it's early in the morning in our time. So I'm happy to be here at your international summit to talk about surgical techniques to counter postpartum hemorrhage. And in view of the theme of this conference, I think that it's very important that we also recognize that there are many aspects of healthcare for women where there are inequities, and we need to address these in many ways. This was last December when we were here, and my wife and I really enjoyed India, especially traveling around to experience the fantastic culinary opportunities. So I'm to talk about postpartum hemorrhage, and part of that surgical fellowship is really, we also have a team within that we've trained to be able to deal with some of these really complex surgical issues in obstetrics. But PPH is still the leading cause of maternal mortality around the world, at least 1/3 of maternal deaths, and 60% of maternal deaths in developing countries. And the majority of these deaths occur within 4 hours of delivery. And it's important for us in Canada not to be smug about this. We've had a recent maternal death in one of our largest cities in Canada. And so this is something that we need to remind all practitioners of obstetrical care that it is a very significant issue around the world. And just remember the classification, the T's, tonus, tissue, trauma, and thrombin. But often it's a combination of these that result in the problem of postpartum hemorrhage. And management really does involve an interprofessional approach. A lot of the times in the post-delivery phase, the nurses are looking after these patients. And we all need to be acutely aware of how to accurately assess blood loss and fluid replacement and the control at the source of the bleeding. So what are the risk factors? And here's the issue. You mentioned about ultrasound. The three most important things in the last 40 years in our specialty is number 1, ultrasound, number 2, ultrasound, and number 3, ultrasound. The reality of it is that better quality and high quality availability of ultrasound is critical for this particular issue because many of these things are predictable. So if somebody has had a retained placenta, maternal or obesity is a huge issue in North America. Older maternal age, the majority of patients in Canada are delivering after the age of 30 now. Maternal anemia, and it's obviously a huge issue both in gynecology as well as in obstetrics, but twice the risk if the patient is anemia, and obviously the risk of requiring more blood transfusions. Multiple prior cesarean sections. So around the world, we have an epidemic of cesarean sections, certainly in Canada, with rates in the low 30%. And here's the thing, with multiple prior cesarean sections and or placenta previa, we have increased incidence of placenta accreta syndrome. So this is why I've developed the team to respond to this in our level 3 unit. But today we need to talk about, well, what's happening in the rural areas. And this, of course, is very important in India and extremely important in Canada because we have a very large country and multiple small obstetrical centers that don't have large blood banks and they don't have the ability to have a lot of these high risk tools to be able to diagnose and to predict. And so the ability to transfer patients is limited as well. So many of these are predictable with a high index of clinical suspicion, but by also high quality ultrasound, especially the placenta accreta syndrome. So in these risk factors, we need to be asking for our sonologists, if they're obstetricians and or radiologists, to be able to be looking for these issues. And the reasons for delay in appropriate management is simply underestimation of blood loss in both volume and the rapidity of loss. And patients initially can compensate well for the losses if they're younger patients in good health. And also the hypervolemia of pregnancy allows them to tolerate significant blood loss without significant change yet in their vital signs. And also a delay in diagnosis of coagulopathy. So I've had a lot of, shall I say, discussions or arguments with our anesthesia colleagues about getting coagulation results before they treat. But really what I teach our residents is that if you're thinking about coagulopathy, you need to start thinking about getting the blood products. And also taking a red top tube and just holding it in your pocket and waiting. If it does not coagulate, you know you've got a dilutional coagulopathy or DIC. And remember, pressure is our friend. Whatever source, we can diminish bleeding by proper use of our hands and other instruments to be able to decrease blood flow, as we'll touch upon. And here's the other one. So even if you have a patient who is on pressors and is hypotensive, don't forget that we can press on the aorta, and I've done this a number of times to allow us to wait for the blood products to get there and to improve the blood flow. And also the use of mask pants if we're going to be considering transfer of patients is something that we need to have available. So for our hospital and a larger hospital, and I recognize that hospitals are going to be different, but we need in terms of their personnel. But larger tertiary care hospitals really need to have a massive obstetrical protocol, as do all hospitals, but we don't often have all of these people to be able to facilitate this process. So we need to do this in advance, and we need to do simulation techniques to be able to make sure that we know where all the appropriate things are, all the appropriate instruments that are going to be needed. But as soon as we call this, an OR is on standby, resuscitation with large bore IVs, packed cells, coagulation screen, all the rest of the other things, and obviously fluid replacement with lactated ringers and normal saline, and then transfusion. And then coagulation factors and all of the tests that we would normally do for this. And certainly platelets become necessary if we've had multiple transfusions and if their platelets are less than 50,000. And evaluate the response by vital signs, urine output, CBC, coagulation tests to guide therapy. But again, the remedy for the cause of bleeding can very rapidly become surgery. And remember that coagulation and coagulopathy is often a clinical diagnosis. And don't let your anesthesiologist or anyone else delay the ordering of blood products on the basis of waiting for tests. The other thing we have are cell salvage systems. Now, we utilize these for those cases that are picked up by ultrasounds of placenta previa, placenta praecrita syndrome. And we know that we can recirculate the patient's blood once we've delivered the baby and we've gotten rid of all of the amniotic fluid. Then we switch over to the cell salvage system. Now, clearly, this is not going to be available across the board in all countries, but it really should be in tertiary referral centers. And we should be picking up these cases so that they don't have to be transferred to those referral centers, and picking them up by understanding that multiple C-sections increase the risk of placenta accreta syndrome in combination with the existence of placenta previa. So these are our guidelines that surgical intervention is recommended if conservative measures fail. And obviously, these are all the medical treatments that I'm not going to talk about, but compression, sutures, uterine artery ligation, hypogastric artery ligation, or what we call usually internal iliac artery ligation, as well as hysterectomy. We try to avoid subtotal hysterectomy. I have techniques to be able to figure out in a fully dilated cervix where the end of the cervix is, but that's another discussion. And for women experiencing PPH and awaiting transfer, bimanual uterine compression or even external aortic compression may be done, and the use again of non-pneumatic anti-shock garments. So by the time our team get there, most of these techniques using B-Lynch, and occasionally people are trying to get the uterine arteries, but all the different techniques, at least in our experience, have been less than satisfactory for control. Others may have better techniques. The other thing to think about are bulgog vascular clips, which we can use at the uterovarian ligament, and occasionally for open surgery for the uterine vasculature. But the problem is that we do see cases where people have tried to get the uterine vasculature, but due to the proximity of the ureter, they get damage to the ureter. So the solution to this is we don't recommend getting the uterine artery close to the uterus. We need to go into the retroperitoneal space, identify the internal iliac artery, the origin of the uterine artery, and getting it there. If you're into that space and you can do it, it's actually better to do bilateral internal iliac artery ligation due to the multiple collateral blood flow that will continue the bleeding. So basically, the clips at the uterine, the ligament of the ovary, uterine origin, and ideally, my bias is to do the internal iliac artery, which we'll see in a second. This is a technique. This diagram shows the traditional way of utilizing silk ties. This has the risk of damaging the veins behind the artery. So we recommend a different technique that was taught to me by a trauma surgeon in the Canadian Armed Forces who had worked in Afghanistan during that unfortunate activity there. And in their when they were dealing with pelvic bleeding in any patients, males or females, they would do an internal iliac artery ligation using large vascular clips. So he taught me that. It's much faster than the old technique. And I'll just show you this if it'll work. There we go. So this is on the right side of the patient, and you can see the ureter, the external iliac artery, and the internal iliac artery. So here we've already opened up the peritoneum parallel to the infundibulopelvic ligament. Then you isolate the internal iliac artery. And we use Lowers to develop the spaces just on either side of the vessel, and usually about 2 centimeters from the bifurcation of the external and the internal, and holding the ureter, as you can see with the Yonker suction, away from where we're going to put the clips. And this is not a difficult procedure. It just takes practice to get into these spaces and to understand them. So here we use the contemporary clipping technique. And we use, excuse me, 2 large vascular clips. And you can see in the bottom, this is a case of placenta percreta, and there's a very large bulging out placenta. So these are the ones that bleed very significantly. And here we go. We've completed that procedure. And here's one. We got called just last week for a major bleed that was unrecognized and had been transferred. And here you can see on the right-hand side, the hand holding the uterus. And what I'm doing is showing exactly where the vessels are. So just this is a little bit more difficult to see than a animated one, but you can see it's the same technique. And there we go. And we use 2, and you have to do it bilaterally, just simply because of the collateral circulation in the female pelvis is absolutely amazing. And in fact, even if you're not doing a hysterectomy, this does not impact on a woman's fertility for the future. So the other thing that I've been taught by trauma surgeon is damage control. This is really the concept where if there's traumatic injury or bleeding due excessive bleeding and dilutional coagulopathy or disseminated intravascular coagulopathy and continued bleeding, it leads to hypoperfusion, acidosis, and exposure with an open surgery for a long period of time can lead to hypothermia. So unless we correct all of these things, the patient is going to die because she will not have an adequate response to even repletion of blood products and coagulation factors, because if they're cold, they won't work. And here we have damage control concept overall. So dilution of coagulation factors, hypothermia, acidosis, hypocalcemia lead to coagulopathy, which continues the acute hemorrhage, even though we're giving transfusions, IV fluids, as well as blood products, as well as hypoxia. So this is a massive, terrible cycle that patients get into that lead to death. So damage control can be utilized for transfer. And what is that? So in this situation, what we have to do is put pressure on the bleeding sites. So at laparotomy, multiple sponges, green towels, and closure of the abdomen or non-closure, and just utilizing special issues with pulling the tissues together can actually save the patient's life, because if you can stop the bleeding with the pressure, warm the patient, and then give all the blood products, or even transfer the patient to a tertiary care center where blood products are more readily available. This can save the life. So pelvic packing is the key to this process. And this is what they do in these war-torn areas. And they pack and they put the patient in the ICU and they re-warm them and get the blood products in when they're warm and to save their lives. So at the end of the day, with postpartum hemorrhage, if they're not controlled by the usual medical and pelvic examination and pressure, then we need to move to surgery. And in conclusion, blood loss is consistently underestimated. And this can result in inadequate treatment, resulting in the complications or death. And as I say, even in a large center in Canada, this can happen just simply because people are not watching and are underestimating the blood loss. A trickle can be enough over an hour or two. And pregnancy anemia and other underlying health conditions can profoundly affect a woman's ability to tolerate any blood loss. So, and remember, all of those predictable risk factors can be determined in advance. And if you need to send the patient in advance to a center where there is a much better blood bank and many more people to be able to look after these patients, these very high-risk patients who are placenta accreta syndrome need to be transferred. So, and most of the time in places around the world now, in Europe and in the United States, it's that it wasn't picked up early enough and they're in a small center and weren't able to keep up with the blood loss. So damage control is a very important concept and may save a life. And ultimately, we need to train all healthcare providers providing maternity care should learn all of these life-saving surgical skills as well as other techniques. Systematic pelvic devascularization is a good way to conserve the uterus and to control pH. And again, we are now training all of our residents to go out into practice with these skills, but they need to practice them. And we often have simulation models that people can utilize. So we must, and in keeping with the theme of this particular conference, reduce maternal deaths to promote safe motherhood around the world. Motherhood and mothers need to be saved in this way, and we all need to recognize that there are lots that we can do to convince governments and hospitals to provide these appropriate instrumentations and better ultrasound, etc., to improve our care and reduce maternal deaths. Now, that's a whirlwind view of this, but in fact, I think the important concepts are here. But again, thank you very much. And my wife and I, again, had a wonderful time in India, and we look forward at some point to coming back to your wonderful country.
Thank you, Dr. Nicholas. That was really a fantastic talk. And I think, the one aspect which you stressed on, this particular surgery should be taught to each and every gynecologist, because I think it's life. It's really, really important that this skill is updated to each and every person who does deliveries, and very, very important. In India, we have the FIGO project, FOGSI FIGO project, which is PPH Ampli. And as you said, damage control, before we reach the damage, I mean, if we are teaching our gynecologists about carbetocin, tranexamic acid and misoprostol. In fact, those who deliver at home are actually given misoprostol so that if they find that the bleeding is more, they can self-administer those drugs. Because it's like you talked about smaller centers where it's not possible to do tertiary care or the surgeries. One question I wanted to ask you, because obviously all of us are working in tertiary care centers also. Is there any comparison between the surgical ligation and maybe, uterine artery embolization or those kind of where we use, like I did a cesarean, we put a balloon, and block, it was a placenta accreta. We put in a balloon and then we left it. We released the balloon, there was no bleeding, so we came out and gave a methotrexate. But do you have any comparative studies on these things?
Yes, in fact, we do. One of my last fellows who left to go to Mount Sinai in Toronto actually looked at the data from our center a comparison to theirs, which at that time they were doing the uterine balloon application. And it actually is a very effective way, but here's the problem. It took a significant amount of time out of the operating room to be able to do this. So there was the huge amount of time. They did have some complications with damage to the blood vessel, but I mean, it really depends on the expertise of the place and the ability to do this. So I think both are virtually comparable. The advantage as perceived is that you're not ligating the artery, but we do know from lots of data that it doesn't actually impact on fertility, and the collateral circulation takes over fairly quickly. So at the end of the day, in our article, we recommended just based on the fact that it was very quick and that not everybody has the ability to do IR, that we should be training people to do this so everyone knows how to do the internal iliac artery ligation. And most of the people are being trained in the tertiary care centers, and they go out to other centers, so they need to be familiar with the techniques. So that's why they've switched to the ligation at the time of the hysterectomy.
I wanted to also ask you, is there any difference in the fertility preservation? A lot of people would, like to have another child, or sometimes I had a patient who had a stillbirth. So she wanted to obviously conceive again. So
actually, there have been a number of publications on this, and I had the experience myself when I was a resident. I learned how to do this, and I taught it to a staff person who had a patient who had a 24 years old and had a perforation during a therapeutic abortion. And we originally tried IR, but it actually didn't help. So I put it in the, I showed him passionately. She came back 6 weeks later and asked for a tubal ligation. And the doctor said, no, I think we should wait. You're only 24. But then I rotated to another hospital, and there she was at 18 weeks, a number of months later, pregnant. And obviously she could get pregnant, but in fact, when you look at the literature, it really doesn't impact on fertility. I mean, obviously we'd like to avoid it, but
Thank you. One second.
I think fantastic talk, and I think that what we are to, as you rightly said, we need to train people, just like FIGO has a obstetric fistula training. This is probably equally important to train our people in how to do it. Maybe one person, at least in each of the main cities in the world, we should have the competency to do the ligation. That is very important, I feel.
I couldn't agree with you more. And in fact, like many surgical procedures, it's just a question of seeing it and understanding it and not being afraid. I think many gynecologists are afraid of the retroperitoneal space because we don't get trained to go there. And in fact, it is not a difficult procedure. And in Canada, it pays a lot more than the cesarean section, but nonetheless, it's easier than most cesarean sections, really.
Great. I think we have had a wonderful talk from Professor Nicholas, and we are looking forward to meeting you in Cape Town, where we are all, just now in the other hall, Dr. Priya Somepillai, the assistant, the deputy secretary of scientific chair, was telling that already 5,000 people have registered for the conference.
Oh, that's fantastic.
Yeah, so we are all looking forward to meeting all of us, and I would like to tell the audience that you should please register. There is time. There's nearly 40 days remaining, and the visas are easily available, tourist visas, so you can easily register for the conference, and it will be a fantastic, fellowship and a lot of science as well, and a lot of learning and a lot of, exchanging views and mingling with cultures. So thank you very much. Pardon? One question more for him.
The last one, right? What is the anatomical basis for uterine artery ligation in PPH?
Okay, so the majority of the blood flow to the uterus at term, and it's 500 cc's per minute, is through the uterine artery. And in fact, when you go back to the origin of the uterine artery, that is exactly where the anterior division of the internal iliac artery is. So if you're going to clip the uterine artery, I think the logical thing is to move back, because then you get the vaginal branches, the other branches that interact with the other blood supply from the inferior mesenteric artery, and and you want to do it on both sides. So the logic is that will reduce the pulse pressure. It doesn't diminish the blood flow completely, but it diminishes the blood flow and the pulse pressure sufficiently to allow for clotting and diminution of the blood loss.
Okay, thank you so much. Just on a lighter tone, I had read somewhere yesterday or 2 days ago that there's a robotic pregnancy. Is that really happening? What is your, just to go on a different note, a robot carrying the pregnancy to term?
Yeah, so actually, that some Chinese firm is offering it like for $11,000. Maybe it will be possible. Maybe 5-10 years. They are quite dog sure about it with artificial intelligence and all. So we don't know. But
you never know. But I don't think robots bleed, so maybe there is some advantage.
But yeah, then all this SDG goal will be achieved very easily.
Yes.
Okay, thank you so much. It was a wonderful lecture, and it was really nice connecting with you again, and hope to see you in Cape Town. Thank you. Thank you very much.
It's always wonderful to see you, and I look forward to that again. Thank you. Have a nice evening.
Thank you. Now we'll go on to the next session.
All right. Thank you so much, ladies and gentlemen, for all our international viewers as well. Thank you for joining in online. We have so many people logged in from multiple countries. And we'll also like to remind you that this session is for today and tomorrow. But people who would like to listen to the talks again, there's going to be online. You can view it for 2 more weeks. So thank you for this session. And now for the next session, I would like to invite our chairpersons. We have Dr. Nandita Palchetkar along with Dr. Tanya Vijan, and I would request them to please invite the speaker for the upcoming session. Over to you, chairpersons. Thank you.
Good evening, everybody. I'd like to invite Professor Thomas Gelhaus, mentoring our next generation. I think this is a very important topic. Dr. Thomas Gelhaus is again a friend of India. We are very happy to see him. He is a professor at the University of Iowa College of Medicine. He's the president of the ACOG, and he has served ACOG and its members for more than 30 years in various positions. Dr. Gelhaus's interest in the area of mentoring, advocacy, and healthcare policy for providers and patients. He has completed the McCain Fellowship, a month-long in-depth experience in advocacy at the ACOG in Washington, D.C. in 1999. In 2001, he was the primary care policy fellow with the U.S. Department of Health and Human Services. And also, he has received a doctorate from our Indian College of OBGY. So I'm very happy to welcome Professor Gelhaus. And can we have his presentation, please?
Right, so our online viewers, keep sending your questions and we'll try to address them all by the time we are uploading the talk.
Hello, everyone. My name is Tom Gelhaus, and I'm a professor emeritus at the University of Iowa in Iowa City, Iowa, in the United States. Thank you very much for this opportunity to present at your conference. I'm going to speak today about mentoring our next generation, probably one of the most important areas in helping and promoting our younger generations in the field of medicine. Mentoring really wasn't spoken much about in the early 80s and 90s when I was a resident and learning OBGYN. So let's first discuss the definition of mentoring. And there are many definitions in the literature. One that I look at a lot is that it's an experienced and trusted advisor, someone who teaches or gives help and advice to less experienced and an often younger person. It provides guidance and inspires. And I really like that part about inspiring. I think that's very important about being a mentor. And then it's someone with whom you can let your guard down, share your insecurities, and ask the S questions we all have. But first, we have to differentiate between role models and mentors. Mentors and role models empower people to live a certain way, and they influence the important decisions they make in their lives. Although the two terms role models and mentors are used interchangeably, there are distinct differences and some similarities. The express definition of a mentor, as we said before, is someone usually known to the other person with more experience and knowledge, who guides and teaches that person face to face. A role model, on the other hand, is usually someone that is not known to the person, but whom they look up to and who influences the way they live and act. So a mentor is someone who can show a good example and teach best practices. In contrast, a role model can offer both positive and negative examples, and it will be up to the person to understand the difference and learn only the good. So why is mentoring essential? Well, we know that it's a proven method of learning, and it results in the development of professional traits in the mentees. An ethical and moral example develops like traits in young professionals. And we know it helps decrease burnout, especially by having that mentor who has been through it before guide the mentee through the difficult times. Why is this important? Why is mentoring important? Well, what do we have today? We have increasing complexities of our profession, changing times with new generations and expectations, many more challenges and demands on our time. And a lot of this can result in physician burnout, and mentoring is one way we can help prevent that. There are types of mentoring. We break it down mostly into formal, which is assigned, or informal, which is unassigned. The relationship can be initiated by either the mentor or the mentee. And a lot of times in the informal, it's the mentee asking the mentor to engage in that relationship. Some studies suggest that informal mentors are more effective than a formal relationship. but the quality of the relationship is much more important than the way it is established. So how does mentoring work in the academic world, in academic medicine, where many of us are? Well, there was this very interesting study by Erin Tracy in the OBGYN department at Mass General Hospital in Boston, Massachusetts. And the title of their study was Outcomes of a Pilot Faculty Mentoring Program. And this involved junior faculty members. And their goal was to identify particular positive and negative aspects of such a program. And they had two recurring themes in their results. The participants felt better supported by the department, and they appreciated a greater sense of camaraderie. Most mentees noted the program's success in the following areas. They had a role model, they had an example, and this is where a role model can meld into mentoring. They had that example, that good example. They had increased visibility. In other words, they were invited to events and they were able to network and make more connections, not only in their department, but also within their university system. They had someone to whom they could turn, someone that could help them with difficult situations. And that was very common for all of us when we were starting out. And the conclusion of their study was their mentoring program had significant benefit for everyone who participated. And that included the mentors, and helped ensure the success of the new and young faculty members. And that's something we all want in all of our departments and divisions. So how can you be a great mentor? Well, first thing, it is a big responsibility. But a great mentor must believe in the mentee personally and professionally. The mentor sees the mentee as a person and not just as an employee. And the mentor has to be unafraid to tell them the hard truths. They must be honest with them, completely honest with them. And the mentor must put in the time and the energy in the relationship, or it will not work. Essential to mentoring is that the conversations must be completely confidential. What you see here, what you say here, stays here when you leave here. Kind of what we say, like what we say in Las Vegas. What happens in Vegas stays in Vegas. And it will not work if the mentor breaks that confidentiality. Now, the mentor receives a lot of benefits also of mentoring. There is incredible personal satisfaction from watching someone reach their full potential. When that happens, mentors gain in return. It goes both ways. And this happened with my first mentee. I learned so much from him. And I think he learned something from me, but I felt like I benefited greatly from what I learned from him. So in Forbes magazine, I found an article about 9 things to know to be a great mentor. Number 1, always play both roles. Be a mentee as well as a mentor. You have to put yourself in the mentee role as you mentor. Number 2, be committed. Follow through and be there for them when needed. Being a mentor is a commitment, and you have to follow through on your promise. Mentors need to be there for their mentees when they are needed, or it will not work. Number 3, know your mentee can be anyone, anywhere. And it's very important that we supplement our skill gaps to help each other. Mentoring doesn't need to follow the traditional elder upstart prescription. We can have peer-to-peer mentors, and I had many of these over my career. I had one of my resident mates, and we still together today are peer-to-peer mentors. And I think this is very important to have people that are in the same position that you are in to also discuss concerns that you may have or finding out ways to deal with difficult situations. You can also still look up to your elder mentors, so to speak, but you can have those peer mentors that are at the same level as you. Number 4, listen. This is one of the most important things there is. Take time to listen and understand their situation. Spend more time listening than speaking. Listen intently as the mentee vents and sorts out the confusion, because frequently they will do that. As they're talking, they will sort some of the confusing and concerning things out in their heads. The power of listening is massive. And as my father always told me when I was younger, you listen better with your ears than your mouth. Number 5, have your own mentor network. Enlarge your circle to a wide variety of experts in many areas and age brackets. And I have done that over the years, and it has been invaluable to me. If you are insular, if you're always closed in, you will always return to the same small circle, and you may be closed off from other opportunities. To be the very best mentor, you need to continue building your network and taking advice from those you trust. Number 6, be open-minded, be compassionate. It is necessary to understand the mentee's needs, wants, and feelings that can only come in the form of deep and implicit empathy. They will never see your side until they are convinced you have seen their side. You have to put yourself in their shoes. Number 7, have patience. This can be a long-term and a trying endeavor. And it may require constructive criticism, which can sometimes be very difficult to hear, and it can be easily misinterpreted. But you cannot placate the mentee. My mentors helped me the most when they were honest with me. Direct and honest, and that's what helped me make a difference in my life. Number 8, be a role model. And a role model in the definition that we used earlier. Your actions are being evaluated. Set your bar higher than what you expect from your mentee and lead by example. Few things are more impactful than leading by example. Number 9, care about the relationship. Invest yourself and you will get much more out of the experience. If you do not care or cannot invest in the relationship, then find someone else, because you can do more harm than good. And the same goes for the mentee. They have to invest also in the experience. This is a photograph of my mentors when I was inducted as president of the American College of Obstetricians and Gynecologists. These were my mentors throughout my years. Second from the right was the resident who was my mentee, and he was the one that I learned a lot from, and we worked very closely together over 4 years. Far right is a person who was in my residency group with me, and he and I are peer mentors to this day. So I had a really good group of people. They invested in me, I invested in my mentee, and it was a great experience that helped me grow. So, as Michael Jordan said, just do it. Become a mentor. Watch what happens, not only to your mentee, but also to you. And don't forget, magic happens when you go outside your comfort zone. And sometimes this may be going outside people's comfort zones, but do it and you'll see what happens. Thank you very much for this opportunity.
All right, thank you so much. If you have some questions from the audiences, we request you to please put it on the Q&A box, and we'll try to answer all your questions. For the next talk, can we have the CV, please?
For the next talk, we have Dr. Stella Dantas, who's going to be joining us. We would like to thank her for giving us her valuable time. She is an obstetric and gynecologist from the Institute that is the American College of Obstetrics and Gynecologists. She's got the honors and awards from the Outstanding District Service Award, American College of Ops and Gynae 2023, Portland Monty, Top Doc OB/GYN in 2014, 2015, 16, 17, 18, 19, 20, 21, 22 till 24. State Legislative Advocacy Award, American College of Ops and Gynae 2011, 2018 Teaching Award, and many more accolades as you can see on the screen. We thank ma'am for giving us a valuable time, and we would like to have her talk right onto the screen. Thank you so much.
Thank you so much for that introduction, and I just want to extend my deepest thanks to the AICOG and FOGSI for inviting me out to speak and to be part of this amazing conference at this amazing venue. So I don't have anything to disclose, but the only thing I will disclose is I am not an expert in wellness. I'm still on my own personal journey. And I have had periods of emotional exhaustion, depersonalization, and a low sense of accomplishment at work, which many of you know is the definition of burnout. My objectives today are to understand the rates and the cause of burnout in medicine and obstetrics and gynecology and the wellness initiatives that resulted, to understand the need for us to shift to a culture of wellness and to learn one model to approach well-being, to appreciate the importance of the relationship between individual and organizational resilience, and to recognize the need for social connection, belonging, and community to support all of our well-being. So I put up this picture, and since we don't have our third speaker, I'll tell you the story. I was going to skip this, but this is a picture of my 50th birthday, which was on June 4th, 2021. At the time, I had become Associate Medical Director of our institution, which was over 2,000 physicians, over all of ambulatory care, so primary care, all of the specialty care. And of course, when I took that position in 2019, what hit about 8 months later was a pandemic, which we were kind of making up as we went along. And we had one of the we had the first patients in our state of Oregon, one of the first patients, I think, in the country hospitalized with it at the time. So flash forward to June of 2021, on my birthday, when my husband, I had told him I would go have lunch with him and my family, and I had excuse after excuse why I wasn't going to be able to be there. And as I finally got home late for a lunch, basically finding a friend of mine who'd flown in for my birthday to surprise me. Later that night, my brother who'd flown across the country from New York to Oregon, to the other coast to surprise me, and into a party later that evening that I well could have missed because of all the excuses I was making as to not show up for the community that had supported me throughout my career. So the party could have looked like the picture on the left, but thankfully, after a lot of prodding, it ended up looking like the party on the right. And what that did for me was it caused me to examine what I was doing with my life at the time. I had been asked to be in that role. It wasn't a role that I had applied for, and it was extremely busy. And was I really filling and giving the meaning to my life that aligned with my values and what I thought my purpose was? So about 6 months later, I transitioned out of that role. I made the active decision to leave. I gave them as much heads up as they wanted. I said, I will stay as long as you need me. And then transitioned back into what really drove me, which was women's health. And I would say my life isn't any simpler, any easier, any less busy being the president of the American College of Obstetrics and Gynecology, but I'm found much more joy in my life and purpose. So to talk about burnout in medicine and OB/GYN, we know that more than half of practicing physicians and trainees are experiencing burnout in the United States at this time. It's at epidemic levels, with hitting a high of 63% in 2021. And in 2023, about almost 49% of physicians reported experiencing at least one symptom of burnout. It has ranged from 40 to 75% of OBGYNs suffer from professional burnout, and in 2023 we found the first little drop from 54% to 51.2% of OBGYNs in the US. But it's really dramatic because at least you have a high level of experiencing one symptom of burnout in your lifetime. When I was looking up about India, I found, this is just a smattering of articles I found, and it seems that here in this country, you're also experiencing burnout. One study I saw, which was just a questionnaire-based study on medical practitioners, showed 45% and about 66% scored high on the emotional exhaustion depersonalization scales respectively. About 87% scored low on a personal accomplishment scale, and about 63% and 11% respectively had medium and low scores on the satisfaction with their medical practice. So I'm assuming the prevalence is very high, just as it is in my country and other countries. So why do we experience this? So it's a high adrenaline and demanding field. We have poor work hours. We have patients that demand an experience from us, especially in the obstetric world, that does not align with the medical care sometimes that we feel we need to provide. In the US, we have a very litigious environment. We have an electronic medical record that adds minutes upon minutes to every encounter. There are administrative burdens that become more and more for us, especially regulatory in the US. There's lack of autonomy. More than 50% of our physicians are employed, so they don't control their work hours, the time off that they get, their templates of how many patients they see in a day. There's increasing amounts of financial debt, up to $400,000 just for the 4 years of medical school in the United States, and our reimbursement is becoming less and less. It is not keeping up with the inflation of our country, and it has not moved in almost 30 years. And as you've all heard in the news, we're experiencing a lot of legislative interference now in our country with the practice of medicine and what choices we can present to our patients to allow them to make the best choice for themselves. And then we're battling misinformation, especially with social media, on the science and what we can provide to patients. And then when a patient's in your exam room and you're trying to tell them about the correct information and then earn that trust back from a community that's not trusting the clinicians anymore. And then how do you integrate all of that on top of your personal life? When I was reading about India, you have significant staffing shortages. Your ratios to your population have not kept up. Lack of support systems in the healthcare systems, much like the US, of having people and practitioners to help with the mental health needs of our clinician and healthcare population. And there's also a stigma of seeking help. And then violence against physicians and clinicians and doctors here. In a study of the Indian Medical Association that I found, 75% of your physicians have experienced some sort of violence from a patient or their family, or some sort of aggression. And ACOG is working very, very hard to confront these challenges, because it is our mission to support our members so that they can improve the lives of all people seeking obstetric and gynecologic care, and for their families and communities. This is just a list of the things ACOG does to try to support. We try to advocate for better policies, payment reform, clinical guidance, try to combat racism in medicine, strengthening our residency programs and the ease and the burden upon our students, and having a patient-facing website to really battle that misinformation and have a place for patients to go. What this graph shows is with the rise of wellness and the importance of wellness, there were a lot of publications that came out and talked about tools that you could use: art therapy, gratitude exercises, wellness days. There were workshops, webinars, we have them all. They added a core requirement for our residents in training to have wellness built into their curriculums. But we're not seeing like a dramatic drop, despite almost 10 years at least of the rise of these publications. And the reason is because they're giving tools, but they're not giving the infrastructure. We're not creating the infrastructure to support those. We're not providing and figuring out ways to provide more mental health care capacity to our healthcare workers, and resourcing all the initiatives that need to be done. What I like about this slide is it shows what probably many of us have gone through in our lifetimes. And when you look at the era of distress on the left, that's like before 2005. So if you were practicing or in a training program before then, you were probably, expected to be superhuman. You didn't need sleep, you didn't need to eat, you stayed till the work was done, 36 hours, there was no work hour restrictions. It wasn't a time where when you signed out your patients, you did it all. And it was a sign of weakness if you couldn't do it all. When you shift to the middle to Wellbeing 1.0, that's 2005 to about 2017, 18, there was a recognition that we should have some work-life balance. It's important to be healthy, it's important to sleep, it's important to exercise. So we're talking about the tools, but we're not given the infrastructure to implement. And now, after 2020, we're in that time where we're talking about it, and how do we have the organizations support us in that? How do we recognize this, the toll it's taking on our workforce? How do we support people and provide them resources? So one model I wanted to show you, there are many models out there, but is Stanford's model of professional fulfillment. And it's an approach to well-being that's not just about reducing burnout, but shifting a focus toward improving resiliency, and both for the individual and the organization. And because if you are finding joy in what you're doing, because every job in healthcare is challenging and difficult, then we are going to increase professional fulfillment and decrease burnout. And if these interventions are based and the organization supports it, it's going to be more effective. And I talked about having employed physicians, and which is why it's so important that the organizations support. But you also need physicians' engagement, and you need them to inform what initiatives are actually going to help. So here's the model. There are 3 domains, and the domains, it depends on all of these having relationships to each other. They share a common mission. They affect both the individual and the organization. But if we're able to drive this, people will feel valued and empowered and engaged. They'll feel part of an effective team. They'll feel like they belong. They'll feel part of community. And they'll have purpose, and they'll feel like they're making a contribution to something meaningful, which is larger than just them. It will affect how we collaborate and communicate. It'll affect how we our work and how efficient we are in the workplace. And we know that that leads to improved performance, better patient experience, better quality, and decreased costs in healthcare. So the first one is efficiency of practice, which is workplace systems, processes, and practices that promote safety, quality, effectiveness, and positive patient and colleague interactions and work-life balance. And we've seen this list already in my presentation. So how do we make that successful? Well, we involve the workforce in designing the workflows, the processes, how we do our work to make us more efficient. We have people inform what are the right staffing ratios we need. We build staffing to recognize that people need time off, that they're going to take medical leaves. And so that has to be informed. The second is building a culture of wellness. So an organizational work environment that values behaviors that promote self-care, personal, professional growth, and compassion that physicians and scientists have for themselves, their colleagues, their patients, and beneficiaries of their innovations. So this is where you need leadership commitment. You need them to commit, you need to have them drive this, prioritize it, and resource it, and measure that the tools they're implementing are making a difference. You can have a wellness champion, but I would say if you have a wellness champion at your institution, they should sit on an executive team so that they're with the operational team and driving wellness throughout from the top down so that there is buy-in. You need to have a burnout tool. There's several of them out there to measure the effectiveness again. You need to build in social events and celebrate people's accomplishments and recognize them. Build in time for retreats. Have mentorship and coaching opportunities. And something we are doing at ACOG is we are starting to build peer support systems because not everybody's institution has the resources to do peer support. So at some point at ACOG, we will have a place where if you're an ACOG member, you can pick up the phone and you will be matched, it might be across the country, with a peer supporter that can help you. But what is most important is that we normalize that struggling is okay. We ask about it, we recognize it, and when we see it, we assist our colleagues in getting the care they need. And that we show people, and we can lead by example, that it is okay to be vulnerable, it is okay to be struggling, and we can get better. And then the last one is personal resilience, which resilience sometimes can be a dirty word, but this is about our individual skills, behaviors, and attitudes that contribute to physical, emotional, and professional well-being. So this is where you build in things at work, helping get people, those are where you have workout restrictions, right? To give people the time off they need. There's a hotline to call if you need help. There's peer support built in. We had something called a navigator at my work, where if you needed childcare and you didn't have time to interview a bunch of nannies, you could call this service and they would provide it and help you find a nanny for your childcare so you could be at work and know that your kids are secure and sound. Lastly, I want to revisit COVID for a second. So we went through something very, very challenging, right? I mean, something that none of us had ever been through before. However, it created an instant community around us to get through that difficulty. And that resilience activation happened because there was something called liminal suspension, where people just suspended what they did to all work against a threat together. So primary care and specialty care, I saw, they were willing to share patients, see each other's patients. Orthopedic doctors were willing to see any sort of back pain, so primary care could take care of all the patients with respiratory problems. We had our people, our community banging pots and pans for us and forgiving our backlogs and the care we couldn't give them, the preventative care. And then we had health systems in my city that usually compete, working together to provide beds for each other, ventilators, right? But then as the numbers came down, all of that went away and our community went away. And now I find that patients are even more anxious and sometimes upset. So just quickly, if we have a little more time, if I can, okay. I wouldn't have told my story. Wanted to show you kind of what are the 4 things that are very important in it between an individual and their organization that we have to do, and things that we can do ourselves without resource that is going to help people with their professional fulfillment and resiliency. And that is communication. Make sure that you're having great two-way communication with people at your organization. Make them understand the why, because we're all going to have to do difficult things. But if they understand and they feel that psychological safety that they can ask questions, they will feel like they belong and they're part of it. Create that sense of belonging for people. Create that community. Share the vision so everybody understands and are rowing in the same direction when we are having to drive work. And then recognize people for the gifts and the talents they have. Everybody should do something in leadership, I believe. Everyone should help. And everybody has different talents. Some people are more organized. Some people are more visionary leaders. Give them the job that their talents will help them be successful in. And they will have more meaning and feel more tied and affinity for an organization. Because by doing all of this, you will gain more than all the gratitude exercises or wellness days off that you can give, yoga, all of that. Those are still important. I'm not trying to say they're not. But when you positively influence all those areas of connection, you're going to improve relationships and create attachment both to people's work and their organizations. And then if that's negatively affected, then you'll have a decreased sense of attachment, and that contributes to burnout. And this is something our whole community can do for each other, because we want to feel connected. We want to have purpose to what we do, and that's our basic human desire, is to feel useful and that we're making a difference. And if we feel like we're making a difference, we will feel joyful and content each day. One thing I want to mention is purpose changes with changing opportunities and circumstances. It's not a destination, it's not a job or a goal, it's a whole journey. And so you want to make sure that you're working towards your goals and they're aligning with your purpose, and that will help pave your path to wellness. And that is what I discovered in June of 2021. And then it will help you believe that our lives and what parts we are playing is mattering. So again, social isolation, I'll just say I won't read through this slide, all the negative effects, but connection has positive psychosocial benefits, physiological benefits, and behavioral benefits, and just connect with people. It can be family, friends, work friends, it can be on the phone, virtually, in person. Just cultivate those high quality connections, and that's the key to leading a joyful and fulfilling life. And these are all the things you can do in the next week that are very, very easy to do to help create and enhance that sense of belonging and connection and to strengthen your community. Here are some pictures of my community. Down at the bottom is the ACOG board. At the top are my work friends that I made do karaoke to help us feel safe with each other. And then my big family on both sides, our last holiday. So we need to come out of our silos after the pandemic. We have to confront our challenges together, share knowledge, solutions, and our coping strategies to build our resilience. And that's how we will keep our workforce healthy, how we will be able to take care of the population together. Thank you so much.
Hi, Stella. Hello, Stella. हमारा म्यूट किया है क्या?
Hi. How are you?
So good to see you.
Good to see you.
Yeah. See, it was a lovely talk. It was really wonderful. And I think physician burnout is so, so important. And so is the patient burnout also. I think you highlighted it so well in COVID and non-COVID. I think in India, we have very long hours, so there is no limited practice. We are on call 24/7. So I think it has a lot of psychological impact also. So yes, I think what we have done is we have started doing group practices so that we can help each other, be a community and work for each other. It is really good. What are the different things that you all do in America?
So we have group practices here. We are, we have large multi-specialty groups so that we can make sure that we have time away. I think it's interesting because when I trained, it's a long time ago in Hawaii, they were much like it sounds like in India, where they were solo practitioners, and even if they formed a group, they really weren't a group that covered for each other. Even when they were on the island, if they had a delivery, they went in for that delivery. And then now they've started to cover each other's patients. And I know it's a hard transition to make, but in my practice, when you are off, you are off. I mean, if you want to sign out your in basket so that when you're gone, you can actually detach from your electronic medical record and covering all those, your in basket and all those questions that come in, because it's shown that you have to really be off of your electronics for a certain amount of time to really start to relax. You can do that. The other thing, and that is hugely important though, when you have an organization, and I don't know that we're there yet, in this country, is you need to build and have the workforce that covers for that so that when people are gone, it is not just falling on a smaller number necessarily of people, that you're actually looking at when you think about all the days that need to be covered, you include the days that you also want people to be away, if that makes sense. So you actually have to figure out staffing for that. You either have to bring in locums to cover for that time so that it's not burning out the people that are left behind. In my organization, we have people who are, they're at retirement age, but they're not really ready to stop forever, but they just want to scale down. They're the perfect people to do that because they have flexibility in their schedule. Often they're enjoying life and they're happy to make a little extra money to come and cover for a week. So, and it's kept them involved. It's given them purpose, but allowed them to ramp down their practices and as they ease into a full retirement.
I think Stella, good of you to come for the program. At present 3,700 people are registered and 1,900 are online seeing the program. So when I came for the ECOG meeting, this was one of your themes of your presidency, and I was really impressed because we have occasional, in fact, some suicides also amongst the resident doctors, and it's a real big problem we are facing, and we have to see that we prevent this from occurring, because the work load is quite a lot, plus they are on a lot of pressures, and they are not expecting such kind of sudden onslaught of work. They are from their academic activities, suddenly they are suddenly dropped into massive amount of work, and there are a lot of emotional factors that are also playing interplaying at the same point. And I feel this is very important for FIGO to take it as an important thing, because I had noted it at that point in time that this is a very important topic for FIGO to look at, because this must be happening all over the world, because our especially gynec residents are under a lot of pressure, because deliveries take place 24/7, and I think it's a very important topic, and that's why it has a lot of relevance worldwide. You want to say anything more, Nandita? So thanks a lot and we would like to looking forward to meeting all of you from the United States in Cape Town. Already just now Priya Somapilla had come in the evening to give a talk, and that time she told us that 5,000 people are already registered for the Cape Town meeting, and nearly I think 200 is little less number. I'm sure it is more. 500-600 must be from India. So, but also looking forward to meeting you all there and interacting with you. Thank you for coming.
Thank you so much for the opportunity. It's good to see you.
Good to see you. Thank you. Bye. Bye.
Bye.
Bye.
All right. So I would like to thank our speakers. Thank you so much for being present here and taking your valuable time out. It's time where we start with the next session. All right. So to chair the session, we have Dr. Tanya Vijan here, and we will request our chairperson to please invite the next speaker. Over to you. Thank you.
Hi. So our next speaker is Dr. Ajay Bhardwaj, right? And sorry, our next speaker is Dr. Hani Fauzi, and he's talking on the essence of leadership, disciplines, and the effectiveness of it. Can we have his CV? Perfect. Thank you. He's the Vice President for Global Health and Royal College of Obstetrics and Gynecology, and he works with the NHS. He is a very esteemed faculty, and he helps a lot in he has a lot of interest in building capacity between societies and individuals. So we'll move on with his presentation, please.
Thank you very much for your introduction. I'd like to thank the organizing committee and the PI family for inviting us to this great meeting. We appreciate the hospitality, and it's not my first time to India. This is my 10th time, but every time I come, I find the hospitality, the friendliness is really very much appreciated. I'm going to talk to you about a topic that is perhaps non-traditional, not clinical. So I think there is going to be something in this for each and every one of us. And you can see what the topic is going to be about us as individuals, but equally, hopefully we'll see as we go on the discussion, it's going to be an aspect that perhaps helps our organizations as a whole. The word leadership is echoed in every corridor of any institute. And I would really hope to start with just sharing with you some concepts. I'll map for you some foundations. Can I forward, please? It's not going. Okay, sorry. I'll share with you some foundational key concepts in this presentation. You're going to hear me talking about aspects that relate to discipline. Perhaps a better word for it is a habit. Effectiveness, what it means, I'll define it and perhaps go to the roots and levels of effectiveness. We'll talk about paradigm, principle, what is the paradigm, and what the principles that relate to effectiveness. Then at an institutional level, we'll talk about issues that perhaps are what I call chronic problems in every institute, and I hope you will see and agree with me on perhaps a roadmap to which hopefully involves a whole person paradigm, a whole person solution that will contain our mind, our body, our heart, and the spirit. So here's a poem by Samuel Smiles. He's a physician and an author from Scotland of the last century. And it goes simply, I'm sure you read it by now, sow a thought and reap a destiny. Everything starts with how we think, and that really determines our destiny. And you can see in between there, reaping a habit. That habit is a discipline that hopefully we'll go and talk about. But if we want to develop a habit or a discipline, what is it? What are its components, so to speak? I'd like to urge you to think about it on 3 different parameters, 3 circles, and the intersection of these is where we really talk about disciplines, a discipline in general. The first relates to knowledge, skill. Most people would expect the third one to be attitude. Not very far, but is the desire. The knowledge, what to, why to, then the skills, how to do whatever we want to do, and perhaps the most important element is the wanting to do this aspect. Let's start with effectiveness. How do we define these? I'm sure there is so many ways. I did not use the word success here for a very good intentional purpose. It means something different for everybody. Some people, it is money, some people it's status, some people it's glamour, and so on and so forth. Effectiveness, perhaps you have also read the definition by now, is getting the same thing that you want continuously, or even better than whatever it is, but having clarity about what it is that you want. To expand on this a bit more, I'm going to share with you what I would call the roots of effectiveness. And here is a story that goes, I'm sure you have heard it before, Aesop's and fairy tales, the goose and the golden eggs. It goes like a farmer had a farm, and there was a goose that laid for him eggs. He takes it to the market in exchange for other goods that he wants. One day, he finds a yellow egg. He takes it to the market, and to his surprise, it gave him more money than what he used to get for the white, usual eggs. Happy as he was, he went back home with a lot more things, so they were happy. The following day, the same thing happens. The third day, again, this golden egg exchanged for a lot more money. Then a thought came to his mind, hey, rather than going and coming every day with this golden egg, why don't I slaughter this goose? And I'm sure the rest of the story you know. I'd like you to think of a production capability that this goose was producing and the eggs being the result. If we're talking about effectiveness, we're talking about getting golden eggs every day. What do we need to do for that? Care for the goose. And here, you take this metaphor a bit further, you can be thinking about our individuals as being the production capability of getting that result, looking after ourselves to get the result. Okay, where effectiveness starts? I'm sure it starts with character, the roots. It starts within ourselves, not with the others. But why is then the personality so much appearing above the ground? That's what people see first. The first thing that we all notice is hits us in the face. What the world sees is the tree. How many of us really think about the roots? And I'd like you to challenge yourself at this stage that character is not seen, but especially in early relationships, is the most important element in having the wonderful, nice tree that we might see in the tell. True strength of individual is the foundational. And as such, if we have the foundation weak, weak roots will give us weak trees. Strong roots, strong trees. I talked about effectiveness as being in the center. It applies to us in individuals. Disciplines apply not only to individuals as a matter of fact, but it also teams and organizations. Effective individuals make effective teams, and in turn, the effective organization. After all, I hope you agree with me that an organization is only as effective as its individuals within it. What I'd like you to notice from this, it is and in, out. It starts with us as individuals before it implies to our teams and then to the wider real aspects of what an organizational effectiveness is all about. And hopefully you'll see this context of inside out as we progress in this presentation. Let me then perhaps move to a different concept. What determines these results that we're talking about? We get them at work, we get them at home. Most people would say it's our behaviors. How do we see things? Come at a later stage. I'll give you an example. You're going into a building, you find the door, you want to open the door, you keep pushing, turn the knob, push. Once, it's not giving way. Twice, it's not giving way. You see the word pull. You pull the door, wow. Now the door is open and you can go through. If you want to have a different result, I would like to challenge you that we have to change not only the way that we do things, but how we see them. And I'm sure you might have heard the term, the phrase, need for a paradigm shift. All our politicians talk about it. All our leaders keep talking about it. What is a paradigm? I trust I have seen it, shown you with, and demonstrated with you that the concept of the see. And if we want to go and define it next, it's the way we see, understand, and interpret the world. It's our mental map. So think of it as a window. Think of it as glasses in front of your eyes. Developing a new discipline, or a habit for that matter, is more than just doing things differently. It's about seeing things differently. Let's say you want to get to the store and you have seen that this word made the whole difference to you. I'd like to challenge you. If you really want to have a quantum leap in results, a difference, you're not happy with what you're getting, you can change your behaviors. Improve your behaviors will improve the result. But if you really want a quantum leap in better results, change the mindset. Change the way you see things. So another word for the word see in the see, do, get is the paradigm that hopefully is well explained by now. It's compared to the window that we have. And then as a matter of fact, when we are young, we have a very clean window. But the world corrupts us, messes our windows, the way we see the world. We get conditioned by many things. And unfortunately, as we grow, our experiences shape our behaviors, accordingly, our results. I think you can take this see, do, get paradigm and think of a number of things. Think about poor outcomes. You might feel like your people are not behaving, are not getting good results. The next thing you're going to be doing, look at it, what your behaviors, you might be micromanaging them. And then improving this gets you nowhere. Improving your behaviors, yes, but if you improve the way you see things higher up, it changed the whole world. As you have seen here, in the center of all these disciplines, there is principles. So what are principles? Here is another thing that we want to talk about. Effective people base their paradigms on principles of effectiveness. When we talk about a principle, we really talk about things that are timeless, universal, self-evident. Whether we work, whether we like it, whether we understand them or not, they are there, they exist. They are not temporary. They are not situational. They are not subjective. We all agree on things. Fairness, justice. If I give you one example from biology, talking about human body needs nutrients to survive. Thinking about it, timeless. It's not temporary. Did our ancestors require it? Will 100 years in the future, future people will need nutrients to survive? The answer is categorically yes. It's universal. It's not situational. Does every human being needs nutrients? The answer is categorically yes. Self-evident. I'm sure you'll agree with me. Did we make up this law of nutrition? Not open to other interpretations. We don't invent them. That is what principles are. And if we're looking at these disciplines, you can see here a long list of principles. Think about the first one relating to responsibility, choice, accountability, initiative. All principles I'm going to take, it is that particular first line that hopefully I'll build on the next case to demonstrate where paradigms are, how we see things, how we do things accordingly, and how we get our results. The first real aspect relates to proactivity, being proactive. The second line talks about having clarity about where we want to go, a vision and a commitment and a purpose that we're going towards things. The third relates to putting priorities, putting first things first. You might have heard about the 7 Habits of Highly Effective People by Stephen Covey. These are the concepts, by and large, the principles that has been working on. And these first 3 principles are related to our individual, what he, Stephen Covey, calls them private victory. Moving on to, if we want to start going into, I talked about individual, teams, organizations. Going into teams, we really talk about mutuality, trying to have a mutual benefit, a win-win, a mindset, thinking of win-win, I win, you win. Moving to the next, to apply this, the behavior relates to creativity, perhaps more mutual understanding, courage, communication, the central of it. And then the synergy element of coming up with some creative ideas, not your way, not my way, not halfway, but really come together with a completely creative, different way to try and see how we can make things a bit better and different. And the last element really relates to principles of effectiveness relating to our individual renewal, the mind, body, heart, and spirit. And I'll come and show this later on as our discussion for organizational. How do we see things? A common paradigm as an example, this is just the way things are. There's not much I can do about it. That's a standard way of perhaps thinking that I'm sure you can expect the effectiveness that will come out of these. If you want to be genuinely proactive, have choice as the heart of it, you will talk about freedom to choose and the ultimate responsibility for my happiness. And if you think about a stimulus and a response, any stimulus is a response. That's Newton's third law. For every action, there is an equal and opposite reaction. And in that gap between these 2 aspects, stimulus and the response, lies our genuine happiness. I'll come to talk about this mind, body, heart, and spirit at the end, but I'd really like you to see these human endowments, human gifts that were only uniquely given to us as humans, talking about our mind, the self-awareness, talking about the imagination, I beg your pardon, it's relating to our mind, the spirit, talking about our self-awareness, and then understanding what is right and wrong with our heart, and the elements that relate to an independent will. I'll move on because of time. We have seen one aspect of seeing things, and here it is, the stimulus and the response again. The practices. The first talks about reactive moods. You have seen the gap, and what we feel we need to change this is how we really pause and respond based on principles and what we want to have as desired results. The second line talks about blame, accuse, and use the victim language. Language is important. The language we use is so crucial. It's nothing to do, nothing we can do. Just the way I am, it makes me mad. Have to, can't, must, all these phraseology. See how we can perhaps, using proactive language, talking about, let's talk about alternatives. I can choose different approaches. I can do. I choose a better response. Choose, choice, preference. And you can see the language just changing, how it can see it will give us a different result. The third line talks about aspects that are about circle of influence and a circle of control. How much can we influence? Where do we put our focus? Usually, we are all concerned about the weather. We're all concerned about outside world. How much can we do? If we concentrate on things that we can influence, we can expand and we can shrink that space and increase our circle of influence. And the last one really talks about being a positive transition person. For organizations, the way you behave perhaps makes people think, what do you want them to be? They can quit. They don't like the organization. They move on. You can see they can be willing compliance, happy just to move on, get the money at the end of the month. But As you go up north of that particular line, you can start seeing the cheerful cooperation, the excitement about what's happening, heartful commitment, and creative excitement. This is what, hopefully, as organizations, we would love to see our thoughts and processes going. The coming few slides are going to be talking about organizations on the wider level, and that's where, hopefully, you'll start seeing the essence of leadership. I would challenge you that every organization, regardless of how much resources it has, there is going to be this element of persistent chronic issues. If you want to lead, think of what these issues are. At the heart of it is low trust. And the other aspects are very obvious to ourselves. I'm sure I'm going to share with you a roadmap in the coming 4 slides that really takes about all these elements of how we use our mind, our body, our heart, and the spirit. And you will see these are exactly the parameters that I have just used earlier on in defining the principles. The first, from a leader of essence of pathfinding, is the use of our mind. You can see 2 concepts here. One really thinking about, as long as people have a clear job description, they will be fine. Good enough, but a better way, if there is a clear and compelling vision that exists, you're going to find that people will volunteer their best efforts. Here is a thought process. If there is a tools for it, have clarity about what is the job to be done. Element of money is important, even if it's charity, even non-government organizations. A business acumen, where is the money going to come from? And then link it to everything that you want to do to a strategic perspective. On the body level, how we align systems. Everything depends on me as a leader. Think about a proper leader, effective leader, thinking about ensuring success is in creating systems. And here on the right-hand side, you can see the behaviors, the disciplines that relate to aspects of how to have a clarity about focusing on a widely important goal, acting on the lead, not the lag measures, and then really keeping a compelling scoreboard, and then creating a cadence of accountability. 2 more slides. Talking about the heart. Here, the essence of leadership is empowerment of people. I need to constantly motivate people. That might be a mindset, but think of a more effective mindset. My job is to release the talent and passion of the people that I work with. And here it is. You found your voice, the intersecting element of the need, the passion, the talent, and the conscience. Founding yours, it's your time to help others to find their voice and see what legacy they want to really impact and leave on to the next. The last spirit is about our spirit, and that is the crux. That's where we started. If you remember, I talked about the character and the personality. The character and the competence are the central element of credibility and trust. I get things done because I'm the boss. That's the formal authority. Think about a more effective way of really being a leader that says, I get things done through personal influence and credibility. That is more informal, but perhaps has a higher moral authority. Dear colleagues, in closing, I want to remind you that leadership is not about titles. It's not about status. It's not about the rank. It's not about the office that we hold. Leadership is a choice, and each and every one of us can have that choice to lead or otherwise. I hope I have given you some food for thought. As I leave here, I hope you leave not just as attendees of this meeting, but as champions of change, equipped to transform our perceptions, our actions, and ultimately our outcomes. Thank you very much for your attention and dedication.
Hello. I think it was a wonderful lecture on leadership by Professor Hani FOGSI, who has been the Vice President of RCOG. And we have a lot of things to learn from them in the West. And surely we can exchange our viewpoints and ideas and evolve a better leadership in the future. Dr. Nandita, would you like to say?
No, I think Dr. Hani really stressed on the leadership qualities that are required, and we're having a beautiful program of FIGO with FOGSI and with other countries where it's a LDI program, leadership development, and I think that's very, very important for the progress and for the doctors to understand how it is, what is communication, and not only help with, you know, in delivering lectures or anything, but also communication with the patient. It really helps. And so I think it's fantastic. Thank you, Hani, for a wonderful lecture. Thank you very much.
I agree. We have this LDI reach, which is there for long. I think it was initiated during Professor Jean Connery, who was the president of FIGO during her time, and Hani also was a part of the group that brought the LDI reach program. And India is one of the important part. We both, me, Dr. Nandita, Dr. Rishma, we all are in the LDI reach program, which has been funded by the Gates Foundation, and it's really helped in building new leaders for the future. So thank you, Hani, and we'll now close this session and get on with the next one.
Yeah, session continues. Can you give the next speakers? Yeah.
Right, so we just like to acknowledge that we also have Dr. Ajay Bharadwaj online, and we also have Dr. Hema Divakar online with us. Pleasure having you here.
Hema, hi.
Hey, back again.
Ajay.
Hello, Ajay.
Good morning, good afternoon. I don't know where you are.
No, it's good morning. Good morning. Hi, Hema.
Hi,
Hi, Rishikesh. Yeah. Hi, Nandita. Good to see you. Yeah.
Hema, can you introduce him?
It's very difficult for me to introduce Dr. Ajay Bharadwaj because it's been an association of over 3 decades, and we both have seen various avatars of each other, so to say, from our infancy to the mature stage where we have reached in the initiatives that we have taken for FOGSI in collaboration with other international organizations and other NGOs. Ajay has been an exceptional support because of the trust that he has in FOGSI and FOGSians, which is the most crucial binding factor for us to move ahead. He recognizes that we are all busy practitioners, we have our limitations, but then he's there to lean on as a rescue factor, may it be any project that we would take up. He's the founding board member of the South Asian Leadership Public Health Institute, Avni Health Foundation, board member of the HISP India, that is Health Information Systems Program, technical advisory board member for accreditation of private nursing homes and maternity homes, a member and technical resource group for oral health and HIV/AIDS in India. NHS is the institute, and he is qualified as a pharmaceutical industry professional for more than 10 years. Leadership is something that is automatic or spontaneous for Ajay, and he's a great one for creating more leaders. So let's hear from Ajay, his views on the collaborative approach for the initiative which FIGO and Gates Foundation are leading with multiple countries in the LDI, or the Leadership Development Initiative, and the Ampli PPH project, of which, of course, as Dr. Rishikesh mentioned, he and Nandita are an integral part. It's all about implementation and outcome, which will bring about the impact. Let's see Ajay take us through our own journey in this initiative. Ajay, please.
Thank you so much, Hema. It's absolutely wonderful to be here.
Yeah, Ajay will be available to us for the Q&A post his deliberation. So can we have Ajay stop, please?
So we're going to play a video, and meanwhile, to all the audience from all over the world, if you have any questions for Dr. Ajay after his talk, please do not hesitate to put your questions on the Q&A.
Hello.
And can we have his video?
Yes.
It's an absolute delight and pleasure to be here speaking to you online. So therefore, good morning, good afternoon, and good evening for all the colleagues who are in various parts of the world and listening in. I'm going to essentially talk about 2 projects. One is the LDI Reach Initiative, and the second one is Ampli PPHI project. Both of these projects are from, of FIGO, and being implemented here in the country by FOGSI, which is the lead organization. But before I begin, I must really thank Professor Rishikesh Pai for inviting me and for this special occasion, and under whose leadership this entire program is being conducted, which is called the International Summit for Women's Health and Rights. It's interesting because Rishikesh has been kind of the key person who has been leading similar initiatives for last several years, and this is one of them on which I'm going to talk about. So LDI initiative is a FIGO project funded by the Gates Foundation. It's being held in countries like India, Bangladesh, Ethiopia, Kenya, Nigeria, and Pakistan. It's a 4-year project where Rishikesh is the project head. Myself and Dr. Madhuri Patel are the core national team members. And we have 4 key centers, 2 in Uttar Pradesh and 2 in Bihar, who are conducting this program. And we do have 50 leaders from within FOGSI who are kind of taking the entire project forward in every sphere of their interaction with the individuals in various societies. The aim essentially is to strengthen the leadership skills of the society and its members, adoption of maternal and newborn interventions, and bringing in some kind of gender transformative approach to champion women's in leadership. But more importantly, I also like to stress upon the addressing of the barriers aspect to it, because when you're implementing programs and initiatives, there are several barriers that facilities face, and identifying these barriers and also providing solutions for these barriers is how we can make a program successful, not just in the pilot phase, but also when you try to scale it up. So we are anticipating all those challenges and providing solutions for it. The clinical focus for this particular program was on 2 areas. One was the providing hematinic agents for anemia, especially with a focus on IV iron. The second one was related to the emotive implementation, that particular trial for PPH. We have made tremendous amount of progress since the project was launched in 2023. We have created about 50 leaders across the country. We have completed the barriers assessment, phase 1, phase 2, phase 3, phase 4, and phase 5, and we have identified several of them and have overcome most of them. We have prepared a evidence-based curriculum. Now, this was done specifically with various technical teams getting together and making this curriculum so that everything that we deliver is uniform, and everyone who talks about this project and the technical aspects related to anemia and PPH speak the same language, because that was very critical. We do have data collecting tools and the reporting formats. The reporting formats capture a lot of data related to anemia and the PPH and how the 4 centers are performing. And this data is kind of shared every month with FIGO, and a complete analysis is done of the same to see where we are and how we are progressing. I'll talk about the data in a bit in the next couple of slides. We did complete the Leadership Empowerment Series training program, and there was a gender training and orientation was also completed related to this. Advocacy for this project and the work that we have been doing has been going on full swing. Almost about 5 national, international conferences is where we have participated and showcased what we have done for the project and how we have progressed. So this includes the Femtech 4 and 5, the All India Congress of OBGYN, which attracts anywhere between 8 to 15,000 people, was completed in 2024 and 2025. And we did have the South to South conclave in 2025. We have built a lot of salience related to the initiative on emotive trial and PPH itself. Almost about 92 programs on these 2 as well as anemia have been conducted, which includes training programs for various OBGYNs and the nursing staffs and participation in conferences. Almost about 8,000 plus people have been reached through this program. We have established a partnership with the State Health Society and UNICEF Bihar. And in this particular program, Dr. Alka Pandey, who is one of the center leads, has taken personal initiative in reaching out to various district hospitals and the headquarters of those districts and trained the various staffs over there. We do have a ready reckoner which has been created, which includes a poster and a flip chart. This poster is available to everyone within FOGSI and worldwide through the FOGSI website called FOGSI.org. And there's an icon on the home page itself. It talks about LDI reach. Once you click on it, you will have access to the poster and the presentation, PowerPoint presentation, and you can download this poster, which talks about the escalation chart, and it also talks about the protocols which are necessary to be put in place related to the PPH management itself. Talking about data, because at the end of it, where are we? I mean, basically, where did we start and where are we as far as the program is concerned and how the 4 centers are faring? In all, Dr. Alka Pandey, Dr. Vinita Singh, Dr. Uma Jaiswal, and Dr. Neera Agrawal are the 4 center leads who have taken the project forward in their centers and implementing everything related to the project as is defined within the tenets of what we need to do. Almost about 5,500 deliveries have been attended. We have identified about 344 cases of PPH anemia, about 1,200 deaths due to PPH were about 2, neonatal deaths with due to PPH were about 5, and we did have near miss cases of about 16. It's interesting to point out the chart over here. The first part of the chart shows when we began the project, and if you see in terms of the implementation of the project itself, most of these 4 facilities, you see, they were at 0%, 0%, 25%, and 0%. So they were at the bottom of the entire chart in terms of its overall implementation. And as you see, quarter by quarter, the implementation has improved dramatically to the last quarter that we saw, that almost 3 centers out of the 4 are at 100% in terms of implementation of every step that is required to be fulfilled in order to make sure the PPH management for the women who are coming in for treatment in their respective facilities are indeed taken care of. One facility is not at 100%, and this is a very large facility. It's a public facility with almost 350 to 500 deliveries per month. So we are working very closely with this particular facility to see that they are in the highs of 80s to begin with and eventually come to about 100%. So that's where we are with these 4 facilities. And this is a very interesting slide that we talked about and shared with all of you all. With that, I would like to move on to the second project, which is related to it's called the Ampli PPHI, accelerating measurable progress and leveraging investment for PPH impact. Now here the team lead is Dr. Professor Nandita Palshetkar and myself, who are implementing this project along with several team members in India. Who are essentially FOGSI members, who are taking the torch and the light forward in various societies across the country. And now, what is this project and why this project has come about? This kind of chart defines the entire need for such a project, especially in a developing country like India and several other South Asian countries as well. When we look at the data itself, we talk about 810, women die during pregnancy and childbirth related causes every day, and of which almost about 87% are almost in sub-Saharan Africa and South Asia. Now, if usual progress continues the way it is at this point in time, in the chart on the right hand side, you'll see the top line is if it continues as usual, we are not going to meet this SDG 2030 goal. But however, if we add another 5.4 percentage points to the entire initiative, we see the middle line, which definitely has a fall there, but it's definitely not going to reach the SDG 30. So if all countries have to meet the SDG goal of maternal mortality ratio of less than or equal to 70, the yellow line is where we need to be, and therefore the steps need to be taken now and continuously to make sure it actually happens for the women of the world and women of our country in India. When we look at the PPH in the region itself, there is a definite linkage between anemia and PPH itself. The chart on the left talks about the anemia cases in India, Pakistan, Nepal, Sri Lanka, and Bangladesh. And on the chart on the right talks about the percentage contribution to MMR due to PPH. MMR essentially is maternal mortality ratio. So you see, all of them are high numbers in terms of numbers itself and in terms of percentage itself. So, and there is on an average, PPH contributes about 36% of all maternal deaths in the region. So which is pretty high, pretty scary, and pretty something which is a cause of concern, and therefore urgent steps need to be taken and continue to be taken to make sure we alleviate this particular issue. When we talk of postpartum hemorrhage, we have established that it's a leading cause worldwide, yes. And we do have a challenge in terms of, where we are and where we need to go. And when we look at, India itself, we do have tremendous amount of progress over here. Government of India, Ministry of Health and Family Welfare has done tremendous amount of work across the country to make sure it actually happens, and we have seen tremendous amount of improvement, thanks to the efforts put in by Government of India and the various facilities across the country. But a lot still needs to be done, because we're talking about 25 million births a year. MMR 93 per 100,000 live births, which actually has gone down as per the latest SRS data, which is like 93 per 100,000 live births, and translating into about 25,000 maternal deaths per year. So which is significant. And when you ask you and me what's a maternal death you want in your family, the answer would be 0. So therefore, why should these 25,000 maternal deaths also take place in our country? And Ampli PPHI is an initiative which is contributing towards making sure we are able to, bring about a change and add to the reduction of MMR in our country. So Ampli PPHI is a project funded by UnitAid. Project partners include JPIGO, FIGO, FOGSI, which is a lead organization implementing it in India, and PATH. Project countries include India, the DRC, Guinea, Kenya, Nigeria, and Zambia. We have exchange learning states of Uttar Pradesh, Bihar, Assam, Chhattisgarh, and Odisha. And we have, as part of this entire consortium, learning exchange countries of Nepal, Sri Lanka, and Bangladesh, where we are interacting with them and making sure, we are, giving them all the support that they need as and when required, including the technical as well as, other findings that we are having while implementing the program here in India. The goal is to catalyze early adoption and scale up of new and recently recommended drugs to prevent or treat PPH in high burden states and countries as part of an integrated package for PPH. Here, the focus is on 3 drugs. The first drug is heat stable carbetocin. So while we do know, and oxytocin is utilized everywhere, but it does come with a set of its own challenges in terms of its storage. Therefore, a beautiful option, a fantastic option is in HSC, the heat stable carbetocin, which is what we are trying to promote. Tranexamic acid is another one, and misoprostol, where we are looking at seeing how we can, communitize it and, make it available through, the community healthcare workers for women for self-administration. What we have done so far is actually quite a lot. We do have tremendous amount of advocacy efforts which were carried out at the AICOG, the All India Congress of OBGYN, in 2022 and through to 2025. Everywhere we've done it. We hosted and conducted an exchange country hub meeting, which included Nepal, Sri Lanka, and Bangladesh, and of course, the entire leadership team from India. We have participated in about 40 meetings, training, conferences at the state and society level as well, and reached almost about 3,000 plus fellow OBGYNs and paramedics whose capacities have been built related to these three drugs, and particularly a focus on PPH itself. We have participated in the FOGSI SAFOG conference and the FOGSI FIGO GUCOG conference as well. Here are a few glimpses of those very events that we have participated in. The 14th SAFOG conference where we had, so we have the entire leadership team there talking about it, and also giving a kind of picture perfect scenario for us. There we have on the left hand side our leader Nandita, who's talking at the AICOG in 2024 advocating for these three drugs. On the right hand corner we have our participation in AICOG 2025 led by none other than FIGO. Dr. Parag Bhambre is there, and the entire team, including Unit Aid and Gates Foundation, is present on the dais where we addressed a panel and addressed various questions from the audience as well as the panel lead. We continue with our efforts. We have the learning resource package which was developed and released, which is a standardized LRP. We do have 2 job aids on HSC and TXA, which were released. District level workshops were conducted, co-investigator workshops were conducted, and importantly, the data collectors play a critical role in this entire program, so their training was also conducted. We did have a stakeholders consultation on improving the access to drug, because that is another thing. You may have the drug, but you may not have access to it. So what are the barriers for it, and how we are going to improve and change that, overcome those barriers are some things that we talked about. So with that, thank you very much for your patient hearing, and I will be happy to take on any questions that you may have related to both these projects. Thank you very much.
That was really very insightful. Yeah, Hema, your view.
Yeah, thank you so much, Ajay. I just wanted to pose one question. Since you're leading the initiative in multiple countries, which you mentioned, what is the major difference that you find in execution of the project? What are the barriers? What are the challenges? Because we presume that South Asian countries all are almost similar, are we ahead of the curve when compared to others, or how is it going in a healthy comparative way in various countries? Any comments?
In fact, thank you very much, Hema, for this question. And it's an interesting one, because what we have seen is you have across the countries, in terms of, when you look at a common line drawing across the countries, you have fantastic set of people, extremely dedicated and committed to what they need to do and what they are planning to do and how they are going about doing it. They are well planned in terms of the overall implementation, and they are basically at it. And so is India. Okay. Having said that, one of the key things which is coming out as a barrier, so would I say, is that when approval of these drugs at the ministry level or at the country level and making them available. I think that's where the gap is, and that's where a couple of agencies are working to make sure, including the various societies who are in those countries, are working toward making sure they are able to navigate that space, advocate for the availability of those drugs, and making it available. So the science is there, the evidence is there across the country. It's just that little bit bridge, and few of the countries have already crossed it. So out of the 3 drugs, 2 are available, or 1 is available. And I must also say about few other countries that what they have been able to do, particularly for the emotive trial and the assessment of the quantitative loss of blood loss as against the visual estimation, which was the common prevalent thing across various deliveries, is that while DRAPE has been recommended as per emotive trial with the clear measurement, clear markings and everything, few of the countries have done fantastic innovations. Some of the countries have used a plastic bag, clear plastic bag, with physically marking everything down. Somebody religiously sitting down in that OT and marking down those plastic bags for multiple uses. And our own country, apart from using the V-drape, we have innovative with a tray, which has got a marking of 500 ml and excess blood going to the second compartment, which makes it, to the 1,000. So that's another second innovation. The third one is, people using the Macintosh, drape itself and kind of funneling it into a bucket, those white buckets with a marking over there, which can, be reused after wash, and you're able to clearly judge what is the quantitative and objective assessment of blood. So yes, we are in a very good space to answer that question, Emma.
Excellent.
And most of the countries are leveling up, and we are seeing a change, and we should continue seeing this change as we go forward.
Excellent. I think these innovations in itself could be shared between the countries. That's the first point. And secondly, it's all about leadership and influencing the policy and also the supply chain and the availability, as you've said. Nandita may have got some questions from the audience on her mobile, but meanwhile, when she looks at that, I just have one quick question about what has been the influencing factor for availability of heat-stable carbetocin in the public sector. Will this initiative be able to influence our government to make that available at a reasonable cost, affordable cost in the public sector, or because there are many, many states in the country who need the heat stability? So it is one of the very crucial steps for the potency of whatever we are giving to contain the PPH. So where are we regarding that, especially in India?
Okay, yet another question, and a very thoughtful one at that, Hema. And now, the first aspect is that we are in a very good space. Why? Because the HSC has been approved and is available across the country, and which means that the private sector is already using it.
Right.
Okay. And government sector doctors are also using it. However, it is not available within the system. So one would prescribe it if need be and make it available. Okay. Now, advocacy work on the front related to making it available through either the essential medicine list or having a GR across, various at the national level or at the state level, that process is going on.
And the dual pricing, Ajay, the dual pricing.
And the pricing. And the pricing is the biggest factor in all of this, where it is not. The advocacy work is going on not just in terms of why HSC is better or than oxytocin and thereof, but the second aspect is also that to back it all up with the India specific data, building that. So internationally data is there, but how it works. One needs to have that data available in the country for the country to be able to advocate that much more powerfully with the government. And thirdly, related to the cost part, the average daily lives saved for utilization of HSC vis-a-vis oxytocin, I think that's where one needs to look at the cost effectiveness of this entire aspect, and not look at a per unit cost, but look at the cost in terms of the overall impact in terms of life saved. So that is the angle, or that is the platform that we are kind of building on, and continuously engaging with the government. So we are a bit far off with the government itself in terms of them making it, approving it, and making it available across government facilities. But I do know states like Maharashtra, Tamil Nadu, and Karnataka are already at it in terms of kind of bringing it out there, and work is already happening. So we are hopeful that it will all actually pan out and come out very nice. Thank you, Hema.
Yeah, great. Nandita?
I think that was really good. In fact, Hema, the other learning that has come out of it is, the women are being given misoprostol, who are the ones who have planned on a delivery at home because they are far away from, the hospital. Now, out of those women also, 50% of them who were distributed misoprostol did, institutional delivery. So I think we are looking at even the collateral learnings from this project. And I think that's wonderful. The PPH Ampli has given us a lot of learning, and we are publishing all this data. So as Ajay said, the data is homegrown, and that is why it's so valuable. So thank you, Ajay. Thank you, Hema. I think it was a wonderful.
Thanks, Ajay. And for our Nandita, for our Manyata leader, Dr. Rishikesh Pai, we must tell him that because the private sector is using carbetocin already, there could be a lot of data from our private Manyata centers to gather and in a defined protocol, and that could be then brought to the table for the public sector to make this available, and we can always negotiate the costs in the shortest possible time. So Rishikesh, that is on our agenda.
There are a lot of interaction. We have the Manyata program going on. We have the two programs which Ajay's foundation, Avani, is tackling for us, the Ampli PPH, the Elder Reach program. Now we have the newer Gates Foundation supported FOGSI program, Aduna. Then we have the Sampurna, which is the SIP Foundation. So all are connected, and that's what it is all about. We have to ultimately connect all the dots and see to it that we bring the MMR down, which is already down. I'm sure that as India becomes more developed, and that's the same story with all the countries in the world, the LMIC, the Western countries have already reached that goal, and the other countries are also catching up quite well. And I think our organization, especially the FIGO, I feel it's well positioned with this all 139 countries. If we collectively work, I always feel that implementation is what is necessary now. We have the ideas, we have the protocols, we have the goals. Now let's get down to actually implementing it, which we have done in India. We have achieved a lot, and maybe that learning we can give to our other brothers and sisters across the continents, all the South, as well as many of the Eastern European countries and all. They also have similar problems which we face, because it's all dependent on economic development also. We are all evolving nations, and as we evolve, we are going to achieve our goals of a decrease in maternal mortality. So I think thanks for, because some of the giants are there in this, at the twilight of our session today, we have Dr. Hema Divakar, Mr. Ajay Devardhan, who is also a giant in this field. Nandita is there, and we have a junior in the form of Tanya, also one of our fellows, who is learning from us in imbibing. And we have 3,700 people are registered, and 1,900, I don't know how many are there online at present. Our Dr. Shantanu, also one of the young Turks, is there in the audience. And so we are getting there, and we are looking forward to meeting all of you in Cape Town, where we will have fellowship, interaction, learning, learning from each other, and interacting, getting new ideas, So it's a exciting life ahead for all of us.
And Rishikesh, this session is actually running ahead of time. And it speaks volumes of us being ahead of time in a sense. And with your philosophy of integration, which you have always believed in, and inclusiveness, which also is your very strong point. And that's how we've got us all together in this mega webinar. And we really, really appreciate and hope that we will be able to do a lot more to the world at large. Thank you.
Yeah, in
Thank you,
fact,
Ajay.
Both of you.
yeah.
And so we'll have the last now talk. We are, inviting Professor Frank Lewin, who is going to be our next FIGO president, and he will be giving us a talk. Nandita, can you introduce Frank? Because can you put on
Yeah,
a...
thank you so much. Yeah.
Thank you, Ajay.
It's really a pleasure to introduce Frank Lewin. Frank is a friend of all of ours, and we're always happy to hear him talk. And he's the FIGO president now, incoming FIGO president. He's a professor and head of division, University of Frankfurt, Maine, University Hospital. Oh, I think Pradnya, can I go closer and read it? Yeah, sure. Yeah, I think that's what I'm going to do so that it's easier. Okay, he is academical, social, and other functions, German Society of Gynecology and Obstetrics, DGG executive board member. 2010 to 2022, he was the vice president. 2020 to 2022, he was the president of the European EBCOG and president November 2023, International Federation of Gynecology and Obstetric, FIGO president-elect. He is in October 2023, he was elected. Then Executive Council member from 2015 to 2021. He was the chairman of the Scientific Program Committee, FIGO World Congress of 2021, advisor of the ECAC Board, Quality Management of the Government of the Federal Republic of Germany, Planning Commission for Certification of Perinatal Centers, Medical Director, School of Midwifery, Frankfurt, Maine, Coordinator of Evidence-Based Medicine Guidelines. Wow. President and Honorary Membership, AOG, Ukraine 2022, Honorary Membership of SOG, Israel 2022, Active Fellow, AGOS, USA 2023, Fellow Honorary, FOGSI in India 2023, and Fellow Honorary RCPI Ireland 2023, and Fellow Honorary MOGS SI India. I think we really love him, and his work and his CV speaks for the commitment and his passion for women's health. Can we play the Rishikesh? Do you want to?
Frank is a very dynamic individual, and it will be an asset to the FIGO and women at large of the world. And I'm sure he will create a lot of impact, bring about change, and we have exciting times ahead of us, both for FIGO as well as women's health worldwide. So without much ado, I would like to request you to now play Professor Frank Lewin's presentation.
Modern approach in labor. And I doubt whether I will meet your expectation today. Because when you ask for modern approach, that obviously always includes new technique, new drugs, new protocols. So I don't want to talk about that. I really want to talk about a modern approach on labor. So I will not talk about breach today, but on that topic. And what we have to realize, if we are really honest, then I have doubts whether we as obstetricians, and I define myself as an obstetrician, whether we are actually doing a good job. If you just look to that graph, I choose Norway. Everyone knows Norway in Europe has an extremely low perinatal morbidity rate, an extremely low maternal mortality rate, an extremely low cesarean section rate. And although, if you just look at that graph here, and you observe just the last 2 decades, then you identify with this line, the induction of labor rate. And that induction of labor rate increased from 10% to more than 25% within 2 decades.
What is the result of that decision to induce at least a fourth of the whole population? A massive increase in postpartum hemorrhage, a little bit increase in vacuum and forceps. You don't reduce it, you increase that by somewhat like 30%. You have an increase in emergency cesareans. You have an increase in neonatal intensive care unit stays for the newborns. You have no change in elective cesareans. You have no change in APGAR scores. You have no change in fetal death. And you have no change in neonatal death. There is a problem. There is a real problem. What are we doing here? So we are increasing our induction rates from 10 to 25%. And that is a conservative country here when it comes to obstetrics. And we double the cesarean rate. And there is no positive but negative impacts on maternal morbidity. If you look a little bit closer in that paper to the impact of the pregnancy week, when you start induction of labor, then again you see no influence in the APGAR scores, neonatal intensive care unit, fetal death, neonatal death rates, but postpartum hemorrhage. That is F, that is there below on the right side. Realizing that with fantastic evidence-based guidelines, we call them evidence-based guidelines, relying on systematic reviews from all our member societies, having protocols for labor in low-risk patients, then maybe we have to rethink what we are doing. What we are doing actually is we are realizing, as I mentioned, with that approach, we are increasing the postpartum hemorrhage, and we want to avoid that, what you see here on the left side in these pictures. That is on the one side an increase in atonias. It is on the other side a massive increase in placenta accreta syndrome. That is a complete unknown disease. We had the first description of a placenta accreta in 1937. We are responsible for that disease. So we have to ask ourselves, what are we doing here? So the recommendation, for example, to have in a primigravid woman who decides never to have a child in the rest of her life, if she knows that well, to offer a cesarean should reflect the problem. To offer a woman in 39 weeks or in the beginning of 40th week in a primigravid, low-risk pregnancy, induction of labor, to reduce stillbirth rates should immediately give us an idea how we have to counsel that women right. Do we know whether birth will begin? How long will it take? Whether the mother or the child are ready? Think about NICU and PPH, what I mentioned, and what happens, at least in molecular and cell biology, to recognize pathology. Because we are talking about a physiological situation. Giving birth is physiological. There is no pathology. We need pathology to have an indication to do an intervention. And we are losing our field because women rely on midwives. And it is not the bad women, the midwife, who is opposing us as obstetricians. No, I completely understand women who are completely healthy, no signs of any fetal anomaly, completely healthy pregnancy, and then we start with increasing risks. We are increasing risks in healthy pregnancies. We ask for protocols. We don't recognize the estimated date any longer. We are relying on something what was published 70 years ago. And everyone knows the graph of Friedman published in the American Journal in 1954. And you're still relying on that? Really? Go to the so-called evidence in that paper. You believe that labor usually is 8 hours? Really? Do you think the women you're treating today are the same as 70 years ago in the United States? Is it true? Really? I mean, if you just look to obesity, that is the big theme in our world, actually. Obese women need more induction than underweight women because they quite often don't meet the due date, but they have still a cervical length of 3 centimeters when they are 10 days after the estimated date. Cervical ripening didn't happen. Do we ask that? Or do we just have a protocol to do something when these women arrive in our ward, labor wards? Do we have protocols for that? Or do we have an understanding what's happening in these cases? Why do have these women gestational diabetes or type 1 diabetes, type 2 diabetes? Why do these women don't ripen their cervix until the estimated date? I mean, that is the question. And then we can start with a modern approach in labor. Again, not about breach, but what is the fear of a woman today? That is pain, and that is pelvic floor and perineum damage, and that is prosecution for all of us. So pain, okay. Is labor painful? Oh yeah, that is written in our textbooks, right? That is the first sentence is, it's painful. But what is your experience in your labor wards? There is a group of women, they deliver within 3 or 4 hours, and they don't even ask for pain relief. Not because they don't have time for that, because they don't need it. And others just start with the first contraction, and it is so painful that they definitely need it, although there is no dilation in the cervix. So maybe we should restart again to understand what is physiological and what is pathophysiology. And that is what we have done when we were medical students. So actually, we in obstetrics, unfortunately, we are discussing, and still most of our patients are low-risk patients. We decided to influence, to search indications for interventions in these patients, although we are just in a physiological situation. So, giving birth, when is there pathology is a main question. When is there an indication for an intervention? We should ask ourselves whether we have an indication to do something. What are the consequences of our interventions? You have just seen that with the Norway data from the Norway survey. I have no conflict of interest, but nature and evolution, can we trust them more than our own knowledge, the evidence we ourselves produce? Do we not follow the findings of our studies published in our journals and textbooks and the statistically validated systematic reviews for the safety of our women given birth, also for our own safety? After all, we know how long a birth can last, how long, I mean, Friedman, 70 years ago, how long a pregnancy can last, and which molecules nature has mistakenly not sufficiently provided us within natural processes without pathology. So we have protocols to always, again and again, without any other indication, to give hormones like oxytocin. We have that in our protocols. We do that routinely in low-risk patients without pathology. We add on something, believing that we have an indication. Also, there is no pathology. So we know better because our knowledge has revealed this, right? Or maybe not. Or should we go back to our craft, understand nature when it comes to physiological process, such as birth, and understand where pathology begins, where interventions are indicated. So I really don't want you to leave now labor wards. I want you to rethink what we are doing. We need better trials. We need better research. We have to understand what is happening in physiology. We shouldn't immediately talk about drugs we had to administer to our women without any indication. So when we ask for reasons for cesareans, and here elective cesareans are excluded in that graph, and that is from 2011, published in Obstetrics and Gynecology in the Green Journal. So 1/3 of these emergency cesareans is related to labor arrest. Oh, what is nature doing here? I mean, 1/3 arrest of labor? Do you really think after hundreds of thousands of years evolution, there is 1/3 not stop of labor? Is that really your belief, or is there a human factor here? From us, a doctor factor, a iatrogenic factor. 17% malpresentation, that is not breach, that malpresentation. How come that in a cephalic presentation, the baby doesn't turn right? Although the pelvis of a woman is perfect for that, because they are lying in beds. Nature didn't recommend beds for giving birth. And you have seen that in the lectures when we talked about breech deliveries, the huge influence of the position of the mother in second stage and labor, and whether they are moving or not. We come back later to the movement in second stage. Non-reassuring fetal tracing. Oh, maybe the CTGs are wrong, because that is not related to anything what you measure later in these fetuses. Yes, sure, we have to detect, and fetal-maternal medicine is doing a great, great job. We have to detect those fetuses which are at risk. Then we have pathology, and then we have indication for interventions. That is fantastic. But not in a healthy baby with a normal perfusion, when everything is fine, everything what we know, everything what we have done is perfect. Then maybe something's wrong with our indication. So first stage, insufficient cervical ripening. Is there anyone in the room who can explain that to me? And how come that more and more women, and I told you, I just gave you the pictures, 2.5-fold higher rates in delivering after the estimated date, worldwide. How come? I mean, one generation, there is no genetic base for that. If a mutation in a population is implemented that needs, geneticists are telling us, 300 generations, not one generation. Women given birth today have the same genetics as their mothers and grandmothers. So what about this cervical ripening thing here? What is influencing the cervical ripening in our women today? Why do we have more and more women giving birth after the estimated date? Premature rupture of membranes at term. What is normal here and what is not? Is that really an indication for antibiotics? for induction of labor? Or could we find out why in a few cases it starts with premature rupture of membranes? Let's discuss that also in that oration, comes later. Hormonal imbalance, oxytocin. I mean, in most of the protocols, we administer oxytocin in first stage. You think that's right? Really? Do you remember the really good studies from physiology? 40 years ago, 30 years ago, 20 years ago, 10 years ago. Well, why do have women two different hormones for labor? Oxytocin and prostaglandins. Let's see. And specific psychological situations, extremely important, and we don't respect that in most of our units. I include myself. Because if you put a woman under stress, she is immediately releasing adrenaline, and that is the best tocolytic agent on earth. If you set a woman in fear with your behavior, with your thinking, with your counseling, with the lights in the room, with the people running in, you make sure that she will have an arrest of labor. And second stage, malpresentation, prolongation, arrest, maternal malposition, also a topic. So let's start with endocrinology. That was, I mean, today we are forgetting that, even in our medical faculties, in all our universities. It's a real problem to teach our colleagues today. I mean, those who are doing reproductive medicine, they are experts in endocrinology. They really know what they are talking about. But all the rest of in our profession, but how do we define our profession if we don't have any idea about endocrinology any longer? And endocrinology is crucial in obstetrics. It's crucial, but people are forgetting that. And you got Nobel Prizes for that. You see here those who received the Nobel Prize for oxytocin, for the detection of oxytocin and for the synthesis of oxytocin, for prostaglandins, and even for steroid hormones. That was Butenandt in the late 30s, who was the first to give us an idea about the structure of these steroids. So it was so important that those who detected these hormones received Nobel Prizes for that. And today we are forgetting that completely. We put it to the protocols, but how that works, why that works, and more important, why doesn't, for example, prostaglandins do their job in first stage in women with gestational diabetes? Maybe that is interesting. How does that start? Everyone knows that. So the fetus is the one in around 35, 36 weeks, giving signals to the mother, and these signals are hormones. And by the way, someone, Bloch, got the Nobel Prize for that. So giving the information that the baby is ready to be delivered in 4 weeks. So it takes 4 weeks for the placenta to produce enough prostaglandin receptors on the cervix. Because women don't have usually these prostaglandins on their cervix. And why do I know that? Because no woman on earth who is not pregnant will have a shortening of the cervix in her life or a dilation. Imagine, we, the gynecologists, would detect in every second woman not being pregnant a dilation of the cervix. What a nice information, a new disease. Open cervix, shortened cervix. We don't have that if the woman is not pregnant. But all of us are producing prostaglandins. Prostaglandin E2. Oh, that is a show later, right? With the light. So, yeah. First, the baby gives a signal to the mother that she should produce prostaglandin E2 and prostacyclin and PGF-alpha receptors on her cervix. Otherwise, there is no ripening. Otherwise, she will not deliver at the estimated date. And if there are no receptors, and at the estimated date, the placenta is producing a high amount of prostaglandin to find the receptors to do the job and there are no receptors, then something very usual is happening. These prostaglandins go to other receptors, and we will see what that means. So yes, we are talking about oxytocin, we are talking about prostaglandins, and for sure we are also talking about steroid hormones. So when do we detect in normal labor, without any help, without any intervention, at the estimated date, when do we detect oxytocin in plasma of the mother? Late in second stage, not early. And we have these graphs since 30 years, but we don't respect that. There is a reason why you, women giving birth, have two different hormones, the one for the first stage and the second for the second stage. And the prostaglandins, you can see that here, prostaglandins in amniotic fluid, that is in human, this is in use. In human beings, you, for the first time, have prostaglandins 2 days before the estimated date. And if you have rupture of membranes and you are ready, then you get contractions. And if you are not ready, if the uterus is not ready, and maybe also the baby is not ready, then you don't usually have contractions. So a typical advice from midwives is, if there are no contractions, then you should open the bladder. Well, that is a crazy idea, because if there are no prostaglandins in the amniotic fluid, because she is not ready to give birth, then you just increase complications without any contractions. So we have to understand the physiology, and we don't. What is that? Yeah, you want me to dance, right?
There's a light fluctuation going on in the region, not only in the whole region.
Yeah,
So
yeah.
just,
No, I enjoy that.
you can continue.
No problem, Rishi. So first, the first step is we have to detect receptor. Wouldn't it be a nice trial to relate the receptors in the cervix to the readiness of a woman to give birth, and also in the pathological situation of prematurity? Because we have so many patients with prematurity, but they don't deliver their children. So we have, again, protocols to treat them without good knowledge whether that will proceed to labor, yes or no. And we know the receptors, and we can detect that. And my strong belief is it should start. These prostaglandin receptors are at the membrane of the target cells, and you can easily detect these receptors, and there are a couple of really good studies reflecting on these topics.
Hello.
And I just brought it here. Anyone who is interested in these topics might go deeper down to the physiology of these receptors in the first stage of labor. But we all of us, since we were born, have also prostaglandin E2 receptors on the pain receptors, the nociceptor. You can activate a pain receptor with different molecules. One of these molecules is prostaglandin E2. So if you have all your receptors on your cervix and the placenta releases prostaglandins, and all these prostaglandins, you know, the prostaglandins have a very, very short half-life time, very short. We're talking about seconds. We are not talking about minutes or hours. So when it is released and it is on the prostaglandin receptors at the cervix, you don't have any more prostaglandin E2 for the nociceptors. If you have less receptors on the cervix, all these prostaglandins go to the nociceptors. So now remember what we have. 2 women, both on the estimated date. One woman comes in, both have contractions since, let's say, 1 hour. One of these women, she is obviously really breathing. She's not talking to you. She is just handling her contraction, but she's not crying. It is just a strong contraction. She is challenged by that. She really has to breathe, and you can see that. And we all know these situations. We wouldn't ask her for something. We just wait until that contraction is over. And immediately a midwife knows she will deliver within the next 2 hours. You don't have to examine her. You know that. The other women, also 1 hour, since 1 hour, she is crying again and again and again, all contractions. She can't stand, she can't sit, she can't walk. She is just crying. It's so painful. And the midwife knows she will deliver in 2 days. Not today, not in hours. We know these cases. We know them, but we don't react on that. We still believe in a Friedman curve 70 years ago, telling us that within an amount of hours, something has to happen, otherwise we have to administer a drug. Oxytocin, prostaglandins, whatever you want. Pain relief, whatever. So let's see all these different cases. One preemie comes in the delivery room on a due date with severe pain symptoms and regular contractions for 4 hours. Admission finding, the cervix is soft but 2 centimeters long and 1 centimeter dilated, and the fetal head is above the pelvic inlet. And that takes hours, maybe a day. Another one comes to the delivery unit. She has strong contractions since 1 hour. She is nearly fully dilated, just contractions since 1 hour. She can't, when there is a contraction, her husband has to hold her, or she has to hold herself. And when the contraction is over, she's smiling, saying, okay, that was really strong. And she will deliver immediately. Another first-time mother comes to the delivery room on a due date with severe pain symptoms, with regular contractions, premature rupture of membranes 1 hour ago, and the admission finding is cervical soft, 0.5 centimeter, 3 centimeters dilated. The head is still in the inlet of the pelvis. So she has a lot of prostaglandins in her amniotic fluid, so she is ready to give birth, and that just gave a push. And another one is in 30 weeks, and she has rupture of membranes and not even 1 contraction, because she's not ready. She is not ready. So why we could discuss why she has a rupture of membranes, and it is a little bit too short just always to say there might be an infection. Inflammation, yes, right. So premature rupture of membranes at term might lead to contractions or not. And that is not individualized by the women. It is just relying whether enough prostaglandins were produced by the placenta and the amniotic membranes, because also the amniotic membranes are producing the prostaglandins. And that is a fact. So when there is no contraction, she's not ready. She's not ready. You can start with induction of labor. Have fun for the next week. And all these topics are well described. Let's go back to this 30-year-old graph here. You can find it in textbook, not just only in the paper. And we have to recognize that the first stage is prostaglandin-based, and the second stage is oxytocin-based. And why is it so? I mean, if you have a high blood glucose, we just have 1 hormone. That is enough for us. If we don't have it, we die. Not today, because we can produce insulin and we can give it to the patient, but before it was detected, before it was synthesized, human beings died. So no replacement for insulin. Here we are in a delivery situation, and you have 2 hormones. That means you don't have a substitution. It means they have different effects, and we have to recognize it. And when you have too early oxytocin, you know that situation. You know it. Every one of us knows it from the time when we are in labor wards working. The woman comes in, and she's 4 centimeters dilated. Everything is perfect. And then an hour later, although she didn't need any pain relief, now she starts crying. And the head is pushing on the cervix, and the cervix is still 4 or 5 centimeters dilated. And nothing's happening anymore. she stays with 4 or 5 centimeters, and it is not soft any longer, but there is an edema on the cervix, and it becomes stronger, harder. You can feel that. If you are not very experienced, you might say, okay, let's give oxytocin, then maybe she will deliver faster. She won't. What is the midwife advice? Put her to a bath, to warm water. Why? Because warm water is reducing oxytocin release. So the oxytocin pushed too early the head on the just 4 centimeters dilated cervix. It's wrong to administer the wrong hormone in that situation. And the description, when you detect which hormone in labor, is also, that is more than 40 years old. A fantastic paper, and I brought it here. And they are saying there was a significant increase in plasma oxytocin levels from the time of initial visualization of the fetal head to the time of delivery of the head. These data support the view that maternal plasma oxytocin levels remain low during pregnancy until late in the second stage of labor. We produce problems in labor. We don't have the solution. You know the Ferguson reflex. Yeah, but the Ferguson reflex doesn't mean that you put pressure on a cervix what is 3 centimeters dilated. The Ferguson reflex reflects a situation in which a woman is fully dilated and the head pushes against the vaginal wall. We have to rethink what we learned when we were medical students. Oh, let's go a little bit deeper to research. Patients with poorly controlled diabetogenic metabolism have significantly less favorable cervical findings at the estimated date than patients without metabolic disorders. Well known. And that is our experience every day. Patients with poorly controlled diabetogenic metabolism have a significantly higher rate of secondary cesarean sections than patients without metabolic disorders. Patients with poorly controlled diabetogenic metabolism have a significantly higher need for epidural anesthesia than patients without metabolic disorders. Patients with obesity have significantly less favorable cervical findings at the estimated date than patients with normal or underweight. A significantly higher secondary cesarean rate and a significantly higher need for epidural anesthesia for vaginal birth. We all know that. So why don't we do research on that? Here we are now in a pathophysiological situation. We have an underlying disease. Well, what is the problem? What is the problem here? Is it the pancreas? Is it insulin? Or is it the blood glucose level? We should find that out. Patients with regular physiological activity have significantly more favorable cervical findings at the estimated date than patients without regular physiological activity, and a significantly lower need for epidural anesthesia during vaginal birth. Wow. I mean, now it comes to behavior before labor. Everything's published. And there is I love that publication. Unfortunately, a little bit forgotten. That was done by an Australian colleague from physiology, by Foden, and that paper again is around 40 years old. And what he found out is that related to blood glucose levels and related to nutrition, you have different amounts of prostaglandin production by the placenta. So now we come back to our population we are treating today. Because we have very different nutrition, not just only obesity rate, compared to our parents and grandparents. High blood glucose levels are usual finding. And you can do that. Today we have these patches, you can measure it on your mobile, you can see how you react on different nutrition. And we use it, we like it. All in my unit, all my midwives, all my doctors, all my colleagues, all my nurses tried that out to find out how they react on that. we have to realize that nutrition today is not as healthy as it should be. And it has a direct impact on the prostaglandin production after 36 weeks. So let us think about trials and how we can produce evidence, what we put to systematic reviews when we are discussing our interventions with good indications. So in use, fasting increases uterine contractility and leads to early birth of viable lambs in animals close to term. We have to realize that, and we don't. We still believe that we have to treat the patients related to the evidence we produced in our trials 50, 60, 70 years ago. There are fantastic reviews and systematic reviews also on the impact of second stage and the maternal position. And to make long things short, lying on the back is the worst decision you can make for the women. Because usually a woman feels better when she's walking around. Do we trust in nature? Or do we trust in our advice? I mean, I learned it when I was a medical student and when I was a young trainee. All the women were lying on the back, and we were trained to do episiotomies in all these patients because we believed that the Lord forgot to do an episiotomy in labor. We really believed that. Today, the episiotomy rate in my unit is below 1.2%, and we have the lowest laceration rate in whole Germany. But not just only because we don't do episiotomies, we also don't let them deliver lying on the back. And you know that from the talks about breech deliveries. And we have evidence on that. I really don't understand why we don't react on that. That is a fantastic systematic review. You see, Gupta was responsible for that, delivered in the Cochrane database. That is a fantastic systematic review. The evidence was quite low, but that is the problem of the trials. That is how they included the patients. So maybe you restart it again in your beautiful country to promote trials, randomized trials on this topic. And what you will see is faster second stage, less lacerations, better outcome of the babies, and better outcome of the mothers. And everything is written here. So we just have to reproduce and do better trials on these topics. So the author's conclusion in that systematic review in the Cochrane library on the position of the mother in second stage is, if she is in upright position, the result of this review suggests several potential benefits for upright posture in women without epidural anesthesia, such as reduction in the duration of second stage and reduction of perineal incision rates and assisted birth. Here they mention without anesthesia. Well, I mean, these trials were quite old. Today, the gold standard is that women with epidurals are mobilized. There is no reason that they shouldn't walk around, that they shouldn't have a walking epidural. And that is not another technique. That is just another concentration of the same drugs. So you can immediately implement it. We are struggling with that in Germany. I even don't understand why. Because there is no change for the anesthesiologist or for the obstetrician in that procedure. It is just different concentration of the drugs. We are very much interested in the impact of the position of the mother giving birth, at least in second stage. And that's why we use open MRIs actually with our pregnant women. And we try to find out, why is the pelvis of a mother mobile and what is changing in different positions. And what you immediately detect is that the angles are completely different in the pelvis, and also the wideness of the pelvis in the inlet and the outlet of the pelvis, if they are in upright position or if they are lying on a back or on the side. So there is an impact of your counseling, how she should deliver. and we should produce the evidence. As long as we don't do that, we won't have it in systematic reviews. As long as we don't have it in systematic reviews, we don't have it in our guidelines. But that doesn't mean that we follow the right evidence. So I know that I didn't meet your expectation on modern approach in labor, but I strongly believe that after this talk, you might reflect what you see in your labor wards and how we can improve labor in future to make sure that women again rely on us as obstetricians when it just comes in a healthy woman to labor. So thank you so much for attending this session.
Are our leaders present in Hall B? I think this talk, which was very eloquent and elaborate, has completely turned our heads around what we should be rethinking about. In fact, after the COVID era, the words such as rethink, reform, restructure, research, all of these have become very, very popular. And this is yet again another topic which inspires us to do the same, because we have been oftentimes blamed for over medicalization and also not adhering to the standard protocols. Perhaps by intuitive decisions, sometimes we differ or delay, and many a times iatrogenic premature labors, also the clinicians are to blame for their decision making. So this is a whole big Pandora's box of rethink, with Frank Lewin as our future leader of FIGO. I'm sure not only on this topic, but on many other existing practices, we will produce more evidences in keeping with the present era, and we move forward on a new path altogether. And forward movement, however slow, is the necessity, because, ladies and gentlemen, change is constant. With that, we bring the day one of the deliberations in Hall B to a close, and over to the Master of Ceremonies to do the concluding remarks and draw the curtains on this delightful day. And we will see you again tomorrow without fail, because there's more to come. Thank you.
Thank you, Dr. Madam. Thank you so much, ladies and gentlemen. So here we conclude with Hall B. I would like to thank all the chairpersons, especially all the speakers who have taken their valuable time and giving their important inputs. A lot of scientific talks we had. Especially, I like to take this time out and thank all of our viewers from all over the world. We have it in great numbers. Thank you for joining in from different time zones. That was an amazing side that we see a lot of people here. And yes, ladies and gentlemen, we are going to end the session here. We'll see you tomorrow at Indian IST time at 12:30. So please do log in. And as also been reminded by Dr. Pai, this is not going to be just a 2-day conference. If you want to listen to these talks even later, so it's going to be available with us for a long time. All right. So with these words, I'd like to conclude the event from Hall 2. Thank you so much for joining. And this is your time manager, Himai Lakhani, signing off. Thank you so much for joining us. Thank you.
Thank you. Thank you, Rajendra.
Thank you.
Thank you.